हाँ सर, आवाज आ रही है। हेलो। हेलो।
Check. Testing. Hello. Hello.
Check, check, hello, hello, check.
Check.
सुरेश आवाज आ रहा है? आवाज आ रहा है? बात कर।
हेलो सर, आवाज आ रही है?
हाँ, नहीं तेरा नहीं आ रहा।
हेलो 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 हेलो।
हेलो हेलो हेलो, मेरा आवाज आ रहा है?
हाँ, आपकी आ रही है सर, क्लियर।
हेलो 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 हेलो
हेलो
हेलो।
हेलो।
हाँ
सर आ
हेलो,
रही है?
मेरा नहीं, तेरा नहीं आ रहा।
आपकी आ रही है।
এই কালোটা কালোটা কালো ইপিটা। हेलो हेलो
हेलो।
हेलो।
हेलो सुरेश भाई।
हाँ सर।
সাউন্ড কাট দেনা, যা ইচ্ছে হয়ে যায়।
हेलो
না আসছে না। हेलो,
हेलो जी सर।
एक सेकंड रुक जा, एक सेकंड होल्ड कर।
सुरेश भाई।
आप हेलो, आ रही है दादा आपकी? हेलो, आ रही है? आप क्लियर आवाज मेरी आ रही है आपको?
हेलो
हाँ हेलो,
सुरेश भाई, तुम्हारी आवाज नहीं आ रही।
मेरी आ रही है
हेलो,
आपको?
नहीं आ रहा है, नहीं आ रहा है,
हेलो हेलो।
नहीं आ रहा।
सुरेश भाई
आ रही है ना क्लियर?
आ रही बोलो
आप-
बैकअप को कौन।
आपको भी आ रही है, आपकी भी आ रही है मुझे।
ये बोला वो बैकअप है ना, बैकअप को कौन बना देना।
बना रहा हूँ, बना दिया मैंने।
तुम्हारा तो बता दो।
हेलो जी सर।
ठीक है।
हाँ दादा। हेलो, हाँ जी बोल। हेलो। हाँ दादा, कौन से पाऊँ? छह छह का आलू का हुआ है? अभी तो आ रही थी। नहीं, अब नहीं आ रही, पहले आ रही थी। म्यूट म्यूट तो हटाओ, सारा म्यूट तो करा रखा है। ये और चीज तो सेवन है क्या? सेवन में चेक कर लो। 6 नंबर में आपका भी तो आ रही थी, 3 घंटे बाद मेरी। हाँ, ये 6 नंबर में आप बोलो, उसमें सारा कंप्लीट करा है। ऑडियो की नहीं आ रही। नहीं आ रही 6 में।
टेस्टिंग हेलो हेलो हेलो
आप
हेलो
नहीं आ
चेक
रही,
हेलो
ये क्या कर रही हो? हेलो 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 हेलो, चेक आगे लगा मेरी। हेलो,
अरे भाई,
हाँ
हाँ बोलो।
आ रही है क्लियर?
ये आ रही है।
अरे ये
हेलो
आप पीछे
चेक
में कौन से हॉल
चेक
में, पीछे
टेस्ट
में 6
हेलो
में बोल रहा
हेलो
है।
हेलो
पीता था 6
चेक
में था,
हेलो
वो चला
चेक
गया शायद 7 में।
साथ में बोलो ना यार, मैं चेक हुए बहुत में करवाना चाहिए।
चेक हेलो चेक
एक मिनट मैं पूछता
चलो चलो मैं
हूँ।
जा रहा हूँ।
वो सभी हो रहा
हेलो
है सब करता हूँ।
जीवन हाँ।
करता हूँ।
हेलो
पता है, आपको पता है।
हेलो हेलो
हाँ, पीटर दर 7 में है, 7 में है।
हेलो, हाँ आवाज आ रही है, आ रही है दादा, आ रही है, मेरी आ रही है आपको? ठीक है सिर्फ लेवन क्या आ रही है। हेलो 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 हेलो
हेलो चेक 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 हेलो हेलो चेक हेलो हेलो चेक हेलो चेक हेलो Hello. Check, 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 check. Hello. Hello, check, testing. Check, test. Hello. Hello. Hello, check. Hello. Check. Hello. Check. hello, hello, hello. Lanta. Check, check, check. Hello, hello. Check, check, check. Hello, check. Hello.
Hello.
Check, 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 check. Testing. Hello, hello, hello. Hello, 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 hello. Check, 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 check. Test, test. Wow, wow. Check, 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 check. Testing. Hello, hello. Check, test. Hello, hello, hello. Check. Hello, check, test. Hello.
Hello, 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 hello,
I'm
hello.
calling on Dr. Mahalan sir for his presentation.
Hello. Yeah. So very good morning. E-coach. Hello. Hello. এখান থেকে E-coach. এখান থেকে E-coach. Hello. Yeah. Just leave it. Let's leave it. Very good morning today in the fag end of the conference. I welcome you all. To start in the free paper session, we have 3 papers that will be demonstrated. We have Dr. Anil Kumar on his first paper of acute kidney injury. He'll present another paper. Dr. Anil, over to you. And as moderators, we have Dr. Rangan Kole in the Department of Cardiac Anesthesia, NSH, and Dr. Anisha from Department of Pediatric Cardiology, NSH. Over to you, Dr. Anil. 13 November to okay. AKI system.
So, very good morning. I'm Dr. Anil Kumar. I'm working as consultant pediatric cardiac intensivist at Sir Gangaram Hospital, New Delhi. Okay, so I'll be presenting 2 papers today, and my first paper is related to acute kidney injury after cardiac surgery in children and their management strategies. So as we know that acute kidney injury is a common concern after surgery in children, cardiac surgery in children. The prevalence of up to 33 in this group. But in neonates, it can go up to 2/3 of the patients. 2/3 of the patients in neonatal age group can have acute kidney injury. And many studies have documented a very high mortality of up to 90% in patients who require renal replacement therapy. We also see in our ICUs that newborn, borderline hemodynamics, bloated, swollen up baby with poor urine and PD not functioning. And this is a time when we can think that this patient is not going to survive. It's very difficult to manage. So on this background, we aim this study to determine the incidence of acute kidney injury and to find the risk factors for acute kidney injury after cardiac surgery in children. And in a subgroup of patients, we also try to find the accuracy of urinary NGAL, which is neutrophil gelatinase associated lipocalin, as a biomarker in early detection of acute kidney injury. So this was a prospective study, and with a duration of 2 years, and patient age group was 18 years. Patient who had pre-existing acute kidney injury and multiple organ dysfunction were excluded, and AKI was defined by pediatric rifle criteria. And in the subgroup of 102 patients, we also send a urinary NGAL at 0, 2, and 6 hours in the post-operative period. So coming on to the results, total of 309 patients were included in this study, and around 28% patients have acute kidney injury as defined by P-rifle criteria, and most of them have a stage 1 AKI, and only 4% have stage 3 AKI, and which is 4 patients. Around 5% of patients have stage 3 AKI. So if you see the incidence across various age groups, so I have made 2 age groups, less than 5 years and more than 5 years of age. So younger patients have higher incidence of AKI, and we can see that all of these stage 3 AKI belongs in this age group. So this is a significant finding. Similarly, if we see the distribution among various RACS category, so in smaller babies with a body surface area of less than 0.3 meters square, they have higher incidence of acute kidney injury. This can be explained by the fact that these patients had immature renal tubular system, which was hit by cardiopulmonary bypass. If we see the incidence across various RACS category, the category above 3 have higher incidence, which was significant association. And similarly, cardiopulmonary bypass of more than 90 minutes have higher incidence of acute kidney injury. This is also significant. So in this subgroup of 102 patients where NGAL was sent, so we found that urinary NGAL rose early, significantly early. The peak time of peak levels was around 2 to 6 hours, while the serum creatinine started rising after 6 hours, you can see here, and urine output initially increased and thereafter started declining. So this was also consistent with other studies also who have evaluated the role of urinary NGAL. So about the hospital stay, mean duration of ICU stay and hospital stay was significant, not significantly, but it was high in with children with AKI, and mortality was significantly associated with children with AKI, where there was total 7 mortality, and out of them 6 patients expired in this patient who had AKI. So 10 patients, 12% of this patient, AKI group required renal replacement therapy. 4 patients required renal replacement therapy because of their renal failure, stage 3 renal failure, and in 6 patients, 2 in stage 1 and 4 in stage 2 required early peritoneal dialysis for achieving the fluid balance and to stabilize the hemodynamic status. So a few points about the management studies. What we do in our center is we can categorize as preoperative, intraoperative, and postoperative phase. So in preoperative phase, we usually evaluate all children for non-cardiac structure anomaly. We usually do a ultrasound KUB in infants and in high-risk children. And although not backed up by the evidences, but as most centers, our center also use a pre-induction steroid to target post-surgery inflammation. During intraoperative period, in monitoring part, we usually use renal NIRS. As we can see in this image, we usually put a probe over here for renal fossa to monitor the renal perfusion during the intraoperative period, especially in children who is undergoing deep hypothermic circulatory arrest or where lower body perfusion is compromised relatively more. And apart from urine output monitoring, fluid and electrolyte management via hemofiltration during cardiopulmonary bypass is taken care of our perfusion team. In post-operative period, apart from monitoring of urine output, renal functions, and NIRS, we usually target the prevention and management of low cardiac output. So organ perfusion pressure should be maintained to prevent the acute kidney injury, and prevention of fluid overload. We limit intake in POD0 around 25% of maintenance only, and we never give diuretics in POD0. We start diuretics on POD day 1 usually after 18 hours after achievement of the hemodynamic stability. We usually put PD catheters in all newborns and higher X category patients. And early peritoneal dialysis have a special role in targeting fluid balance and hemodynamic stability. And definitely the avoidance of nephrotoxic drug should be there. So to conclude, the incidence in our cohort is around 28%. And the incidence of AKI was higher in smaller children, higher X category, and children with higher CPB time. And in our cohort, early detection of urinary NGAL, there was significant as compared to the levels of serum creatinine and urine output. Thank you. Questions? Yeah. Yeah. So the levels of NGAL rises early actually. This is the urinary levels.
So it has got a short shoot. I mean,
in very early, in 2 hours
yeah,
post-operatively.
in 2 hours time
Yeah.
post-operative, right?
Yeah, we only sent 3 samples up to 6 hours only. We didn't follow after that. So levels as compared to serum creatinine started rising after 6 hours. And urine output definitely on POD 0 reflects. But NGAL shows a sharp spike within 2 hours after surgery.
So you are advising to have an NGAL test done as early as possible. I mean, after 2 hours in the post-op period. Right?
Yes, this shows a significant association. Yes, sir. It can detect that these patients will land up into AKI. So we can implement early management strategies.
When you get a result, NGAL, we don't do it repeatedly.
Yeah, we don't do it.
That's what I'm asking.
Yeah, this was in the, it's a part of a study.
How much time do you take for an NGAL report to come?
NGAL, sir, this was a study part, so it came within I think 6 to 8 hours report came.
And if you have a patient undergoing cardiac surgery, say with a high RAC score, the institution of PD in OR should be routine, right?
Sorry?
Institution of PD catheter should be routine in the OR only. You are saying that you want to institute PD catheter in the post-op period, but you can institute the PD catheter in the
KCU.
Sorry,
So
no, in the OR only. You can institute a PD catheter.
Yeah, in the OT only, sir.
Sir, Patati, we are recently starting a study on correlation of IL-8 and with AKI. We very recent. I don't know. I cannot comment on it also. कुछ values आए नहीं है, but for future studies, NGAL तो we are.
NGAL तो है.
हाँ, अभी we are starting it. And definitely we put PD catheters in the OT itself.
Okay, Dr. Anil, last question. You will just comment on the usage of Lasix in these sick newborns or infant child group whom we are operating in the OR. Do they administer Lasix in the OR? I, being a cardiac anesthesiologist, we administer Lasix in the OR in 60% of time. 60%.
So we usually do muff in the OR.
You don't muff, right?
Yeah, we do.
We are muffing regularly.
We are muffing, so we are delaying diuretics.
You're doing only cough, right?
No, muff, cough also and muff also.
Okay.
And during the weaning from bypass, we take out usually, if hemodynamics allowed, around 100 ml per kg of fluid through muff.
Lasix is not used regularly in the OR. You want to mean,
no,
right?
no, definitely not.
And also in the post.
I'm from the OTT. So we regularly cough and muff regularly.
Yeah.
So our policy is, because child is so much dehydrated that day, we do not give Lasix till 18 hours. So the next day, when we think that the child is against signs of those fluid overload, then we start Lasix. But first 18 hours, they don't require. Actually, they need volume after that, because we take out so much in the OT.
It's a valid point. We'll try to implement in our setup. Like,
you give Lasix on the same day? Okay.
mostly after 8.
No, many units have different.
After 8 to 10 hours, normally you start Lasix infusion also. Dr. Shubhadeep is there. He starts like that. We'll see into it.
Yes.
Thanks.
Thank you, Dr. Anil. I'll request you to remain on stage for your next paper on NIV and fast tracking. Over to you.
Thank you very much. So my next paper is in the continuity of the discussions which has been going since last 2 days in relation to fast tracking early extubation, or you can say on-table extubation. So this was to evaluate the role of non-invasive ventilation in fast tracking cardiac surgical program. So we know that use of the non-invasive ventilation is increasing, not only in the pediatric ICUs as well as in the pediatric cardiac ICUs, with the incidence of more than 50%. And many studies has backed up with the evidence that NIV helps in the reduction of the extubation failure rates and decrease in VAP incidence rates. So this study was aimed, this was a prospective observational study in our department. The study duration was 1 year. And we observed and recorded the respiratory support profile of patients between 0 to 18 years of age. Patients who were in mechanical circulatory support were excluded. So we have an established criteria for extubation in OT. So after patient selection and ruling out all the core morbidities, we assess for stable hemodynamics. We see the satisfactory cardiac repair, intraoperative. After surgery, we do a routine OT echo, and we confirm that there should be no residual defect. And after that, we see for the stable perfusion markers, satisfactory respiratory parameters, optimal acid base and metabolic status. And we also wait for that there should be no active surgical bleeding. And after meeting all these criteria, we extubate the patient in OT only. And after extubation, we have set prerequisites for NIV, indication contraindications for NIV. And we never use NIV prophylactically. We have set criteria. These are usually standard criteria. So after clinical assessment and after assessment of the blood gases, we decide what mode of non-invasive ventilation should be used in that patient. Coming on to the results, there was total 144 patients with a male-female ratio of 0.5:1. And if you see the age group, there was 57 patients in less than 3 months of age group, 29 between 3 to 12 months of age group, and 58 in more than 12 months of age group. Around 52%, 74 out of 144 patients were extubated in the OT only. So this was including all of the age group, less than 3 months also. And patient who were in whom extubation was deferred, 1/3 of the patient was already intubated preoperatively because of the sickness level. So if we see the distribution of age and REX in the patient who are successfully extubated in the OR, in this REX category, we can see REX 1 and REX 3. So patient more than 3 months of age, most of them was extubated. And in an age group of more than 1 year, all of the patients were extubated in this 2 REX category. We have lesser number of patients in REX 4 and REX 5, so I cannot comment on that. And even in REX 3, 2/3 of patients of more than 12 months of age were extubated. So in patients in whom extubation was deferred, who are sent to ICU, if you see the median duration of mechanical ventilation. So one point we can see that higher the REX category and lesser the age, patient requires prolonged mechanical ventilation. And second point I want to make that as you can see in REX 1 and REX 2 category, this is the group where maximum patients were extubated in the OT. And in these patients who are not extubated, the median duration of mechanical ventilation is very less. We can see that 8 hours and 5 hours in REX category 1. So they are relatively stable patients. Most of them get extubated, but those who are not extubated also require lesser duration of mechanical ventilation. So after extubation, NIV was indicated in 56 patients, around 39% in this cohort. We use non-invasive positive pressure ventilation and heated, humidified, high flow nasal cannula. And CPAP plus PS was the commonest mode which we used. And we use 2 interfaces usually. Nasal pillow, as we can see in this image, is used in patients with less than 1 year of age. And in the older patients, we use oronasal mask. And we don't use this separate device for HFNC or separate circuit for HFNC because they are too costly. So what we use is kind of indigenous. We mix this air and oxygen through flow meters via this tube, and this tube is connected in this inspiratory limb of the ventilator circuit, and via this ventilator circuit it is connected to the nasal interface. So one benefit is that this circuit can be quickly switched over to NIV circuit. This is the one benefit with using this. So if you see the distribution in patient who was successfully extubated, 10% of patient required non-invasive ventilation when they were shifted in the ICU. 1 patient required non-invasive positive pressure ventilation, 5 HFNC, and 1 patient required transition from NIV to HFNC. Similarly, in DOR group, 70% of patients require non-invasive ventilation. So if we see the details of these patients who are extubated in the OT and require the non-invasive ventilation, we can see that the indication for ventilation was only respiratory issues, milder respiratory issues such as atelectasis, bronchospasm episodes, and milder kind of wetness of lungs. And we can see that even they are indication was there of non-invasive support. The duration for which non-invasive support was implemented was only around 1 day, only 24 hours. And we see that. So this is the group. This is the group in which we can say that use of non-invasive ventilation can help in this patient to avoid reintubation or extubation failure. So because these are relatively stable patients and they just non-invasive ventilation just helps in tiding over the transition period. So in patients who are not extubated in OT, who are shifted in ICU, the NIPP, the mean duration of non-invasive positive pressure ventilation, if you see the distribution among age and REX, you can see that in REX 1 and REX 2, the use of non-invasive positive pressure ventilation was longer as compared to other groups. So this is the group in which patients, most of the patients were extubated and they require lesser duration of mechanical ventilation in ICU, but they can be managed by non-invasive ventilation. Again, because they are relatively stable patients, so they can be managed by non-invasive ventilation. So thus avoiding the complication of mechanical ventilation in these age groups. Similarly, if you see the mean duration of high flow nasal cannula interface, it is usually distributed in a in all category and all age groups. And one finding which may not be significant, but in higher REX, the mean duration was higher of HFNC. So we can interpret it like that. Higher REX category patient require prolonged mechanical ventilation for a longer period of time. So this mode of non-invasive ventilation can help in weaning of these patients. So HFNC can, in this cohort, was seen as a tool for weaning of this group of patients. So if you talk about the duration, median duration of stays, overall median duration was 5 days. And as REX more than 3 and age less than 3 months, the median duration of ICU stay was significantly high. If we compare the median duration of ICU stay in SEOR and DOR group, it is also, there's a significant difference in duration of ICU stay. Coming on to the VAP incidence in this cohort, a patient with VAP has higher duration of mechanical ventilation and more than 4 days, and patient with no VAP usually have less than 48 hours of mechanical ventilation, and this is a significant association. So there was no patient who was reintubated in SEOR group. 4 patients were reintubated in DOR group in ICU. So reason was airway edema, unilateral cord, vocal cord palsy, NEC, and septic shock. And there was total 6 mortality in DOR group. There was no mortality in SEOR group. And the reason was sepsis with NEC, and other reason was low cardiac output syndrome. So to conclude, I can put it this way, like NIV prevents reintubation in fast track patients, just to tide over the transition period. And in infants less than 3 REX category was successfully managed on NIV after extubation in ICU. So this helps in reducing the duration of mechanical ventilation, thus complication associated with it. And patients who require prolonged mechanical ventilation, in this cohort, it was shown that NIV, like HFNC, helps in weaning of these patients. So this was our observation. Thank you. Questions?
What is the incidence of patients getting extubated in OR? I mean, you told there are 2 selected groups. We can defer, and the other group was selected for extubation in OR itself.
Yeah, deferred with those patients who are shifted in ICU.
ICU and to be extubated
extubated in the OR. So overall incidence, including all age group, was 52% of successful extubation in the OR.
What is the preferred mode of analgesia? Because you're extubating quite early for fast tracking. What is the preferred mode of analgesia?
So we usually dexmedetomidine. We usually use dexmedetomidine.
And do you use caudal analgesia?
No.
No, right. Okay. And Can you just show me the slide of nasal pillow? Because I haven't used it.
Image, sir?
Yeah, yeah. You already showed in that image.
First one. Sir.
Oh, we have used it actually. I didn't know it's called nasal pillow, right? Now you tell me this fast tracking and all these things, we are doing it for the betterment of the patient outcome.
Yes.
But what is your view on the really outcome change in WAP and in the length of ICU stay, whether it has caused that much of difference?
Yes, yes, definitely,
We
sir.
want to change the difference, I mean, the outcome, right?
Yes, sir. The significance of WAP is significantly reduced. WAP.
ICU stay has been also.
Yeah, ICU stay is also definitely because lesser complication associated with mechanical ventilation. The duration of stay is also reduced.
Okay, thanks.
It's a really nice study. I would like to ask you one question, like for the older kids, while on NIV, do you use any kind of sedation or?
Yes, sir. Not in every patients. The patients who don't tolerate NIV, who are very irritable on IV, we use milder kind of sedation. If we can manage an oral, something like pedigrolil, or sometimes we have to use dexmedetomidine in these patients also.
And when could you initiate feeds in these patients with NIV?
So these are awake patients. If there is no contraindication of initiate feed, we usually give feeds in these interfaces.
And yeah, in our institute also we use this kind of a circuit because it's very easy to switch over. And another thing, we also use the scuba mask so that the compliance is better that way.
Are you comfortable with this scuba mask as she's saying?
So we have never used that
scuba mask. It will cover the face,
whole face,
the holes. So what I have faced is good. Dr. Shubhadeep.
Dr. Shubhadeep was also.
But sometimes the patient, I mean, the awakeness status and all that things get masked due to the fogging inside, and suddenly we will have a bad EVG and the patient gets intubated. So this is a flip side. We have got a lot of good outcome in it, but this is also a flip side because the nurses will be handling all these patients. We will be giving advice, and maybe after some point of time we'll have to move on. So that's
definitely nursing contribution is an essential thing in managing these borderline patients.
Yes.
Borderline patients.
Okay, thank you very much.
Thank
Nice.
you. Thank you.
So now,
Protocol you were asking for
Sorry?
analgesia protocol.
yeah.
So I start Dexam just after induction at a dose of 0.5 mics per kilo per hour, and I switch it off half an hour before we plan to extubate the kid in the OT. And we give one shot of 15 milligram per kilo of paracetamol.
That's a good thing. I also do that.
Yeah. And then when we shift these patients, then Dr. Anil takes a call when to start Dexam again on those patients.
Thanks. Thank you, ma'am.
Thank you so much, Dr. Anil. For the last free paper of the anesthesia session, I'd like to call upon Dr. Thanige for his paper on hyperechoic papillary muscle as a sign of Val Kappa. Over to you.
Good morning to everyone. Myself, Dr. Tanigai from Sri Padmavati Children Art Center, Tirupati. Today, I'm going to present a case report of hyperechoic papillary muscle. It's a sign of Val Kappa in presence of left to right shunt. Anomalous left coronary artery from pulmonary artery, a rare congenital coronary anomaly. It affects 1 in 3 lakhs live births, and it is responsible for cardiac failure in an early infancy period. 90% of the mortality occurs within 1 year if we left untreated. Surviving into adulthood depends upon the pre-existing or newly developed collaterals from the right coronary system. Early presentation leads to surgical early repair, leads to a favorable outcome, and it's usually an isolated defect and most often diagnosed in the 2D echo, particularly in the modern era. But it is sometimes rarely associated with other congenital heart disease. When it is associated with left to right lesions, this altered hemodynamics of the particular lesion leads to masking the diagnosis of Val Kappa. In such cases, there will be a subtle clues, and if we omit them, we might miss the diagnosis of Al-Kappa and leads to the catastrophe. So hereby, we report on such case of ASD with Al-Kappa, where the diagnosis was made post-ASD closure and immediately coronary reimplantation was done and the post-op course remained uneventful. So this is a case report. A 10-month-old female baby weighing 4.5 kg came to us with failure to thrive, was diagnosed of a large ASD with the deficient rims, and large PDA was referred for further management. Our echo showed normal LV function with dilated RA and RV. The only odd finding which we could make out is hyperechoic papillary muscles. The coronary origin cannot be appreciated, but we showed the antegrade flow from preoperative echo. So this was the echo. You can show it clearly RA RV dilated and the ASD which is shunting left to right. So this is the parasternal short-axis view showing the LV function, which just looks normal, but the odd finding is hyperechoic papillary muscles. So this is you can see the red flow, which is antegrade flow. This is demonstrated during the pre-op echo. And the ECG was unremarkable for the Q waves in the classic sign of Q wave in the A1 lead 1 in AVL. The child had an estimated RVSP of 50 mmHg with systolic pressure of at that time 70 mmHg. So we took up the patient, we induction was uneventful. The child, after placing the cardiopulmonary bypass, started having some arrhythmias and cardiac distension. The surgeon PDA went on PDA, was quickly ligated, and the aorta was cross-clamped. Antegrade cardioplegia, which is 10 ml per kg of delnido, which was given expeditiously. And the heart did arrest. ASD was closed with an autologous pericardial patch. The clamp time of 12 minutes. And after the closure of RA, aortic cross clamp was released. Rhythm returned, but P showed severe LV dysfunction. We were little why there is for ASD case of severe LV dysfunction. Then we will be discussing itself, and we couldn't see the clear coronary anatomy on TE. The surgeon decided to open the PA, and we found out there is Al-Kappa. So the patient was cooled to 26 degrees, and the cross clamp was reapplied. An antegrade osteal cardioplasia was given, which is 20 ml per kg. The pulmonary artery transected, a large coronary button was harvested, aorta was opened transversely, and the button was transferred using trapdoor technique. The pulmonary artery was reconstructed proximally, and the cross clamp was removed. This time, we could able to wean off the patient from the cardiopulmonary bypass uneventfully with a moderate inotropic support, and we discharged to ICU. The course was uneventful, and we discharged by the 7th day with normal ventricular function. So this is the post-op echo. If you can see the same like pre-op echo, which we the 7th day. So this is a post-ASD closure. So moving on to the discussion, Al-Kappa typically presents with symptoms of failure in infancy when the PVR falls down and establishes the left to right shunt circuit, causing the coronary steal phenomenon. Though it is an isolated entity, there are reports which associated congenital heart disease, including pre and post tricuspid shunt like ASD, VSD, PDA, and coarctation of aorta and conotruncal anomalies also described. The positive preoperative diagnosis of Al-Kappa when associated with the other cardiac defect is really a challenge for the clinician, because symptoms of cardiac failure attributed to the secondary associated cardiac defect, not to the particular coronary anomalies. Though the gold standard coronary abnormality is anything is invasive angiography, the present day non-invasive tools such as bedside 2D echo suffice to establish the diagnosis of Al-Kappa. The echo features are mainly based on Al-Kappa hemodynamics, except the first point, which is the anatomical diagnosis, absence of the LCA ostium in the aortic root. The other 3 points are mainly based on the hemodynamics of the Al-Kappa. So the anterograde flow in the enlarged RCA, an abnormal retrograde flow into the LCA, and minimal turbulent color flow region, it depends upon the intercoronary collaterals within the septum and free ventricular wall. The RCA was mildly dilated. The RCA and aortic diameter ratio exceeded 0.12. It is in infant type patients. In adult type, it is more actually. So in the presence of other cardiac defects, the usual hemodynamic situation is altered depending upon the type of associated defect. So does the echo features. So left to right shin lesion commonly has the high PA pressure, keeping the left coronary diastolic perfusion pressure kept in higher side. So the pulmonary blood and consequently left coronary artery blood also more oxygenated than the normal setting relatively, depending upon the importance of the shunt. So in these settings, we may not able to find out the characteristic echo features of the Al-Kappa, But sometimes we have the subtle clues like echogenicity of the LV papillary muscles, various degrees of MR, and regional wall motion abnormality in the anterolateral wall. So in this case, hyperechoic papillary muscle was the only clue. So there are reports of young adults with undiagnosed L-kappa who have been successfully resuscitated from cardiac arrest due to a VF, and thorough evaluation led to a correct diagnosis later periods. And the such case reports, Shanmugamji et al. In 4-month-old child who underwent a repair of VSD, in whom severe LV dysfunction occurred after VSD closure. After the detection of L-kappa and reimplantation of the left coronary artery into the aorta, the patient could be weaned from the CVP and recovered. Another such case report of VSD, Pinsky and colleagues experienced, and they experienced a post-mortality of 2 VSD patients with undiagnosed L-kappa. They concluded that anomalous coronary had been picked up earlier, the surgical risk would have been greatly reduced. There are other few cases of L-kappa unmasked after PDL ligation. One such case is Fiduli et al. In their case report, a 5-month-old infant in whom PDL ligation resulted in ventricular fibrillation found to be an associated L-kappa. The fact that the post-tricuspid shunts have a higher protective impact on L-kappa hemodynamics, so the closure of such shunts leads to immediately catastrophe. To the best of our knowledge, there are only 3 adult cases of ASD concurrent with L-kappa reported to date. Out of these, 2 cases are incidentally diagnosed on cath angio before ASD closure, both are adults, and the other one was unmasked by a pregnancy complicated by the postpartum hemorrhage. In our case, the early presentation is due to combination of the pre and post tricuspid shunt, with the both volume and pressure overload present and both of impact on L-kappa hemodynamics. So the presence of significant shunts clouds the diagnostic water, which can lead to diagnostic problem. And this is a very important issue as ASD is most often devised by nowadays transcatheter in cath lab. The coronary angiography is not performed in all the cases. Using the multimodality imaging preoperatively when having a suspicion is better rather than an on-table surprise. Intra-op TE can be used for troubleshooting in such scenarios. So the joint diagnosis of practical importance because the clinical course of undiagnosed L-kappa in which postoperative myocardial ischemia is often disastrous. If any unexplained arrhythmia or any unexplained LV dysfunction could prompt the coronary issue, and immediate direct evaluation is necessary to diagnose and rectify. Nonetheless, the present case is a suitable example to highlight the need for a thorough evaluation of patients with congenital heart disease, even if the diagnosis seems to be obvious. Thank you.
Hi, I would like you to ask one question. Like before sending this patient for the OT, was there any pre-surgical echo done? Because generally it would have given a clue regarding the hyperechoic papillary muscles or something. So was there a pre-op echo?
Yes, ma'am. The echo with pre-op, all the echo images which initially showed is pre-op echo only. Actually, they because of the other positive things like the diagnosis is obvious ASD, and yeah, only the clue is hyperechoic papillary muscle. That's why important that missed the another question why there is hyperechoic, but that's not answered. So other things are supporting. We didn't have a clue that and showed the antegrade flow that we should have done for a CT or another or angio.
Right.
So that would have been given the clue. So that we omit.
Pre-op ECG.
ECG also there is no QA in the lead one. So
getting an angio done for this inaccurate ASD is not a routine thing,
yes,
right? We
yes.
don't get it done.
Yes, sir. So
you missed it like, but after opening the chest by the surgeon, the tortuous and dilated coronary artery, I mean the RCA, that can also have some amount of idea.
Yes, sir.
That can also give some amount of idea that there is something not right matching with the diagnosis. Then you can have a look, but opening the PA is not also a thing that we routinely do. Then you have to open the PA and see the ostia, whether it is originating or not. So these are things which we can miss actually. So next time or not, we can keep it in mind. I mean, everybody we can.
Yes, sir. So that's why infantile type that RCA won't be that much tortuous like in adult. That is the reason again in infantile it's easy to miss in these cases.
In the pre-op echo, you had LV function was okay.
Normal.
Right? You told L function.
Yes, yes. The only clue was hyperechoic papillary muscle, which we missed for the further questions.
Thank you. Sir, please.
I must congratulate your team to have successfully managed a very tough situation. I agree that it's It's very difficult when you are in the thick of situations. It's very difficult, and I must congratulate you on that. Number one. Number two is the other clue that L-Kappa can give in this situation is preoperative MR. I don't know if that was there or not.
No, sir, no MR.
No MR, because papillomatosis being partly ischemic might dysfunction.
Yes, sir.
That's another clue that you can get.
Yes.
And the question that I have for you is that very infrequently do we have to go ahead and close an ASD at 10 months of age? There was a large PDA and there was a large ASD. Thankfully, you did not go for PDA ligation.
Yes, sir.
Thankfully, but usually
Yes.
many teams would
Go for the
just to
PD.
go for a closed heart surgery, get the PD out of the picture, and then let's see about it.
Let's see.
So, what made your team go for simultaneous ASD closure?
Sir, the patient
was
had
lucky for the child. Though.
Yeah, lucky for the patient had symptoms. That's a little out of proportion. I think that is the reason we. Went
That's
ahead.
your third clue.
Out of
To hear
proportion.
out from you that you had out of symptoms, out of
Out of
proportion symptoms.
Proportions.
So that is another clue that putting 2 and 2 together. I mean, retrospectively, we are all wiser.
Yes.
But this is a lesson for actually everybody in the audience, not just for you. But if you have out of proportion symptoms, just
We should look.
don't accept very easily. Run behind most of the causes. That's the concept. But it's really and thankfully, you see you had a very quick recovery, and
Yes,
that's probably if this was a pure L-Kappa, recovery would have been slow.
It will be taken.
This was a quick recovery because the myocardium was still preserved.
Preserve.
So you put the normal oxygenation. Probably, if you would have stayed on ECMO, also he would have recovered. But that's
not
too much to do once you have the diagnosis.
Yes.
So because he needed more time of rest, he was doing well before. His function was not.
Yes.
Very nice.
Then another things also happened. It's a previous institute where I was in PG. The cardiologist had given a diagnosis of L-Kappa. We took up the case, non-table, there is no L-Kappa, no L-Kappa, nothing. It's just simply a viral myocarditis, and we had to place the patient for ECMO, and we shifted to the pediatric unit after that. We couldn't take care of. I don't know what happened to the follow-up also. So no. So it took as a little semi-emergency type also. They pushed in a lot actually from a pediatric APC. And so from our side, we couldn't do much. So the another side also happened flip sides.
Both ways.
Both ways.
People get labeled as myocarditis and
yes.
had L-Kappa.
So that's close. Thank you.
Thank you very much, sir.
Thank you.
Thank you, ma'am. Thank you, Thanigay.
Thank you, Dr. Thanigay. I thank our chairpersons for this session, as well as Dr. Raja and Dr. Reena. That concludes our anesthesia free paper session. Thank you all for being here. We'll move on to the next session headed by Dr. Manas Mahapatra over here. And we have a fetal echo as well as a quiz session in hall 3. So if you're interested, we might head to that. Otherwise, the pediatric heart failure sessions going on in day 6. So take a pick. Thank you all again. And take it.
Good morning, everybody. So today is the last day of Pediatric Cardiac Society of India's 22nd conference. We are assembled here for the last day's CME. So very good morning to everybody, to my dear colleagues, my respected teachers, seniors and juniors. So this program is dedicated to our pioneer sir, Dr. DILIP MAHALANOBIS sir. So you all know the sir's contributions regarding the great pioneer work of invention of ORS. Unfortunately, we don't have sir with us. Sir left us at 16th December 2022. So may his soul rest in peace. But he lives on through his legacy of saving countless of lives, because this is the cheapest oral therapy for diarrhea and cholera, and no alternative has been discovered till today. So it's 10 minutes past 9. So should I continue or wait for some time? I think all the speakers are there. Okay. So today's program is divided into 3 sessions. The first session is about diagnostics of pediatric cardiology, and the second and third session is about therapeutics. So I'm going to move on to first session, that is diagnostic. I would like to introduce the chairpersons of this session, Dr. Sukanto Chatterjee, respected sir being the teacher of many of us and also head of the Department of Medical College, Calcutta. I request sir to come onto the stage to chair the session. Welcome, sir. So now let me introduce our next chairperson, Dr. Professor Sushmita Banerjee, Madam, Professor of Pediatrics of ICH Calcutta and also in CMRI. Madam being my respected teacher, I have learned a lot of things in pediatric nephrology from Madam. Welcome, Madam, to the chair. So this session is divided to 3 short talk regarding different types of congenital heart disease. So let me introduce our first speaker, Dr. Munideepa Dotto. Dr. Munideepa Dotto. আচ্ছা Okay. So I'm requesting Madam to come onto the stage for the short discussion and to share huge experience regarding the critical congenital heart disease in newborn. How to diagnose and stabilize the child. Over to you, madam.
I'm Dr. Modibika Dotto. I am talking as a consultant in pediatric intensive care in AMRI Mukundapur. And we sometimes, though it is generally the present in the neonatal period, but we also get some children with such sick conditions. So it is very critical to diagnose this newborn, because if we cannot diagnose them in time, we will lose them. And whenever we get any newborn with in the day 2, day 3 of life with some lethargy, poor perfusion, cyanosis, we always think of sepsis first, and then in our mind come the respiratory problems. But it's though they are very common, the sepsis, respiratory problem, but we should not forget the cardiac anomalies this babies can have, which is very much critical. So now I will like to start my talk with this. Congenital heart disease is the most common form of congenital anomaly. It affects approximately 8 of 1,000 live births. And out of this congenital heart disease, almost 1/3 of the infants has critical congenital heart disease. So what we understand by critical congenital heart disease, as per American Heart Association definition, the critical congenital heart disease is a form of congenital heart disease that requires any intervention like surgery or any catheter-based intervention in the first year of life itself. A more practical definition would be any congenital heart disease that require intervention or may have resulted death within 28 days of life if no intervention has been done. So it is very much important to diagnose them early, and they may not have obvious evidence early after birth. Just after birth, most of these babies look normal. And most of the clinical and physical findings are very non-specific, vague, as I have already told, and we should have high index of suspicion. And when the PDA is open widely, the very serious malformation may not be noticed, because most of this disorder is usually duct-dependent circulation. But when the PDA starts to close, just few hours after birth, and then progresses in days to close, then there is severe acidosis, shock, cyanosis, or even death. Now we should understand a little bit of fetal circulation and the transitional circulation to understand our critical congenital heart disease a little more. And in fetal circulation, we all know the placenta being the major organ for gas exchange. Lung is not the one, as in case of normal human after birth. So in the fetal circulation, the gas exchange, the oxygenation occur in the placenta, and then from the placenta goes to the via the liver, ductus arteriosus is mix the blood with the inferior vena cava and goes to the right atrium, where through another shunt is foramen ovale, which directly goes to the left atrium and then to the left ventricle. And from the right atrium, some blood goes to right ventricle, and which bypasses the lungs via the PDA and comes to the aorta. Then the blood flows to the body. And in contrast to the circulation in the neonatal period of the just after birth, the left ventricle and the right ventricle both contribute to the systemic circulation in case of fetus. And what happens after birth? There is, whenever we remove the placenta, there is automatically closure of the ductus venosus, because we cut the umbilical vein, and there is significant increase in the systemic vascular resistance. So the flow to RA decreased. And another thing happens when the newborn take first breath, there is expansion of the lung. So there is fall in the pulmonary vascular resistance, though not very much, but there is some fall in the pulmonary vascular resistance, which was very high in the fetal life. And there is increase in the pulmonary blood flow. There is
pulmonary, there is arterial oxygen level goes up, and this all contributes to increased flow in the left atrium. And there is close, because the left atrial pressure exceeds the right atrial pressure, there is closure of the foramen ovale. And also there is closure of the ductus arteriosus gradually, because there is a placental source of prostaglandin E2 has been removed, and because there is increased pulmonary blood flow, there is also clearance of the prostaglandin E2, whatever is present in the circulation. So the duct starts to close and ultimately close in the next few days. So accordingly, we can divide our critical congenital heart disease depending on the duct dependent, whether it is duct dependent pulmonary blood flow, whether it is duct dependent systemic blood flow. And there are some mixing lesions which can present in critically, and another lesions which cannot come in this three of this category is the total anomalous pulmonary venous return with obstruction, where the oxygenated blood from the lungs not directly not coming to the left side of the heart, but to the right side of the heart, and there is some obstruction at this level. So to enumerate what are the duct dependent pulmonary blood flow, this is a tetralogy of Fallot with pulmonary atresia. The pulmonary atresia with intact ventricular septum or any shunt in between the ventricle or the atria. And the critical pulmonary stenosis, tricuspid atresia with pulmonary stenosis or pulmonary atresia, severe Epstein anomaly. And the duct-dependent systemic blood flow, the hypoplastic left heart syndrome, there's a complex of this disorder. There's various variants of this disorder. There's critical aortic stenosis, critical aortic coarctation, and interrupted aortic arch. Among the mixing lesions at the transposition of gate arteries, there may be shunting of the blood. There's a parallel circulation and shunting of the blood in the level of atrium, ventricle, or in the level of duct. There's total anomalous pulmonary venous return, as I have already explained, and truncus arteriosus. And there may be TAPVR with obstruction. And how this newborn present? That is very important. That they can be asymptomatic in early newborn period. And as we always search for a murmur, whenever we think of any cardiac anomaly, we search for a murmur. But in these children, these babies, they do not have murmur. And usually the newborn, the systolic murmur we get is almost in 75 to 80% cases, they are physiological murmur. So we should not search for the murmur in these babies, or if we do not get any murmur, we cannot say definitely that there is no cardiac anomaly. We should look these children for the other side. They usually present with any of these three symptoms, that is the tachypnea or difficulty in breathing, cyanosis, which is very important to look for, and the systemic hypoperfusion or shock, which can be life-threatening. Regarding tachypnea or dyspnea, which can occur in due to cardiac problem and also due to lung problem. So we should rule out the these two primarily, and in case of cardiac problem, there is usually quiet tachypnea. That is usually there is no significant respiratory distress is most of the cardiac critical congenital heart disease lesions. The cyanosis with markedly reduced blood flow in right heart obstruction. They usually present with quiet tachypnea or peaceful cyanosis. And there may be severe respiratory distress in case of there is obstructed TAPVR or there's truncus arteriosus whenever there is excessive pulmonary blood flow, or there is any obstruction to the pulmonary venous return, or there is systemic, they usually present with systemic hypoperfusion or collapse. And large shunts may manifest in dyspnea, but they usually present slightly later. And cyanosis, it is the visual recognition of hypoxia, which is not easily detected, especially in a dark complexion babies or in case of very high hemoglobin. It can be central or peripheral, but central cyanosis, which we found in this critical congenital heart disease lesions, it is associated with arterial desaturation. The saturations usually less than 80%, or the deoxygenated hemoglobin is more than 5 gram per DL. It involves lips, tongues, and mucous membrane as compared to the peripheral cyanosis, which is usually present in the peripheral limbs. And it is always pathological due to cardiac or maybe due to cardiac or pulmonary causes. And usually the right heart obstructive lesions manifest primarily as central cyanosis. There may be differential cyanosis, that is our pre-ductal saturations is more than 3% of the post-ductal saturation. And this is due to the left heart obstructive lesions, like interrupted aortic arch or coarctation of aorta, because the desaturated blood cannot go via the due to obstruction to the lower part of the body. The desaturated blood goes to the lower part of our body via the patent ductus. There may be reverse differential cyanosis, that is post-ductal saturation is more than pre-ductal saturation, which is though rare. It can present with the DTGA with pulmonary hypertension and DTGA with left-sided obstruction. And what is more life-threatening is systemic hypoperfusion or shock. It usually present in the first 2 to 3 days, first 2 to 3 days of life in case of left-sided obstructive lesions such as coarctation, like interrupted aortic arch. And the symptoms typically occur when the ductus starts to close. These neonates may present with sudden onset of pallor, gray appearance, breathing difficulty, renal shutdown with anuria and metabolic acidosis. Now coming to the diagnosis. For diagnosis, we should keep our suspicion very high, and we should go from the antenatal period with the start with the history. Then the clinical presentation we should look for, as I have already discussed, and there's a certain bedside diagnostic tool with which we can diagnose them. In antenatal history, we should ask that whether there is any history of previous children with congenital heart disease, there's any teratogen exposure or substance abuse in mother, there's history of infection in the antenatal period, or there is a family history of congenital heart disease in this family. There may be, nowadays there is good antenatal scan and fetal echocardiography is available, and sometimes these critical congenital heart disease can be picked up in the fetal period itself, and we know during the birth of the baby that this child will have some problem. And the important tool which is used for screening of this critical congenital heart disease is the pulse oximetry. It is very much easy to use this and safe to use this because it is non-invasive and also cost effective. And we should keep in our mind that this is not diagnostic, this is for screening purpose. And all the babies, whatever maybe where the symptoms or symptomless, all the babies should go through this screening before they are being discharged from the healthcare facility. Because this is screening, we can pick up a moderate number of babies through this pulse oximetry screening. And it should be done at least 24 hours after birth. It is usually better to if you do it in 24 to 48 hours of life. And if anybody is discharged before 24 hours of age, it should be done just before discharge. And if we have any suspicion, we should repeat it in next follow-up. And should be done in alert, quiet newborn. And there should the measurement should be taken for 2 minutes at least. And this is the CDC guideline for pulse oximetry screening. We can, as I have already mentioned, that we should require two saturation probe. There's one should be attached with the pre-ductal, that is the right upper limb, and another is post-ductal, that is any of the foot we can attach them. That is the post-ductal saturation. And if saturation in the right upper limb, the saturation comes less than 90%, then straight away we can send these babies for cardiac evaluation because that is abnormal. And if it is more than 90% and there is less than 3% difference in the pre-ductal and the post-ductal, we should label these babies that they have passed the skin, and there is a chance of having cardiac arrhythmia is less. But If we have suspicion, we should go for evaluation. And what is in the gray area is the 90 to, when the preductal saturation comes 90 to 94%, and it is more than 3% difference in the preductal and postductal saturation. Then we should give the newborn to some time to settle and again repeat our screen in next 1 hour. Again, depending on the result, we can divide this in 3 groups. And if it is, again, it is 90 to 94% in the right hand and more the right hand and foot, and there is more than 3% difference, we have to repeat the screen again. And if in all 3 screen, they come as same, that is the 90 to 94% in saturation, and there is more than 3% difference in the preductal and postductal, we should go for cardiac evaluation of this baby. And this screening tool actually made to pick up the more critical heart disease. The primary targets as defined by the CDC is the hypoplastic left heart syndrome, the pulmonary atresia with intact ventricular septum, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of gate arteries, tricuspid atresia, and truncus arteriosus. We should able to pick up this as soon as possible with this screening. And what was about thing about the hyperoxia test, though we are traditionally taught every time about the hyperoxia test to differentiate between the cardiac and the pulmonary causes of desaturation or hypoxemia. Nowadays, with the availability of echocardiography, the hyperoxia test is rarely performed because it cannot detect with certainty, and there are dangers with running the test because some children may have pulmonary overcirculation, and we giving 100% oxygen for few minutes, we will increase then pulmonary overcirculation. There may be chance of closing of the ductus with the increase in the PaO2 in the blood, and sometimes it may cause death also with this exacerbation. The another important tool is the chest X-ray, which rule out respiratory issues and assess the pulmonary blood flow and cardiomegaly, which is very much important in diagnosis in critical congenital heart disease. And in some lesion, we can get some specific cardiac shadow. Like this is the X-ray with increased pulmonary blood flow. But as we can make out, if there is increased vascularity in the lateral third of the chest X-ray, then we talk it as an increased pulmonary blood flow. And this is, you can make out the differences. This is the pulmonary oligemia. And also in this X-ray, there is a specific shadow, cardiac shadow, in that is the boot-shaped heart, which is seen in the tetralogy of Fallot. And this is the specific sign, as I have told, that the DTGA, Agon side or Agon string appearance because of the narrow mediastinum. And this is the TAPVR with without obstruction, though nowadays we diagnose it quite early. We cannot, we usually do not see this type of X-ray, but this is the classical of TAPVR without obstruction, the figure of 8 configuration with snowman sign. And TAPVR with obstruction, there is whiteout of the lung. And sometimes in neonate, this X-ray can be very much mistaken as a case of HMD. And if you are suspecting HMD, hyaline membrane disease, and we have given surfactant, we have not getting results. So we should keep our mind, we may be dealing with something called TAPVR with obstruction, go for an echocardiography. And this is the coarctation, as we can all know, this is, though it is not present in the neonatal period, later it comes, it is the 3 signs. And we can make out, this is no cardiac causes is here. This is the diaphragmatic hernia. So X-ray cannot only diagnose the cardiac causes, but also the non-cardiac causes of desaturation or illness. And ECG can help in some cases, especially in the case of tetralogy of Fallot. On all its variants, there is right axis deviation with right atrial hypertrophy. And some of the infants, babies can present in shock in case of arrhythmias like supraventricular tachycardia. In that case, ECG plays role, though it is not critical congenital heart disease. And the echocardiography, it is the new stethoscope in case of cardiac abnormality. And the 2-day echo with a Doppler study can diagnose most of the structural and functional abnormality of heart. And this is a composite table which with all the lesions. And now coming to after we diagnose, coming to order, there is a suspicion of diagnosis, coming to the management of this sick newborn. And we should initially stabilize this newborn first. And as in all sick babies, we should ensure thermoneutral environment for the baby. We should not forget our basic monitoring of the vitals, basic A, B, C, the appropriate respiratory support. And in this situation, especially if the baby comes with cyanosis, we should not target for a saturation, very high saturation, keeping the saturation around 80%, 75 to 80%, because we have to balance the circulation between the pulmonary and the systemic. If we increase the saturation much more than 95, if we target for that, there may be more blood going to the lungs and there is systemic hypoperfusion. We should not go for that. And again, the fluids is very important. You should, the baby should be euvolumic and inotropes, not very much high dose, but to support there may be requirement of the low dose of inotropes. And whenever we suspect there is systemic hypoperfusion, there's systemic, so we can decrease the systemic vascular resistance with the use of milrinone, a little dose of milrinone. And what is most important, if we have a suspicion of this critical congenital heart disease, we should start them on prostaglandin as soon as possible after initial stabilization. And this prostaglandin prevents progressive hypoxia and the acidosis in all cases of duct-dependent circulation. Whenever duct is closing, we should use as soon as possible. It is very half-life is very short, so continuous infusion is needed. And its response is within 10 to 15 minutes. And once diluted, solution is stable for 24 hours. So we should prepare it again next day. Do not continue the same solution for so prolonged period. The dose is very much varied. Those are what I can found in various literature and textbook. It can be from the 0.01 microgram to 0.05, that is 10 to 50 nanogram per kg per minute. And starting dose, there is also very much dilemma about the starting dose, but what we should keep on in our mind, there is two situations. Actually, nowadays, we know there is from the antenatal or the fetal echo, this baby is born with a critical congenital heart disease. And in that case, we want to already open the to keep patent. In that case, we can start with a low dose. There's no point in going for very high dose because duct has not been closed. We should start with a low dose and see the response we can increase. But when the baby comes in day 2 or day 3 of life, the duct is going to close or there is almost closed duct, then we should start with a higher dose because we should open the duct as soon as possible. In that case, we may go up to the 75 or 80 microgram per kg per minute and see the response because we have to reopen a closed duct. In that case, we do not have time to go for a short increment. We have to reopen the closed duct. Then we can, after the duct has opened, we can see the response and come down in our dose. So monitoring is very much important regarding titration of dose. And once the duct is open, we can continue the infusion in the dose of 10 to 20 nanogram, that is 0.01 to 0.02 microgram per kg. And some literature says you can continue with the 5 nanogram per kg per minute dose also. And there are certain complications of prostaglandin. The most important and most noted is the apnea. It is the direct effect of prostaglandin on the CNS. It may need assistance. So whenever we are starting prostaglandin infusion, we should be ready for intubations or support this newborn with ventilation, especially on higher dose. And there may be hypotension. So continuous measurement of the blood pressure if liquid, and then fever, flushing, irritability. There may be diarrhea in some newborns, and in long-term effects, if we are continuing for long, there's a hypertrophy of the gastric mucosa. And in certain situations where there will be no response to prostaglandin infusion or there can deteriorate, like TGA with intact ventricular septum and a restrictive interarterial communication. In that case, we have to go for emergency balloon atrial septostomy because the ductal shunting is not adequate to keep these babies alive or symptoms free. There is maybe obstructive TAPVR, which in that case also prostaglandin infusion can worsen this situation. So we should go for emergency surgery, and there may be other non-cardiac diagnosis which we have missed. So if we cannot get response, what is thought, so we go for searching other etiology and treatment of that. And after stabilization, because all of our centers do not have the facility for cardiac surgery or the intervention, so after stabilization, we should go for the arrange transport the newborn to for the definitive management, and as stabilization of the temperature, oxygen, perfusion, and sugar. And whether to intubate these babies before transport or not, whether in prostaglandin infusion, there is always dilemma. But if we are on very high dose of prostaglandin, it's better to intubate and send this baby, and we are going for a very long distance transport, because it is very difficult to intubate and resuscitate a baby if there is recurrent apnea during transport. So it is better to intubate and transport these babies. And care during transport. And another important thing, whenever we are transporting the baby some referral hospital, we should inform that hospital, because they should be ready with their management plan, because there's some days has been gone, and the intervention should be done as soon as possible. So it is better to communicate with the referral hospital, and the basic neonatal transport principle to be followed. And though all hospitals do not have, there should be a dedicated transport team for transporting this sick newborn. So take-home message is the critical congenital heart disease. It needs to be diagnosed early. None of the critical congenital heart disease is incompatible with life nowadays. Early intervention is the need of the hour. And we should not forget about the antenatal workup, pulse oximetric screening, good clinical examination, and the role of echocardiography in arriving at diagnosis and transport to a center with a cardiac surgery or intervention facility as soon as possible after stabilization. Thank you.
Thank you, Monideepa, for the nice presentation.
Thank you, sir.
And we'll have questions, but we'll take it at the end of the session after three speakers.
Okay.
So it's nice presentation. As a pediatrician, we are really interested to know cardiology or non-cardiology, the different symptoms, and then how to go, and the clinics and the different investigations. Well, thank you very much.
Thank you, sir.
And the next speaker, you introduce, or should we?
Thank you, madam, for nice presentation. It helps us to boosting our knowledge in NICUs. How using simple tools to how to suspect, how to stabilize. So moving on to the next topic, I would like to introduce our speaker, Dr. Shatarupa Mukherjee, madam. Madam is a consultant pediatric intensivist at BM Birla Heart Research Center, Calcutta. And our special areas of interest is cardiac intensive care and ECMO. Madam completed her fellowship in pediatric intensive care from Great Ormond Street Hospital and Royal Brompton Hospital, UK. Madam will be talking regarding congenital cyanotic heart disease in children and how to approach it. I request madam to come onto the stage. Over to you, madam.
Good morning, everyone. Thanks for the nice introduction, Dr. Manoj, and thank you for the wonderful presentation by Dr. Monideepa. I would actually, before I start, mine and Dr. Monideepa's talk are a bit of overlapping. So few things will be repeated, but I will try to finish faster and highlight on. So my talk is on approach to a child with congenital cyanotic heart disease. So I will start with a case to make it a bit interesting. We have a newborn baby boy who was born of a diabetic mother, 3.4 kilos by normal vaginal delivery. Was slideshow? It's here. Slide. Actually, the slideshow is not. So a newborn baby boy, 3.4 kilos, born of diabetic mother by normal vaginal delivery, was fairly stable at birth, but was found to be lethargic in the postnatal ward after 6 hours of birth. Was shifted to SNCU and found to have a dusky color. The room air saturations were 60% only. The respiratory rate was 50 per minute, heart rate 160 per minute, extremities were cold and pulses were very feeble. So the baby was started on oxygen, was shifted to CPAP, and then given fluid boluses and started on antibiotics. Chest X-ray was immediately ordered, and we got the chest X-ray in time, and that showed cardiomegaly with increased lung markings. So at this point, we are in a dilemma what we are dealing with. Is it a respiratory cause of the desaturation, or is it something cardiac? So we should not forget that, yes, it can be a critical congenital cardiac disease. We got a VBG. ABG was not possible at that time. That showed a pH of 7.12, PCO2 30, PPO2 30, PCO2 60, bicarbonate was 12, and base deficit -10, and lactate was 12. So the child is in severe metabolic acidosis. The baby was intubated, and definitely we can't wait for the deterioration, and with proper pre-intubation stabilization, we just intubated the baby, started on ventilation, and echocardiography was requested. But the machine was busy somewhere else, so we couldn't get the echo on time, but the child was deteriorating. So at this point of time, we decided that we should start prostaglandin, even though it may not be a cardiac disease, but let's start with prostaglandin PGE1 and see the response. So the baby was started on 20 nanogram per kg per minute of prostaglandin, and thereafter we got an echo that showed it's a hypoplastic left heart syndrome. So our diagnosis was we were right, and that this baby was referred to a heart center. Thereafter, the baby was shifted, and thereafter we have underwent stage 1 Norwood procedure. So this is how, we as pediatricians, particularly, should keep a close or should keep in mind that we don't miss a congenital heart disease, and there lies the importance of measuring the saturations properly of a newborn baby, and we should not wait for echocardiography if we have a strong suspicion, and there's no harm to start prostaglandin or to prepare the baby to shift it to a higher center. So congenital cyanotic heart disease is usually isolated and sporadic, but it may be associated with some genetic conditions, but it's mainly isolated and sporadic. Approximately 15 to 20% are related to chromosomal anomalies. Actually, it's not changing there. I don't know. I have to change here, but there it's not changing. So 15 to 20% infants in with congenital cyanotic heart disease may be related to chromosomal abnormalities that involves a trisomies. And potential environmental risk factors include maternal illness, including diabetes, phenylketonuria, maternal exposure to toxins or drugs, and viral infections during pregnancy. The history, typically, the baby will be lethargic or irritable. There will be diaphoresis with profuse sweating and crying during feeds. The baby might present with longer time for breastfeeding, poor weight gain, and fast or irregular breathing. There will be bluish or purplish discoloration on the skin. That is, and older children may present with exercise intolerance, dyspnea, cyanosis, or palpitation during exercise, and obviously breath holding spells. The physical finding is cyanosis, and we will come across the next few slides where we'll see that the cyanosis may not be visible until the saturations are less than 85%. So it's not always present, and it is very difficult to detect. So that's why we use the pulse oximetry. And whenever we are in, actually, we should use it for every baby born and screen. And therein lies the importance of screening. The baby may be tachypneic, there's increased walk of breathing, tachycardic, there may or may not be a heart murmur, and there's hepatomegaly. We should not forget for the newborn screening to check for the femoral pulses. And obviously, if the baby is in shock, may present with shock or lethargy. So the evaluation part, fetal echocardiography, it is widely coming up nowadays, and I think most of the mothers in towns and cities get a fetal echocardiography. And obviously, if there are risk factors for like the future pregnancy is affected with congenital heart disease, or there is a history of some trisomies in the family, or the maternal age is, so all these risk factors are there, then we should always refer a baby for a fetal echocardiography. And pulse oximeter screen. So the screening is performed in the nursery when baby is at least 24 hours of age. It might be difficult, like we might not be able to like actually see this correct saturation just after birth. So after a bit of stabilization, and even if we check and we find it normal, we should recheck it after 24 hours. Or as late as possible if the baby is to be discharged from hospital before 24 hours of life. Screening is recommended where it's in the right hand and either foot. So to see for the preductal and the postductal differences. So the positive screening results are any saturation less than 90%. If the saturation is definitely less than 90%, yes, we have to screen the baby, do an echo, do an ECG. And any saturation less than 95% in both the extremities on 3 measures separate by 1 hour. So if you're in doubt, if it is between 90 to 95%, that has already been said by Dr. Monadeepa, so we should take 3 for subsequent measures and give some time for the baby to settle. And then if then also we get a saturation which is less than 95%, we should screen the baby. Or there is a preductal and postductal difference of 3%, and that to measure on like repeated measuring. There's a difference of 3%. We should screen the baby for a cardiac disease. So what is cyanosis? This is all known to everyone, but I know it's noticeable when more than 5 grams per deciliter of deoxygenated hemoglobin is present. That's why we might not be able to detect in a polycythemic baby or in a anemic baby. And also it's like less than saturations are less than 85% only. Then only we can we visually come to detect as cyanosis. Otherwise, our pulse oximeter is the key. So the differential cyanosis, this also has been dealt with Dr. Monadeepa, but to repeat it once again, this is very important and quite interesting. Though in practical situation, we might not be able to always get this difference, and we might not be able to document it. So like, but it's a very interesting thing, like when we get a differential cyanosis, that the cyanosis, it's not there in the upper extremity, like there's a difference in the upper extremity and the lower extremity. This happens when like in case of the differential cyanosis happens when there is a PPH, and like a persistent pulmonary hypertension is there when the duct shifts through the duct. There's a shifting from the blood, shifting of the blood from the pulmonary artery into the aorta. And also reverse cyanosis. So what is this reverse cyanosis? It is when the upper extremities are bluer and are more blue than the lower extremity. That is there when there's a TGA with PPH, PH, or with a concurrent coarctation or interrupted aortic arch. So this is the picture which shows that the first one is a normal one. So which shows the normal cardiac anatomy and physiology. There is no cardiac anomaly. The second picture shows that the pulmonary pressures are high and there is a duct which shifts the blood which shunts the blood from the pulmonary artery to the aortic arch. Not the arch actually, it's the descending aorta. So the preductal saturations, that is saturations in the right and the left, sometimes the left also, will have a saturation that is higher than the saturation in the lower extremity. The other one is a reverse differential cyanosis, whereas the upper limbs are bluer, but the lower limbs are apparently not that blue. This happens with the TGA when there is pulmonary hypertension. And the last picture is a TGA without pulmonary hypertension, where we get cyanosis in all the four limbs. Hyperoxia test, which is nowadays we hardly do it because we have echocardiography in hand, and there are some dangers of hyperoxia test, but just for the theoretical purpose, we should know what is it. And we used to do it, like even though we don't measure 100% FiO2 for 10 minutes, but we typically see, like all of us do measure, put the baby on oxygen and see if the saturations are rising, then we are fine. Then it might not be a cardiac cause. But it may be a cardiac cause. And if the saturations are not rising, then we are pretty well dealing with a baby with congenital cyanotic heart disease. So here it says 100% oxygen for 10 minutes, and we measure the PaO2. If it's more than 100, then it's usually a pulmonary cause. And if it's does not go more than 100, then it's a cardiac cause. The other tests that involve ECG. Yeah, we should not forget to do an ECG, and we should know how to interpret it. And a chest X-ray, an echocardiography, and advanced like CT and MRI. So we should not do an echocardiography before we get an X-ray and a ECG. That's very important. We should not forget our basics and directly move on to echocardiography. And there are like CT and MRI, which are more advanced to see the cardiac anatomy in more detail. So this is ECG, like particularly for the right heart obstructive lesions. If we see the normal newborn ECG axis is usually between 0 to 90 degrees. Okay, so if it's like the superior axis and we get a negative deflection in the AVF, then we are most probably dealing with a child with tricuspid atresia. And if we are having normal axis, or there is left axis deviation with reduced RV forces, then we are dealing with a pulmonary atresia. And in case of tetralogy, we will have a right axis deviation with increased right ventricular forces, and then we are dealing with a baby with tetralogy. So, and then the X-ray, importance of X-ray, these X-rays have already been shown. So in case of TOF, we get, so the two most important things which we should see are how is the cardiac shadow and how it's the lung vascularity. So the cardiac shadow is like whether there's a cardiomegaly or not, and how is the lung how are the lung markings. In case of tetralogy, as you know, there's pulmonary stenosis, so there will be less blood flow to the lungs, so we'll get a oligemic lung field. And the first picture is that of a TOF, which shows this boot-shaped heart, and there is no cardiomegaly. And then the next one is an Epstein, where we get a huge cardiomegaly. And the last one is a snowman's heart, where we get TAPVC without obstruction, or like it's a typical snowman's heart. And sometimes, like if it is a TAPVC with obstruction, it's like a complete whiteout lung, and there we might confuse it with the RDS and or a meconium aspiration syndrome. So they're very close. The presentation is very close. But if a baby is not improving, so we should always screen because the X-ray pictures are almost very similar. So the right heart obstructive lesions, we can just divide the cyanotic diseases into right heart obstructive lesions, the left heart obstructive lesions, and the mixed lesions. So, you know, the right heart obstructive lesions is what is happening. The pulmonary circulation is not getting adequate blood, so the blood is not getting oxygenated. In case of left heart obstructive lesions, the systemic organs are not getting well perfused. So we are not able to, like even if the blood gets getting oxygenated, we are not able to reach it to the tissues. And what is this mixing lesions? These are like there is mixing of the oxygenated and deoxygenated blood. In all these three categories, we have situations where there are the diagnosis is not that straightforward. There is a mixing of all the different things, and we usually are like we get sometimes increased pulmonary flow or decreased pulmonary flow or normal pulmonary flow. So for the right heart obstructive lesions, we usually have this pulmonary atresia, tricuspid atresia, TOF, and critical pulmonary stenosis. So they have decreased pulmonary flow. There is a PDA which supplies the pulmonary blood flow, and this is very important. So we have to keep the PDA. So the baby is dependent on the PDA for survival, for the blood to get oxygenated from the lungs. So PDA supplies pulmonary blood flow by shunting blood from the aorta to the pulmonary artery. There is a right to left intracardiac shunt.
There might be an ASD, there might be a VSD or a PDA. At somehow there has to be some mixing and there should be flow to the pulmonary circulation. The PFO shunts deoxygenated blood from the right atrium to the left atrium, and when the VSD is present, blood is shunted from the right ventricle to the left ventricle. So screening findings are, we get a saturation which is less than 90% without a difference in the oxygenation between upper and lower extremity. The chest X-ray shows a decreased or normal pulmonary blood flow. The X-ray is not does not show a pulmonary plethora. The ECG, as we have already told, that in case of pulmonary atresia, we might get like a normal axis with reduced RV forces. And in case of tricuspid atresia, we get a superior axis. So this is a picture. The first one is a tricuspid atresia, where you can see the RV is hypoplastic, and then the blood is shunted across the from the right atrium across the ASD to the left ventricle, and then it goes into the pulmonary and the systemic circulation. The other one is the pulmonary atresia with a VSD. So pulmonary atresia, whether it is an intact ventricular septum or it is a absent with a VSD. So if there is a pulmonary atresia with a VSD, then there is some mixing and the baby can survive. But if it is a pulmonary atresia with an intact ventricular septum, the baby is completely dependent on the PDA, and we have to keep the PDA open. And the last picture is that of TOF, which we already know that there's a big VSD, there's pulmonary stenosis, there's right ventricular hypertrophy and overriding of aorta. The left ventricular obstructive lesions are the hypoplastic left heart syndrome, the interrupted aortic arch, and the critical aortic stenosis. So there is decreased blood to the systemic circulation. The PDA, here the PDA, the baby is dependent on a duct-dependent systemic circulation rather than a duct-dependent pulmonary circulation. And there's a left to right intracardiac shunt with secondary pulmonary overcirculation. The PFO shunts oxygenated blood from the left atrium to the right atrium, and when VSD is present, blood is shunted from the left ventricle to the right ventricle. So the positive screening involves that saturations are usually less than 95%, and there's greater difference there's a difference between this interrupted aortic arch, there's a difference between the saturations of the upper and lower extremity. And there may be a positive blood pressure gradient also in case of coarctation of aorta. So the ECG usually shows a normal axis except for critical stenosis, where we have a left axis for the newborn. So this is a picture of the hypoplastic left heart syndrome, where we had the first baby, we had the clinical case there. So this baby presented few hours after life when probably the duct was closing. So at birth, the baby was maybe normal, the baby was cold, so we were not able to get the saturations properly, and the baby was fine. The baby was he was sent to the ward. So, but then as the duct started closing, as you know, the entire the left side is hypoplastic, so the systemic circulation is at compromise. So and it is duct dependent. So we do have to do something to keep the duct open. And though there may be a shunting, there's a ASD I can see, but that's not going to supply the systemic circulation. And and then let's see the mixed lesion. The mixed lesions are TGA, TAPVC, and truncus. So this is a TGA, which shows that the pulmonary artery arises from the left ventricle and the aorta arises from the right. So it's completely, the oxygenated blood goes back into the lungs, and the venous deoxygenated blood goes back into the systemic circulation. So how will the baby survive? There has to be some mixing somewhere. So sometimes when the babies are born with a VSD, that's well and good, the baby can survive. The mixing can happen at that level. Sometimes if they have a PFO or the ASD, they can survive for some time. But usually the PFO is restrictive, and at some point, that's not adequate mixing. So at that time, we have to open up the interatrial septum by something called a balloon-atrial septostomy, and that will allow for mixing. And for temporary measure, we can start prostaglandin, which will open the duct open, and that will help in the mixing of the oxygenated and deoxygenated blood. Then we have this TAPVR, which can be obstructed or non-obstructed. Obviously, if there's obstructed, there's a controversy regarding the use of prostaglandin, and the baby might deteriorate. So if the baby so the current what we do is that we are in doubt, and yes, in some case of congenital cyanotic heart disease with prostaglandin, the baby might deteriorate, but we see the response, and if the baby deteriorates, we come down on it, or and if the baby improves, we can just go up on it. So it's not that TAPVR is contraindicated, but we usually we usually see the response, and we need to start prostaglandin. And for truncus, it is like a mixed lesion with increased pulmonary flow, where the aorta and pulmonary artery, they arise from the same trunk. So in this case, cyanosis presents with mixed pulmonary and systemic circulation, and PDA is not triggered, but they can present with or without a PFO. Positive screening test, which has already been discussed, and chest X-ray shows a normal to increased pulmonary blood flow. The ECG will usually show a normal axis of the newborn. Now let's come to the treatment or the management plan. So it's a bit at the beginning, the treatment or the management is same for everyone when we are in suspicion, and then we have to categorize into what we are going to do. But most of the babies, at least 25% of the babies who are born with a congenital cyanotic heart disease, require some form of an intervention or surgery at birth. So we should keep in mind that, and if a fetal echocardiogram shows that the baby is having the congenital cyanotic heart disease, then we should anticipate and plan accordingly. So specialized delivery room planning, we should involve the intensivist, the neonatologist, the NICU nurses, the cardiac surgeon and cardiologist, everyone. And so at birth, if a congenital cyanotic heart disease suspected and cardiac investigation with pediatric cardiologist is not easily available, appropriate stabilization, yes, oxygen therapy, infusion of prostaglandin 1, and prompt transportation to a tertiary care center is necessary. We stabilize and we transport. So prostaglandin E1 is useful for a duct-dependent lesion as bridge therapy for further intervention of cardiac surgery. We can't continue the prostaglandin for long, okay, but we can. Sometimes we do need to wait for the baby to be appropriately stabilized. Okay, so that time we can even continue the prostaglandin for a few months. Approximately 25% of child will require some form of surgery or intervention, and septostomy is to be done acutely in case of TGA, where we have restrictive PF or restrictive ASD. Patient can undergo early corrective surgery. Yeah, the surgery can be corrective, but in case of complex congenital cyanotic heart disease, we do a staged palliation, where we do a shunt, and then later we do a stage procedure. This is a picture of a balloon septostomy, where you can see by the intervention cardiologist will open up the septum, and that will allow for a mixing. It will be a balloon dilatation. Yeah. So what do we do particularly for this baby who was with us with the diagnosis of hypoplastic left heart syndrome, who underwent, came to us, but it is a very complex congenital cyanotic heart disease. And most of the babies, we lose most of the babies in our country because we don't pick them up at that appropriate time, and they are profuse, like the systemic circulation is at stake. And so, and these babies, they usually undergo like complex procedure. They will have a staged repair. So at birth, what we do is that we start them with prostin, and then we do a PT shunt or with a RV2PA conduit. And we usually do a Norwood. What we call is a Norwood, that we do a DKS and a BT shunt. So we separate the systemic and the pulmonary circulation. We do the BT shunt or the RV2PA conduit to maintain the pulmonary circulation, and we do other shunt to maintain the systemic circulation. So this BT shunt, it's like a connection between the pulmonary artery and the subclavian artery. So that's how it maintains the pulmonary circulation. And after the baby is around 4 to 6 months old, we go in for a Glenn. So what is the Glenn? Glenn is that now we are trying to separate the systemic circulation from the pulmonary circulation. So by doing the Glenn, what we do is that we insert the SVC to the pulmonary artery. And we separate the venous return from the upper part of the body into directly into the lungs. So we offload the heart of its venous return. And then we do Fontan circulation, Fontan procedure after the baby is at least 4 to 5 years old, when we separate the IVC also from the heart and we connect it to the pulmonary artery. So this is a stage procedure, and there are some prerequisites and we have to assess the baby, whether the baby is suitable for a Glenn or whether the baby is suitable for a Fontan. And there are many complications, but we do have baby surviving with the Fontan circulation. And so the final answer is, if we have a failed Fontan or these complex HLHs, they might land up in a heart transplant. So the conclusion is that diagnosis and management of cyanotic heart disease is with an interprofessional team. It's a team approach consisting of a neonatologist, a pediatrician, cardiologist, cardiac surgeon, intensivist, and NICU nurses. So it's a team approach. The treatment depends on the type of heart defect. Yes, we should start the treatment that is same for everyone, stabilization and starting on prostaglandin, and then we see the response. But then it depends on the type of heart defect. While some infants, yes, they may have isolated heart defects, but most of the cases, not most, but a significant number of these babies, they have other associated anomalies that also needs to be assessment. They might have airway anomalies, they might have feeding difficulties, and it's a multi-pronged approach, and we have a multidisciplinary team for it. So these are my references, and thank you.
Thank you very much, Shatarupa, for a very nice clinically oriented presentation. We will take the questions at the end.
Thank
Let's
you.
move on to the next talk.
Yes, so let's move on to the next talk. I would like to introduce our next speaker, Dr. Lopamudra Mishra, Madam. Madam is working as an assistant professor in the Department of Pediatrics at National Medical College, Calcutta, and she has done DM Pediatric Cardiology at AIIMS, New Delhi. She also has numerous publications in index journals and presentations in national and international conferences. Madam will be talking about the approach to the how do we approach acyanotic heart disease. So over to you, Madam.
Good morning. I want to thank the organizers for giving me this opportunity. My topic is the approach to a child with congenital heart disease, acyanotic heart disease. So the topic is really vast because we know all that numerous heart disease can be present in different age group. So you all know the congenital cardiovascular diseases are the structural problem that arise either from either the heart or from the blood vessels. And the defects can range in the severity from minor defects, which actually doesn't require any treatment and resolve spontaneously, to the major malformations, which might require multiple surgical procedures or interventions, but ultimately may result in death in utero, infancy, or in childhood. So we all know that the heart disease is not a rare disease. Actually, it is the most common congenital malformation, and about 5 to 8 per 1,000 live births, around 2 to 3 per 1,000 infants will require any intervention in the early childhood. And there is more than 35 well-recognized cardiac defects. So our systematic approach should be, initially we should get a proper antenatal and postnatal history. Then in coming to the examination, we should check normal, other patients, like what we do, like the vitals, then general examination, systemic examination. And then we should do some bedside investigation, like we all know, like ECG, X-ray, and echocardiography. And if required, for some specialized patient, we have to do further investigations like CT angio, MRA, or cardiac catheterization angiography if required. So first of all, we have to answer this question: does the child have any heart disease? For that, we have to depend on the age-old NEDAS criteria. Like if some major criteria are like present, like any systolic murmur of grade 3 or more. So basically, if the child has any thrill, that has to be significant, any diastolic murmur, and also presence of cyanosis or heart failure. In the minor criteria, we have the systolic murmur of grade 2 intensity, abnormal heart sound, any abnormal ECG, X-ray, or abnormal blood pressure. So any major criteria or any 2 minor criteria will suffice the NEDAS criteria. So when we show that the child has a heart disease, then we have to decide whether it is congenital or it's acquired. If the child is very small, a neonate, then obviously most of the time it is congenital. But sometimes the symptoms may persist, but the child may be recognized later. Like if the child has any bicuspid aortic valve related complication or something, or PS, though they may be present from initially the defect may be present from the birth, but it will be recognized later. Or also like Epstein's anomaly, which is usually picked up in much later age. Then if the murmurs are more parasternally, it is more likely to be congenital, or otherwise acquired murmurs are more apical, though it is not confirmatory always. And some presence of extra cardiac anomalies also points towards the maybe a congenital or syndromic child. So when we have understood that it's a congenital, then we have to answer the 5 basic questions as stated by the Paul Wood, that whether the child is cyanotic and acyanotic. Though we think that cyanotic and acyanotic, it can be defined very easily. But actually, if the saturation is between the 95 and 85, it is very gray zone. And sometimes these childs are also get complicated by the presence of pneumonia or shock, when the differentiation between the cyanosis and acyanotic disease becomes very difficult. Then after answering the question, we have to decide whether the pulmonary blood flow is more or less. Then malformation is present in the right side heart or the left side heart mainly, and which is the dominant ventricle. Like if the malformation may be in the right side, like if we have a tricuspid valve abnormality or ASD, then the right side will be dilated. But sometimes the right side may be small. Like if there is hypoplastic RV, then the malformation in the right side, but the dominant ventricle will be left side. And then we have to finally answer the question whether what is the status of the pH, whether it's a hyperdynamic pH or hyperkinetic pH due to the flow, or it's becoming a more obstructed pH, or Eisenmengerization has started or not. So as I already stated, between 85 to 94, it's very difficult. More than 94% in the room where it means the child is most likely to be acyanotic, and especially if there is no difference between the preductal and the postductal. So if the 93 to 85s, we won't be able to pick it up. We have to rely on the SpO2. Like if we have admixture lesions where the distal to the mixing chamber, the saturation will become same. That may include TAPBC, that includes the truncus. Here the saturation is quite good. So if we give oxygen to them, even they have a more than 90, even 94% or even more than that. Then we clinically sometimes they behave like a acyanotic heart disease. But when echo is done, then we can come to know that is a cyanotic heart disease. On the other hand, the pink fallows, like where saturation is very borderline, they might present as a acyanotic heart disease. So any cyanotic heart disease with borderline saturation, if there is increased pulmonary flow evidence is present, then it's more likely admixture lesion. And if there is decreased pulmonary or normal pulmonary blood flow, there is more likely a pink top. We have to remember that the cyanosis in the cardiac disease is more constant. So if there is only isolated pH, like PPH and others, that is very, the saturation will change over the time. And if the child is in shock, even the acyanotic child may present as cyanosis because of the venous stasis, right to left shunting, intrapulmonary shunting, or any peripheral oxygen extraction. So differential cyanosis that already been explained in the previous lectures, we can find in the hypoplastic left heart or critical AS and COA, where only the lower limb will be desaturated. So they may present also as a acyanotic heart disease. So basically the classification is the cyanotic congenital heart disease will be cyanotic, acyanotic. In the acyanotic, we have mainly the left to right shunt, which include the pre-tricuspid and post-tricuspid shunt. In the valvular disease, we have the stenotic lesion and the regurgitated lesion, and also have another entity that is the myocardial diseases. In the pre-tricuspid shunt, we all know that is the ASDs will be different type, ostium primum, secundum, sinus venosus, or coronary sinus type of ASD, which is very rare. And also we have the PAPBC, where not all the 1 or 2 pulmonary veins will drained in the RA or other right-sided vessels than the LA. And the post-tricuspid shunt, we have the VSD, AVSD, PDA, epi-window, and RSOV. In the obstructive, it may be aortic valve, pulmonary valve, or the LA inlet. In the among the cardiomyopathies, apart from the congenital cardiomyopathy, also we have to remember the L-kappa, that is, or other coronary angiopathy, which also might present in the initial after around 6 to 8 weeks of age. So coming to the percentage of the different heart disease, we all know that VSD is the most common. Then comes the atrial septal defect and PDA, almost similar incidence, and then the pulmonary valve stenosis, after which around 5%, and then aortic valve stenosis, just around like same incidence. And among the other AV valve regurgitations, we have to remember that the other diseases are very rare, but when it's present, acyanotic heart disease, which is presenting on the day 1 of life, then we have to remember the causes will be like AV valve regurgitations. Like if stain, they present with the TR, sometimes we can get the AVSDs presenting with the MR, or CTGA, that the corrected TGA, where there will be no desaturation, because ultimately the connection will be normal, because the atrium will be connected to the right atrium will be connected to the left ventricle, and which again will connected to the pulmonary artery. So double discordance will be there. So ultimately the saturation will be normal, but they may present in the infancy or the early childhood as with presence of AV valve regurgitation. And then we can have the papillary muscle dysfunction, which again common in the birth asphyxia patients. Then myocarditis or cardiomyopathies can present in the day 1 of life, and the systemic AV fistula we cannot forget in the first day of life. Early infancy, we know that post-tricuspid shunts, they usually present like BSD or the PDA, they usually present by the 6 to 8 weeks when the PVRA decreases and the shunt increases. But we have to remember that the preterm babies, they actually present earlier. They can present by around 3 to 4 weeks. And pre-tricuspid shunt, because here that is the ASD and PAPBC, here the flow depends on the ventricular compliance. So that after decreasing the PVRA, change of this compliance, but because the RV and LV remain same stiff at the after birth, and after decreasing PVRA, the RV compliance will improve, and then the flow will start in the ASD or pre-tricuspid shunt, though so they become symptomatic by 4 to 6 months, not before that usually. And then the aortic stenosis and the pulmonary stenosis, their presentation depend on the type of how tight is the stenosis. Coax also can represent from the even from the initial newborn period to the late age also. And congenital cardiomyopathies also present, there is a varied presentation depending on the age. L-kappa is also again present by the around 6 to 8 weeks when the PVRA decreases and the flow starts. Also the tachybradycardias also have a very huge age group presentation. In the older child, we mostly get the bicuspid aortic valve-related complications and the Epstein's disease. Rest are mostly acquired. Now coming to the symptoms, we all know about the symptoms. Symptoms can be due to the left to right shunts, which is more tachypnea, tachycardia, failure to thrive, feeding difficulties, which is also seen in the cardiomyopathies. But the obstructive diseases they doesn't have a frequent LRTI or this high flow situation like symptoms. They are mostly they gain weight properly. In the older children, we have a different sets of presentation. Like they have, apart from these symptoms, they may have a chest pain, syncope, and paroxysmal nocturnal dyspnea in the case of inlet obstruction, LV inlet obstruction. So L-kappa patient, sometimes they present with not feeding difficulty, but fussiness and irritability during feeding. So that may be equivalent to angina in case of L-kappa. And chest pain are mostly present with the mitral valve prolapse or LVOT obstruction or coarctation or hypertrophic or dilated cardiomyopathy or any anomalies in the coronary artery. On the other hand, syncope present in the severe aortic stenosis, hypertrophic cardiomyopathy, severe pulmonary hypertension, or CTGA which present with a heart block and bradycardia. In case of long QT syndrome or any CHB or any tachybradyarrhythmias or severe hypertension in case of COA. So now coming to the history part, we have to take a detailed maternal history because some drugs or some diseases in the mother predispose for certain heart diseases. And if we get the history, then we can suspect this type of heart disease may be present in the child. On the other hand, if the child is syndromic, we know there is a exhaustible list of diseases where the child is having syndrome, and also very high percentage of them have heart disease, like Down syndrome, almost 50%, Edward Patel, almost 80 to 90% of them have the heart disease. So if we understand what syndrome they have, then we can suspect this heart disease may be present. On the other hand, if we pick up the heart disease, then we can put like this together, like this child may have this type of syndrome. So if this is helpful this way. And coming to the vitals, we all know that if there is a high BP, that may indicate that the child is having coarctation or differential cyanosis if present, then hypoplastic left heart type of disease may be present. Now coming to the different pulses, like what type of pulse they have. If we have a large volume pulse, that means the pulse pressure is less than 20, or if a small baby, if the pulse pressure is more than 50% of the systolic blood pressure, then we can say it's a high volume pulse, which commonly we encounter in case of aortic regurgitation, PDA, AV fistula, truncus, or persistent truncus. On the other hand, the small volume pulse is present in case of coarctation, especially in the lower limb. So this is not actual the normal pulse, where we have this percussion wave, then there is a dicrotic notch. So this pulse here, the amplitude is less, and this is a small volume pulse, which we commonly have in where the left-sided output is less, like AS, MS, or in case of shock also in CHF. Hyperkinetic pulse, there is high output set, so the upslope, this is a rapid upslope, like high MR or VSD, where the volume is left ventricular output is more. So in these cases, we can have this type of hyperkinetic pulse. This is a special kind of pulse where the rise is very slow, amplitude is also less, and rise is slow and delayed. So this is in case of severe valvular AS. And collapsing pulse, where there is a rapid upstroke, but then rapid downstroke. So which is due to the runoff. Means there is a low resistance pathway where the LV output is going someplace else rapidly. So that we can have in case of AR and PDA, where there is return will be through the aorta. In case of RSOV or AV fistula, also there is a low resistance pathway. So the blood will slowly go to the other, rapidly go to the other places. Then we have this pulses alternates, which we can get in the severe heart failure, one large and one small pulse. Pulses paradoxes means we normally know there is a BP falls around 10 millimeter Ag during inspiration, but here the fall in BP in the inspiration will be more than 10, which we can get in case of tamponade or in the constrictive pericarditis. So also the radiodural delay or radiofemoral delay we can get normally in case of coarctation. JBP though is very useful in the adults, but the small babies may be difficult, and mostly it's only indicate that if the child is in the heart failure or having a right-sided obstruction, like in case of TR or TS, the JBP will be high. Now coming to the CVS examination, first we have to see whether how is the precordium, whether the precordial bulge is present. That's mainly indicate the volume overload cases. And if there is heave or lift, that indicate depending on the presence. If it is in the apex, then will be HCM. If it is present in the left parasternal space, then it's mostly indicate that RVH or left atrial enlargement, which we can find in the ASD. In the pulsations, among the pulsations, suprasternal pulsation we can see in case of PDA, epi window, or in case of AR or AS. And epigastric pulsation we can find in case of TR, RVH, or abdominal aortic aneurysm or tricuspid stenosis. On the other hand, back pulsations we can see in case of coarctation. Similarly, thrill in the suprasternal stage indicate presence of aortic stenosis, and pulmonary area is presence of pulmonary stenosis. On the other hand, we can get it in the apex in case of MR. Now now presence of apical impulse. So we can have a RB type. Basically, we need to define what is the type of apex. So type of apex, one is the apex position, and then if it is out, down and out, we all know it is LB. If it is only out, it is RV. And if the apex, that is the maximum cardiac impulse. From the maximum cardiac, we have to understand what type of apex it is. It is LV apex, which is more prominent in the apex, that is then it is LB type. If you say the lower left sternal border, then more it's a RB type. And diffuse apex, we can, where the proper thrust is not felt, which may be present in case of LV dilatation or LV dysfunction. And well sustained or heaving apex means pressure overload like coarctation or aortic stenosis. And in case of volume overload, it's more ill sustained. It is forceful, but it will not sustain. And then coming to the auscultation, we all know about the positions, which is that is the in the left second intercostal space, it is a pulmonary area. In the right parasternal second intercostal space, this is the aortic area. And then left fifth intercostal space is the midclavicular line, is the that is the apex. And in the lower left sternal parasternal space, that is the tricuspid area. But we have to remember that in children, especially when we are suspecting the congenital heart disease, then we should not mention like it's a mitral or it's a tricuspid, because depending on the disease, actually the heart dispositions will be different. So this is not a mitral, might be this side also, if it is a CCTGA. So we should say that this is the place where we are finding this type of apex or this type of trill or findings. We cannot mention that this is a mitral area. Now coming to auscultation, we all know that there is a main, apart from this heart sounds, we can have additional heart sounds like S3 and S4. S4 is just before S1 and S3 is in the after S2 in the diastole part. And then we have ejection systolic click, which starts immediately after the S1. And here we can have the opening snap just after S2. Then we can have pericardial knock, and then comes this tumor plop. In the first heart sound, basically it's mainly important from the MS. If the first heart sound is palpable and it's prominent, which can we have in the MS, TS, and sometimes in case of ASD, VSD, due to the increased flow. If it's a large ASD, large VSD, so there will be secondarily the volume, as a large volume will pass through this left side and right sided AV valve. So there will be some obstruction. So that will cause a loud S1. And soft S1 is found in case of MR, LV dysfunction, or immobile LV, where either the valves are not immobile or they are very they are placed from their distance is less. So from that short distance, when they are getting close, the sound will be less. The second heart sound is very important to differentiate between with the different diseases, because it is called as the key of the auscultation. So what depend normally it's best hard in the second intercostal space, and if it is hard in the apex, actually it is hard more than the pulmonary area. It is also hard prominently in the apex. Then actually this is actually loud S2, and normally after 3 months of the S2 is louder than the A2, and the normal spitting, which we only can hear during the expiration, during the inspiration, then actually it is called normal spitting. That is the inspiratory delay of the P2. So basically this happens because the pulmonary valve, the pulmonary artery, the compliance is much more. So this right-sided valve remain open for a longer time. The blood continue to move in the RV through the RVOT in the pulmonary arteries before, and the left-sided flow stops much earlier. So that there is normally a inspiratory delay that is around 20 to 30 seconds, which is so split is only audible in case of inspiration. But when it is hard also during our expiration also, that means it is the delay has increased. That is more 30 seconds or more. So that is called increased second heart sound split. So wide and variable split means it will be narrower in case during the expiration and the gap will increase in case of inspiration. That means it is a variable speeds which we can found in case of a moderate to severe PS. And wide and fixed split, that is the both in inspiration and expiration the split is same, that we can encounter in case of ASD, in RBB or WPW type A, where the ECG feature will be ultimately like RBB. Paradoxical splitting, that means only the split will be audible during expiration only, but it won't be hard in case of inspiration. That means that the child might be having the PDA or ACE when the left-sided flow will continue for more duration. And single S2, it either can happen because the other valve is not, only one compliant valve is there, or if there is both A2 get delayed or P2 get earlier, so they merge together. So that can happen in case of severe PH, or there is only one semilunar valve, severe PS or ACE, where it is the sound of closure is not heard. So like, how can we use this second heart sound in case of any left to right shunt like VSD? If the child is having hyperkinetic PH, that means there will be wide and variable S2, and P2 intensity will be accentuated. But if the shunt is small, say that will be normally or narrowly split S2 with accentuated P2. Basically, PH means there will be accentuated P2. If it is wide and variable, that means that is hyperkinetic, that is due to the flow. And if it is almost single S2 narrowly split, that means the obstructive PH. And in case of right to left shunt with the PH, it will be single. If the split will become narrower, that means the gradually from the hyperkinetic PH, it is gradually changing to the obstructive PH. In case of mild to moderate PH with the left to right shunt, there will be wide and variable split with diminished P2. And in case of severe PH with the right to left shunt, there will be wide split S2 with inaudible P2. So it will become ultimately single. And the small defects usually have a normal S2. Third and fourth heart sound, we all know it's mostly indicate there is a large left to right shunt, or there is a heart failure present. Ejection click or sound, they are the adventitious sound which are present apart from the heart sounds. Mostly there are two types of ejection clicks. Either it is due to the valves or it is because of vascular. Valves means there is presence of abnormality, some abnormality is present. Like even in the bicuspid aortic valve, though they are not having AS or AR, they still have a click sound. Or if the dilatation is present, the idiopathic dilatation of the pulmonary artery or arterial aortic dilatation, there also we can found some ejection clicks. On the other hand, if we have a click present in the apex, it's mostly indicated in the MVP. Also, the click is here delayed little. Like ejection systolic just happens after S1, but in MVP, the click is in the mid systolic with a late systolic murmur. Now coming to the heart murmur, depending on the heart murmur, what type, it's a diastolic murmur or grade 3 or more, then it's more actually some pathology is there. If it's not, then maybe physiological murmur also. Position of the murmur and onset of murmur also indicate what type of murmur it can be. Like, as we already have discussed, that few hours after birth, if murmur is hard, that means either it's a stenotic lesion or it's a AV valve regurgitation, or thank you, sir, or any small left to right shunt where it's very small, then we can heard it in the newborn period. But if it is a large significant left to right shunt, it will be only audible after regression of the PVRI, that is around 4 to 6 weeks. And post tricuspid shunt usually audible by around after 3 months of age. Pre-tricuspid shunt like ASDs. Now coming to the different kind of murmurs like ACE. If we have an early systolic murmur, that means it will start with the S1. So S1 will not be heard properly here. That means either it's a small VSD or a large VSD with pulmonary hypertension. Or we can have this type of MR or acute TR that can have an early systolic murmur. ejection systolic murmurs, like it will be a rhomboid shaped, like the S1 will be clearly audible because there will be gap between the S1 and onset of the murmur, that we can, if it is aortic area, that is aortic stenosis, and if it is in the pulmonary area, that means a pulmonary stenosis. But in case of PS, we have to remember, even if it is a significant PS, with the increase in severity, gradually what will happen, this P2 will be less audible, because this murmur will spill over the, it will cross the E2 and up to reach up to P2. So because the presence of the murmur, we are not able to hear the P2 clearly. So it almost becomes single heart sound.
Dr. Lopamudra, can we finish in about 2
Yes,
minutes?
yes, ma'am. And so different kind of murmurs, we will indicate what type of heart disease we have. So after this murmur, the other thing which can help us, that is the ECG. So ECG, we can first help us with whether it's a type of, what type of dextrocardia, mesocardia, or levocardia, that we can understand. And then there are specific ECGs which may indicate what type of heart disease we are having, which size, whether the RVH is present, or if there is, what is the axis, which all indicate different type of heart diseases. Like we have to remember few things, like if there is strain pattern, that is LVH may be present in case of left to right shunt also. But if it is LVH with strain, that is the ST depression T wave changes, that means it is either aortic stenosis or coarctation. Or if we have, normally we have to remember, though they have LVH in the left to right shunt, normally the axis is normal. Axis will not change. It will not be left axis. But if a VSD is having a axis change, like left axis deviation, that means either it is inlet VSD or inlet extension of muscular VSD or septal aneurysm or multiple VSDs. Other important characteristic are Himalayan P wave, if we can see, that indicate the Epstein's disease. And if there is Q wave in the right precordial leads and absent in the left precordial, means Q wave is normally present in V5 and V6. So if it is not present in the V5 and V6, and on the other hand is present in the V1 and V2, that means it means that it's a L-loop ventricle or congenitally corrected TGA. Now coming to the X-ray, also similarly we have to go whether the child is having cardiomegaly, then which chamber is enlarged, whether it's a RH enlargement is present or LA enlargement is present, or it's a RV or LV. Depending on that, we can understand which type of disease the child is having. Also, we can look into the vascularity. Normally, we know the lateral 1/3 of the X-ray doesn't have any increased vascularity, and the vascularity is more in the basal portion than the cephalad portion. So this normal pattern, when it got lost, that means the child is having something problematic in the heart. Like if there is plethora, there is more likely the child might be having a left to right shunt. Or if there is a oligemia, that maybe the child might be having a obstructed lesion, like stenosis. On the other hand, if we have a pulmonary venous congestion where we can get this cephalization initially, or we may have the Curly's line, that might indicate the LA inflow obstruction, like MS or MS equivalent, Lutembecker or any LA inflow obstruction like parachute mitral valves, like these things may be present. Also in the coact and AS, we have to remember they might have this pulmonary venous congestion in the newborn period. And pulmonary hypertension, also we have to know there is a pruning, that is sudden change from a dilated pulmonary artery in the medial 1/3 to in the middle 1/3. If there is decrease in 50% in the vessel caliber, that is pruning. If it is present, there is more chance of obstructed pulmonary hypertension, or the child may get Eisenmenger changes may be present. So here we can see X-ray where some vascular abnormality is present. So it may indicate the presence of Schmidt syndrome. And already this has been shown. This is showing the coarctation with the rib notching, though which we can see only after a 7 year of age, and also very large heart, which might indicate the Epstein's disease. So coming to the last slide, that how can we differentiate whether it's the hyperkinetic or pH or fixed pH? That is very important clinically. And one thing, the symptoms will decrease as it becomes fixed. There will be apparent improvement initially, and then there will be deterioration when the child will become cyanotic. Heart size will gradually decrease, but ASD, we have to remember, even in the Eisenmenger ASDs, we have a large heart. And parasternal impulse is hyperkinetic in case of a hyperkinetic pH, and it is just forceful, ill-sustained, and heaving, forceful, well-sustained in case of ASD Eisenmengerization. But it remains mild, like VSD PDM. The click of pH is absent in case of hyperkinetic pH, but is present in case of fixed pH. And the second heart sound already we have discussed, but we have to remember in the ASD it remains wide and fixed, both in the hyperkinetic and fixed pH. But VSD, from the wide and variable P2, it becomes a single second heart sound. And PDA normally is paradoxically split, but it becomes normally split if the child have become, the obstructive pH has developed. The murmurs gradually decreases in case of when as the pH become more obstructive, and flow murmur, which an ST which was initially present now will be absent. So in this way, we can divide whether the child is having left to right shunt or any obstructive lesion, and depending, after deciding that, we can differentiate which type of left to right shunt or the obstructive lesion the child is having. So thank you.
Thank you, Dr. Lopamudra, for your exclusive presentation. I remember my undergraduate days, how methodical you are in the clinical findings, evaluation, I mean elicitation and evaluation. Yes, slow but steady wins the race. I will remember it. Thank you very much for giving stress on the clinical methods. That will never be replaced by the modern gadgets. Modern gadgets could only supplement the clinical methods. Thank you very much.
Thank you, sir.
Come here and sit down, and I pass on this mic to my co-chairperson for questions taken from the audience.
Can we ask the other two speakers also to come up on the stage? Questions from the audience?
Yes, Dr. Anil is there.
Any mic here in the audience? Please come up.
Thank you, sir and madam. It's nice. Can I make a small comment here? It's not question. With your permission of the chair. Thank you, please. They have made our life easier by extensively dealing with the pediatric cardiology. It was a pediatric cardiology review for me in last 1 hour. 2 points I want to make. For a pediatric practice, we want to answer 3 questions. Is there any heart disease? If it is so, what is the type of heart disease and when I'm supposed to refer? 3 basic questions we need to answer. Clinically, seeing the child, she explained nicely what are the parameters we are going to see, including X-ray ECG. NADA's criteria, as we always discuss, 100 years still it is present. So when she was discussing H2, I must honestly tell it is extremely difficult to get H2 in small child because the heart rate is very high. A newborn or small child who is sick, heart rate will be 140, 60 or 80. We cannot get the so detailing of H2. It's difficult. That's why the H2 has come to the minor criteria. Though it is so important, it has come in minor criteria. Major criteria still the loud murmur. So most common referral point what we get is a loud murmur and echo. Like that, that is the most common. Once we are sure heart failure, loud murmur and cyanosis or diastolic murmur, we are satisfying there is a possibility of heart disease. So what category of heart disease is the next one? With failure or without failure, with reduced pulmonary blood flow or higher? We should try to get a good pediatric cardiac opinion. If we are fortunate enough to get in our setup, then we can decide and then plan immediate referral versus slow referral. For example, a child having 85% saturation, diagnosed having tetralogy with good pulmonary blood flow does not require any referral. The pediatric and neonatal team can very nicely manage, and electively the child can come to the pediatric cardiac clinic vis-a-vis a child having duct dependent lesion. There the child need to be shifted on a priority basis to a pediatric cardiac center. The whole importance of this discussion when we should refer after understanding how significant is the heart disease. And last point, that X-ray of the TAPVC usually don't get that figure of 8 before 6 to 8 years of age, because this SVC and the vertical vein don't get dilated. So in newborn, don't expect a figure of 8. This is just some add-on point.
Thank you.
They have very nicely clarifying. So it was getting an rehearsal for me. Thank you, madam.
I think one point that I really took from all of your presentations, you talked about the doing a screening saturation in all babies before discharge. So I think that is something very easy to implement, but I don't think it is being done at all. And I think in many centers, we do not have the neonatal probes to. Okay. But probably smaller nursing homes, smaller out in the community, probably it is not something very common. You're doing right. Right. I think, with after COVID, everyone has access to those, bigger saturation monitors, but with the smaller, accurate neonatal probes is very uncommon.
Where there is no difference in the saturation.
Yeah, you will not. You will miss some, but at least it's a good screening for some diseases. My question is that we often get involved with cardiac patients when there is a AKI as pediatric nephrologists. So fluid management becomes very tricky in children, neonates with a very low cardiac output. So how do you decide how much fluids to give to this kind of a patient?
So yes, we do get come across AKI. So we usually it's difficult to assess what is the cause. It's a pre-renal or a renal AKI, acute kidney injury. Yes, we definitely will give a fluid challenge, as we usually do. We give a fluid challenge and then see the response. And we go by the different parameters, like we see the fluid assessment has to be done, bedside fluid assessment by an ultrasound, like the newer techniques. But yes, when a baby is in heart failure, when there is pulmonary edema and so that time we try to restrict. But we usually do a balance, and it's an hourly or a time to time assessment that is being done. That's what I feel. And obviously renal replacement therapy, yes, these complex kids, they sometimes need renal replacement therapy, in which case for a newborn and for a small kid, it's usually the peritoneal dialysis. But as because we don't get the appropriate size catheters for the hemodialysis or the CRRT in India, in smaller kids. So we depend on PD, and we depend on diuretics like low dose infusion. That's what we do in the intensive care units. But definitely AKI is very challenging to manage, and the fluid assessment has to be very dynamic assessment.
Any questions? Any further questions from the audience? Meet up the audience.
Very often on a Sunday, we don't have an echocardiograph available. So very often we have faced these situations where very small newborns with desaturating at 60, 65, 70, we have given prostaglandin and transported the baby. My only question is this information being percolated into the community where prostaglandin can be life-saving in such a situation? So very often, even in a hospital, we have got scarcity of prostacyclin. And another thing is, do you give aminophylline as a precaution to prevent the apnea, or do you recommend intubating these babies before transfer?
Actually, we start prostaglandin whenever in suspicion. It is better to start prostaglandin because there is no harm in starting prostaglandin, whether it is cardiac or non-cardiac. And after stabilization, we should transfer. Whenever echo is available, we can go for the final diagnosis, but we should start prostaglandin. And regarding aminophylline, we do not start aminophylline prophylactically or preemptively. We should look for apnea. If there is recurrent apnea, we go for intubation, as I've already told. And if it is higher dose, most likely we end up with intubation.
Then I wanted to know from if it's possible that slow dialysis, like the newer dialysis techniques that is it possible to how much what is the youngest stage when it is possible, like SLADE or those things?
Okay, so if you have a dialysis machine which you're using for hemodialysis, which can be calibrated for low blood flow, then you can do SLADE. But the problem is the high flow lines that you need, the central line that you need, which has to be high flow to get enough blood flow, we have not been successful in finding those lines in less than 10 kgs. So we have used, say for SLED or for HD, we have used lines in what is available, 8 French usually, 7 or 8 French, but sometimes that is too big for a neonate.
Because sometimes this type of SLED or these things are helpful in heart disease or heart failure also.
So you've probably seen recently, well, not too recent, last 5-6 years, there are smaller machines with even lower sort of extracorporeal volumes and lower blood flows that have been developed just for neonates. And you can even use umbilical catheters for those neonates, but they are not yet available in our situation.
Well, if there is any other questions or otherwise, we should conclude this session, but I must give thanks to all the speakers. But still, I have one question for Monideepa. That, well, we are all pediatricians, maybe a little cardiac oriented, suspicious, but then on 3rd, 4th day, if a newborn baby is getting rapidly down and say pale and lethargic and all that, besides the possibility of cardiac disease, we commonly think of sepsis and hypoglycemia. So you have mentioned that also, but I think that is more common than cardiac disease.
That is more common, and we should not forget our commonest. That is, we should rule out our sepsis. We give the good antibiotic coverage. We should rule out hypoglycemia, which is more common cause for a lethargic newborn. And we should also look for the respiratory causes also, which is more common than the cardiac critical heart disease. But we should not, this emphasis is that we should not forget the critical congenital heart disease, which is present in some newborn. That is the more common thing we should think of that first, because that is rare thing is rare. So, but we have got the common thing first. So we have to rule out the common thing. We have to cover for that. But at the same time, if with our standard management of the sepsis or the respiratory problem, if the baby is not improving with all the measures, then we should think of this cardiac causes strategy.
Well, thank you very much. And here we conclude this session. And thanks to all the speakers and thanks to my co-chair. Thank you.
Thank you, dignitary speaker and respected and dignitary chairpersons. It was a nice session. I would request chairpersons and speakers to stay just a minute at the stage because we are going to take a group photo. Thank you. Thank you, sir. Thank you, madam. So that's the end of first session. And now we are moving on to the next session. There will be no break actually. Teas and coffees are outside. So teas is on the go. So the next session will be on the therapeutics, the next in pediatric cardiology. So I'm going to the next session without wasting much time. I will. We are fortunate to have Dr. Shumita Basu, madam, she agreed to chair this session. Madam is a renowned pediatrician and professor of pediatrics at Ramakrishna Mission Hospital. I will request madam to come to the stage and to chair the session. Thank you, madam. So now, let me introduce our next speaker, Dr. and Professor Sumantro Sarkar sir. Sir is head of the Department of Pediatric Medicine, Diamond Harbour Medical College and Hospital. Sir is also a research person of UNICEF, NRHM, and government of West Bengal Government's Health and Family Welfare. Sir has more than 100 publications in national and international index journals, and also Sir holds a lot of prestigious awards and recognition. I will request Sir to come onto the stage for the next topic, which is acute rheumatic fever in children. Where do we stand? Sir, over to you, sir.
Respected Chairperson, all the delegates, my teacher, Sir Professor Sukanta Chakravarty is here, my brothers, and all those. It's a wonderful morning here. I wish good morning to all of you. And thank you, organizers, for giving me a scope here to have a talk on this acute rheumatic fever. Where do we stand? From a pediatric point of view. So we know that acute rheumatic fever, a delayed autoimmune response to a group A streptococcal infection resulting in a multi-system inflammatory illness. And in the acute phase, it actually involves the cardiac valves and causes rheumatic heart disease. And when it becomes chronic, the cardiac valve damage can predispose to heart failure, arrhythmias, stroke, and early death. You all know, especially all pediatric cardiologists all know this. But when we talk about where we are, first say where we were initially. There's an interesting history. About 100 years back, rheumatic fever and rheumatic heart disease are believed to be a disease of temperate country, not in India. 22 years before the Sepoy Mutiny in 1835, Dr. Malcolmson first recognized one patient of rheumatism among the Sepoys. And a few years later, in 1870, Dr. Moore has found one patient among the Rajasthani Sepoys. He suspected to be a case of rheumatic heart disease, rheumatic fever, but he could not prove it. Later on, in a gazette published in 1910, Rogers indicated only one possible case of rheumatic heart disease among 4,800 postmortem records in 37 years in Kolkata. That was so rare. And again, in 1932, Keats did not find a single case of rheumatic heart disease in 600 autopsies in Amritsar. 3 years later, in 1935, Dr. Wigg first reported one patient of rheumatic heart disease from India. That was the start, 1935. And thereafter, one case, and then around 1950, rheumatic heart disease and rheumatic fever established and considered to be a commonest heart disease in the country at that time. So that was the history. Since then, there is a change. And this is an article from Dr. R. Krishna Kumar. He wrote an article, the last 50 years of Indian Journal of Medical Research. It's a wonderful article. Since then, rheumatic fever incidents were higher side, and gradually there is a declining phase. So initially there is a high. So there is a, in 1972-75, you will get a more incidence. 12 years later, 2.97. Then once again in 2002-2005, there is a declining phase. This is a report from the ICMR published in Journal of National Medical Science in 2009. So gradual decline because of the advent of penicillin all over the world, that there is a decline in the rheumatic fever because the group-A streptococcal infections become well treated. Coming to the present day scenario now, still rheumatic heart disease affects more than 40.5 million people worldwide and results in more than 3 lakh deaths annually. The true burden of the disease is probably underestimated because of the missed diagnosis and underreporting. Over the past 50 years, the disease has almost disappeared from high-income countries. Remember, in our college days, we had taught that the rheumatic fever is a disease of the developing countries, low socioeconomic countries, and still it is persisting. And average annual incidence in the high-income country is lower, but still remains to be a major cause of mortality and morbidity in a low socioeconomic country like India. It's a wonderful publication there in Lancet. The Indian state-level disease burden initiative collaborators, they have published this in 2016, and they have presented the pattern of cardiac diseases over the years from 1990 to 2016. And they have shown that majority of patients are suffering basically of coronary heart diseases, ischemic heart disease, stroke, and not rheumatic heart disease. And if you enlarge the portion of rheumatic heart disease, you can see the state-wise distribution of the rheumatic heart disease. And the Himachal Pradesh and UP are showing the less number of rheumatic heart disease, while Mizoram and Arunachal prevalence is very low. But remember, in West Bengal, in Chhattisgarh, Odisha, the red marks indicated still we are dealing with more number of rheumatic cases. Maybe we are missing. So there is the iceberg phenomena. RSD prevalence estimators are generally based on echocardiographic prevalence. But many cases of acute rheumatic fever are missed due to variable notification and surveillance. So here lies the importance of a pediatrician, because we are in front of this pyramid. This is once again a publication from Raman Krishna Kumar in the Contemporary Disease Diagnosis and Management. He has shown how this pyramid occurs, and in the base portion, there is an asymptomatic RHD who don't have any symptoms. And gradually, the symptoms are there, and also the patients are having more echocardiographic findings. So on the higher side, it is easier to diagnose, but on the base, it is very difficult to diagnose until we suspect. So from the pediatrician's point of view, our role is much more important to suspect and pick up acute rheumatic fever cases, diagnose cases with revised Jones criteria. The criteria is still there. In 2015, there is a revision, and must do echocardiography at the earliest. I am agree with sir that has told that clinical findings are much of importance, but here we have to go for echocardiography to find out the subclinical cases. And we must remember that the recognition of ARF provides an important opportunity for secondary prophylaxis to prevent progression to RSD. So this was a case recently I encountered. A 9-year-old boy presented the fever for 5 days, and the fever was non-documented. At the time of admission, we recorded the fever, it is 99.5, so less than 38. History of sore throat a few days back, as the child told us. There's an infective skin lesions also present over the legs, you can see. And there is a definite polyarthritis. It was a migratory. You can see the elbow and shoulder, they're also swollen. But there is no cardiomegaly and no murmur on auscultation. Since there's a history of sore throat, we are suspecting in this case to be a rheumatic fever. But there are also other diseases which can present to the arthritis. some reactive arthritis, some viral arthritis like parvovirus infections. Systemic JIA may present like this. So there are some mimickers, but still we have to find out whether this patient is having a rheumatic fever or not. And for matching, we have revised Jones criteria. The recent criteria, nothing changed, but only two things are changed. One, echocardiography diagnosis for subclinical carditis. That is there in this new guideline. Previously, it was not there, but they have given more impetus on this echocardiography finding and different criteria based on the underlying population at risk. So they have divided low risk population and moderate to high risk population on the basis of the incidence. And see the incidence, if it is less than 2 or less in 1 lakh school children per year, or less than or 1 or less out of 1,000 population of all age, then it will be as low risk population. And anything more than that will be called as moderate or high risk population. So on the basis of that, the revised Jones criteria has modified accordingly. So you see the major criteria is divided once again in low risk population and moderate high risk population, and minor criteria similarly in 2 groups. The most notably finding is that in the low risk group arthritis, only polyarthritis is considered. But in the moderate and high risk group, polyarthritis, monoarthritis, even polyarthralgia are also included. So polyarthralgia is a major criteria now. So it happens that many patients comes to us to visit the pediatricians having joint pain. Mostly they have been responding well to some commonly used drugs like ibuprofen and paracetamol, and the patient resolves, and we may miss certain patients of acute rheumatic fever. Other findings are also there, but in minor criteria also, particularly in the moderate and high risk population, monoarthralgia is kept as one of the minor criteria. So pain in only one joint. So that means we are to be very much vigilant to suspect acute rheumatic fever. So any patient with arthralgia, we have to send the patient for echocardiography to find out any subclinical carditis. This is the lesson of the day. And you know, the ESR and CRP, there also, it was previously, but now it has been marked that ESR should be at least 30 and CRP should be at least 3 milligram per DL. Now with this, we have essential criteria also, that is ASO more than 1:330 in children from the end of first week, reaching the peak by 3 to 6 weeks. And it is more elevated when there is a throat infection rather than a skin infection. Anti-DNSB is also there, but sometimes anti-DNSB is not done in our common laboratories. Now comes the newer days, that is a streptococcal RT-PCR. So after this COVID pandemic, 3 years COVID pandemic, many centers are well developed with RT-PCRs. So streptococcal RT-PCR could be a very easy diagnostic procedure in the next few years. So people are working on this. I think researchers are coming nowadays, and we'll get in 2 to 3 years, streptococcal RT-PCR will be there. So investigation done in our patient. Our patient had ASO titer high, 1:400. ESR was borderline, low, that's a 20, low. CRP was high, 22.6. And there is no prolongation of PR interval in the ECG. Here, ESR, CRP, you know, the very non-specific inflammatory markers. And so we need to have some specific biomarkers. The very recent study we have found, published in BMJ Open Journal in 2021, they are searching for technology-driven acute rheumatic fever tests. So new tests are coming in the next 5 years, 6 years. Some tests will be there. That will be the untargeted immune phenotyping, transcriptomic, proteomic, and metabolomic profiling in patients with ARF in currently underway. So these tests are coming, the new generation tests. But what happens to our patient? Our patient, since it's a moderate and high risk population, we found only arthritis. There was a polyarthritis definite. And since we have not done any echocardiography, you cannot say subclinical carditis. Let's see in the minor criteria, CRP was positive. Fever was maybe it was higher in the initial period, but the parents didn't document the fever, so it was not considered. So we are now one major and one minor. We are not getting two major, so we need to have an echocardiography now. And regarding echocardiography, auscultation is less sensitive than echocardiography for diagnosis acute carditis of RSD. So this is a study published where echocardiography has got some edge over the clinical findings. And it is there essential to pick up the subclinical carditis and helpful in diagnosing latent rheumatic heart disease. That is the issue. Patient may be having some asymptomatic patients, may be having valvular involvement that could be picked up by the echo. So this is all known by the pediatric cardiologist. This is the new guideline by the revised Jones criteria that Doppler findings are included. They have specified pathological MR. All four criteria should be made. In pathological AR, all four criteria should be made. They must be seen in at least two views. Jet length in both cases should be at least 2 centimeter, at least one view. Peak velocity should be more than 5 millisecond. And in case of MR, there should be pansystolic jet, and in case of AR, there should be pandiastolic jet. Pediatric cardiologist, my brother Anil is there. They are regularly doing echocardiography in these patients. They are well conversant with this. But the problem is the limited access to echocardiography in low resource countries like ours. We are practicing in Diamond Harbour Government Medical College, where echocardiography facilities are not always available. So we need to have some less expensive handheld equipments. Some studies are coming. And brief training of non-expert health practitioners. So there are studies, they have done studies between the controls and case, and they have shown that even the non-expert people are doing very well. Not a good news for Anil. If you learn echocardiography and at least screen, but no, it will not replace the specialist. It is just for the screening purpose to find out whether the patient is subclinical carditis or not. Then we can refer the patient to for the specialist opinion. And there should be abbreviated echocardiography protocol. The publication is there in the cardiovascular imaging by Francis Jayer in 2021. They have published this data by head-to-head study between the non-expert and the expert by doing echocardiography. So treatment purpose, there is no new advancement. The same that was taught in our college days, that is a streptococcal A eradication, management of arthritis, carditis, chorea, and initiation of secondary prophylaxis. That's very much important. And no convincing evidence for effective disease modifying agents. Since it's an autoimmune disease, since it's a multi-system disease, I was very keen about this DMRD. But no studies are there to find out any DMRD is helpful in this disease. And the treatment of arthritis, the doses, high dose, initially when we were two students, the doses were 75 to 100. But the dose now is at least 50 to 70 milligram per kg per day in 4 divided dose for 3 to 5 days, followed by 50 milligram per kg per day, another 2 to 4 weeks. And then gradually tapered off 25 to another 4 weeks, another 2 to 4 weeks. Total 12 weeks treatment schedule is usually helpful. And whether aspirin is only drug or any other drug we can give, the recent data says, that is published in January 2020, very recent data, effectiveness of safety of ibuprofen. They also, another study where naproxen is also another good drug, which can replace the aspirin. Similar time of resolution of symptoms and normalization of inflammatory markers, but fewer side effects compared to aspirin. So ibuprofen and naproxen may replace aspirin. So that happened in case of patients coming from the outskirts. They have been treated with ibuprofen, all symptoms gone. So we may miss those patients with acute rheumatic fever because ibuprofen is a very good drug. Now, role of corticosteroid in carditis. It is age-old teaching that carditis severe carditis must be treated with a steroid, particularly life-threatening diseases where surgical intervention not indicated or not available. Dose remaining the same, 2 milligram per kg per day in 4 divided dose for 2 weeks and half the dose for another 2 weeks, taper gradually. To add aspirin, 50 milligram per kg in 4 divided dose after 6 weeks. While tapering the corticosteroid, add the aspirin. That was the age-old teaching is there. But whether corticosteroid is at all effective, one study by Anthony Tessillers published recently in 2015, corticosteroids are often used for treatment of severe carditis or chorea, but limited evidence. Evidences are very limited. A meta-analysis including 4 randomized controlled trials found no evidence of benefit administering steroid. Data is not supporting steroid, but still we are using steroid. IVIG? No. Since it's an autoimmune disease, probability of IVIG could be there, but no studies have proven the role of IVIG. Sydenham chorea, there are certain drugs like valproic acid, carbamazepine, olanzapine, levetiracetam, risperidone, all are used. Corticosteroids are also used, but more studies are required to make those drugs established. And now the secondary antibiotic prophylaxis. This is the 2009 criteria. We all know this. That is, without carditis, 5 years or until the age of 21 years, you have to continue. If the carditis is there, but no residual heart disease, then it's the 10 years or 21 years, whichever is longer. If the residual heart disease is present, 10 years since the last episode of recurrence or until age 40 years and possibly lifelong. And in case of severe carditis and after valvular surgery, lifelong prophylaxis is mandatory. And regarding the secondary prophylaxis in the latent heart disease, those who are not having any symptoms, and one RCT done in the Ugandan children in adolescents between 5 to 17 years, this is basically a GOAL study, GOAL, GOAL study. And they have shown that secondary antibiotic prophylaxis reduce the risk of disease progression at 2 years. Just see comparison, the control and the prophylaxis. So there is a significant value, that is the p-value is less than 0.0001. So even if you add prophylaxis to latent heart disease, there is a benefit. So there is an importance of echocardiography once again to find out whether the patient is having latent heart disease or not. So now coming to our patient now discharged home, is now fine, responded dramatically to aspirin, received primary treatment with penicillin, single dose benzathine penicillin. Corticosteroids were not given since it was only a subclinical carditis. So we have just found a few mitral valve deflates. There's a delayed movement. As Dr. Devdatta was there, Devdatta could do the echocardiography and told me that, sir, this patient is having some carditis. But still the carditis was not that much. So we only given aspirin and patient responded well. Secondary prophylaxis done and counseling done and follow-up advised. So the take-home message. Acute rheumatic fever and RSD are still significant burden in India, but neglected. Pediatricians need to be vigilant in suspecting the cases. We are missing those patients and we are falsely diagnosing those as reactive arthritis. Simple viral arthritis, because parvovirus can cause arthritis. One patient came with the knee joint arthritis a few days after giving ibuprofen, patient responded. No one took the history of these throat infections and no one did the ASO or any echocardiography. So we missed the subclinical carditis. Maybe the patient will again come once again after a few years with more serious disease. So all arthritis and arthralgia cases must undergo echocardiography to spot the subclinical carditis. This is a request to all pediatricians to send for echocardiography. Widespread training of echocardiography is required to identify the acute rheumatic carditis. This is the administrative part to train the echocardiographies. Secondary prophylaxis to start at the earliest for the asymptomatic and latent RHD to reduce the risk of disease progression. Thank you for patient listening. Thank you, sir. Thank you.
Thank you, Dr. Sharkar, for a wonderful presentation and also finishing in time. As we have multiple speakers, I thought maybe we can quickly take a few questions on this regard. First of all, I would like to I'm really happy that you have taken up this topic, because now with conversation about Kawasaki predominating a cardiac disease in children, I think we're really neglecting rheumatic heart disease. So with any child coming with arthritis or arthralgia, like you said, with the revised Jones criteria, I think we should really need to put them in the Jones criteria and find out whether they're having rheumatic, and also post-streptococcal arthritis, which very often mimics very close mimicker, and we need to really decide on long-term penicillin.
Now,
So any
in case of,
questions from the, yeah.
In case of post-streptococcal arthritis also, the recommendation is up to 1 year, you should go for regular echocardiography to find out whether the patient is having cardiac involvement. That is the recommendation is there. In PSRA, post-streptococcal arthritis, though the arthritis pattern is something different, the small joints are more involved, is not well responding to aspirin. So those patients are recommended to be having this echocardiography done regularly to find out whether the cardiac involvement is there or not. So that is the recommendation is there.
So, Doctor, any questions? Yes,
Yeah,
please.
I have a question for Dr. Sarkar. I really enjoyed your talk. It was a brilliant presentation. I wanted to ask you a couple of things. One is about, there are a lot of, if you take 100 patients who get rheumatic fever, it's not necessary that all of them go for rheumatic heart disease. Some of them we see the clinical practice, because I'm a cardiac surgeon. I see the very young patients with a severe rheumatic valvular disease, which may be even under 10. There are a lot of patients who come with a failure and they have established rheumatic valvular heart disease. So is there any genetic predisposition that out of the patients who get rheumatic fever, how many of them are going to get into rheumatic heart disease? Is any evidence there in the literature?
Sir, it was, I am agree with you that all patients with acute rheumatic fever will not residual heart disease. That's why there is a difference in the secondary prophylaxis. I have gone through a few literatures that I have not found out any particular genetic sequence that is responsible for this acute rheumatic fever to go into our heart disease. I think it is basically that depending on the particular involvement, so depending on the autoimmune response. The autoimmune response varies among the individuals. Even of the same antigenic challenge, the immune response may vary. Since it's an immunological disease, the immune response depends on the patient's own immunological status, maybe related to the genetic, some hereditary or genetic, but I have not found out any.
I had come across some of those papers which came from Latin America, like Brazil and those places. So they had identified a few subsets of those.
Yeah. Some patients in also in Uganda, they have studied Uganda because they have found more number of patients are suffering there. So maybe the reason there is some genetic predisposition is there.
And is there any work or any work being done or has been reported, anything that's in the direction of developing vaccines so that you can prevent rheumatic heart disease or in the patients with a rheumatic fever?
So I don't get your question, sir.
Is there any research work or is there any clinical vaccine for such patients in order to prevent development of rheumatic fever or even the rheumatic heart disease?
Vaccines against streptococcal infections.
Yeah, definitely, vaccines are coming. Vaccines will be there. So vaccines may prevent. Since you see the incidence gone down, prevalence gone down. As you see the data from several countries and also from India that is published in Lancet, the incidence and prevalence according to the disease-adjusted daily life, prevalence is lower. But our point is whether the decline is true or not, whether it is because of underreporting, because of neglecting, the incidents are coming down. So that's why the revised Jones criteria has given more stress on finding out those patients with the subtle symptoms like monoarthralgia, polyarthralgia. so that the screening might be much more stringent to find out those patients.
Yeah, incidence is coming down. The reason I'm telling you that because I post-graduated from CMC Vellore, and that time majority of the patients who came for rheumatic valvular heart disease operation, they used to come from the eastern part of India.
Yes.
And down south, Sri Chitra, they also used to get some of the patients who used to percolate. Now they are saying that the pattern has changed completely. It's more like a Western disease, or valvular heart disease is more like a Western disease. Degenerative are more common.
Yes.
Rheumatic have disappeared. So basically, it's entirely, as you said, the socioeconomic status of the society that's influences the thing.
Next question.
Thank you, sir. On you.
Very nice question. I think, and Dr. Sarkar, he's my senior. I congratulate. He has very nicely summarized the whole thing, a difficult subject. Regarding this question of whether immunological basis, yes, genetic immunological basis may be prevalent, a big chunk of these patients to us coming from Jharkhand Giridih belt, 8-year, 9-year child getting complete destroyed valve, and juvenile rheumatic is very common. Rheumatic valvular disease. Double valve replacement we had to do at 11 years of age, which I was not heard of when I was in Amrita. So that zone, Waynard had more incidence at that time. There is definite possibility of this genetic linkage, undetected multiple episodes of rheumatic, and that is leading to destruction of the valve in very young age. So community specific, this genetico-immunological influence is high possibility and research going on. Second, vaccine, we all know multiple serologies are there, difficult to develop a vaccine. Work is going on, but still it is not in very successful. Possibly in near future we'll get as we evolve. Very nice one. Your presentation. Thank you.
And the socioeconomic condition in Jharkhand and the Bihar, you see, are maybe the from the families the patients are coming, maybe that overcrowding and all those risk factors are also prevailing that we cannot defy.
There in other part also, but that particular belt has the maximum incidence.
So we need a research there.
We need, correct. We need to research. Thank you.
Thank you. Thank you. Thank you.
There are no further questions. Thank you, Dr. Sarkar, once again, and we can move on to the next speaker.
Thank you.
Yes, thank you, Dr. Sarkar, Professor Dr. Sarkar, sir, for the nice presentation. So it's a very nice discussion with upcoming evidences. So now we are already running short in time. So now, without wasting much time, I'm introducing my the next speaker, Dr. Satyabrat Roy Choudhury, Assistant Professor and Pediatric Intensive Care Unit in charge of North Bengal Medical College, Kolkata. He will be talking about the myocarditis in children and what's new about the issue. So, Dr. Sarkar, over. Dr. Roy Choudhury.
Very good morning to my respected teachers, my colleagues. I am here to give my talk on myocarditis and what is new in this subject.
ল্যান্ড করা আছে
So with permission for my chairperson, I'm starting my talk. So we are here to discuss myocarditis. So myocarditis is not very uncommon in our pediatric emergency scenario. It traditionally has been defined as disease of myocardium, and that is diagnosed by histologically. But there is a paradigm shift in the diagnosis of myocarditis with advancement of cardiac MRI, and now we are relying mostly on cardiac MRI because histologically taking cardiac biopsy is not always feasible and it is not always done. So if we go for epidemiology, the prevalence is 0.5 cases per 1,000, but this data is not very uniform in all studies because there is a wide variation in presentation and there is no such clinical criteria for diagnosing myocarditis. And sudden cardiac death is a manifestation of myocarditis. These all factors are confounding this incidence and prevalence data. So what are the main causes of myocarditis? As we discussed, these causes are infectious agent primarily, but there are also some autoimmune diseases, hypersensitivity, and toxins. So among the infectious agents, adenovirus and enterovirus like Coxsackie A and B, parvovirus, ecovirus, and polioviruses are one of the most common ones. So now we are going through a very common case, which many of us have seen in our emergency. A 3-year-old female baby presented in emergency with cough and cold, low-grade fever, and for last 2 days, lethargy. Well, for last 2 days, he is having lethargy, poor feeding, breathing difficulty, grunting, low volume pulse, 180 per minute, bilateral wheeze, crepitation, soft palpable liver for 4 centimeter, and SpO2 with 8 liter of oxygen by face mask is 96%. So it is clearly a case of heart failure, as there is palpable liver, there is crepitation in the chest, breathing difficulty. So as we are diagnosing it as a acute heart failure, as the child didn't have any previous history of any cardiac disease, or he is not a patient of any congenital heart disease. So this is one of the most common presentation of myocarditis, acute heart failure in a child who didn't have any previous history of cardiological diseases like congenital heart disease or other acquired heart diseases. So there are other presentations like sudden cardiac death I have mentioned, and myocardial infarction, like patient can present with chest pain and elevated markers of AMI, and palpitation syncope may be patient may be a presentation due to myocarditis is always associated with different types of arrhythmias and ventricular arrhythmia and complete heart blocks. So we are back to our previous case, and this child was shifted to PICU and respiratory support was provided with 1.5 liter per kg flow with high flow machine, and blood investigations were sent, chest X-ray and ECGs were ordered. So what we will get in chest X-ray? In case of myocarditis, lots of informations can be gained from these basic investigations like chest X-ray and ECG. In chest X-ray, usually we get cardiomegaly and parahilar bat wing signs for pulmonary edema. And in ECG, usually we get non-specific ST changes, and there may be associated with lots of arrhythmias like bradyarrhythmia, tachyarrhythmia, atrioventricular block, prolonged QT intervals. These things can be present in ECG. So along with ECG and X-ray makes a very good sensitivity for detecting myocarditis. Now, next thing is echo. Echo is very good to pick cardiac dysfunctions. In echocardiography, increased ventricular end systolic and end diastolic dimensions, reduced shortening and ejection fractions, atrioventricular valve regurgitations, and regional wall motion abnormalities are features of myocarditis. And cardiac MRI, as we have discussed, it is emerging as one of the gold standard investigation for detecting myocarditis. We can rely on it. There are few signs we can get in T2 weighted image. We can pick early enhancement, which is usually seen within first 4 weeks of clinical presentation. It detects myocardial edema. And in gadolinium and late enhancement, if it persists beyond 4 weeks, it usually implies myocardial infarction and fibrosis. This late enhancement usually correlates well with persistence of symptoms beyond 30 days. So next important things are biomarkers. In case of myocarditis, where lots of people are using these biomarkers very frequently, but we have to remember cardiac troponin T is more sensitive than creatinine kinase, but this troponin T, it doesn't correlate with this echocardiographic findings. And then elevated N-terminal pro-BNP usually is a very good sensitive marker, and it correlates with very good with echocardiographic finding. But we have to remember this pro-BNP is a marker for heart failure. It is not specific for myocarditis. Acute heart is a marker for acute heart failure. So coming back to our case, this is the X-ray we have done. This is showing cardiac enlargement with signs of pulmonary edema, and this X-ray is showing some ST changes, which are more suggestive of myocardial involvement, myocarditis. And this is the echocardiography. You can see the cardiac contractility. This is done bedside. This is not done by expert expert cardiologist. It is done in our ICU by bedside procedure. And just visually, you can see that the cardiac contractility is not good. So this visualization is very important, because in acute situation, we are not always able to send the patient to a expert to get an expert echocardiography. Now, another thing is this lung USG. This lung USG, you can see this pulmonary edema. This is also a bedside procedure. This can be done very easily bedside, and it can pick up pulmonary edema very quickly. And this can be done repeatedly, so it can guide your therapy also. And pro-BNP was done, and it is high. So now this is a diagnostic algorithm for myocarditis. Here, now where we stand, the patient has a recent history of heart failure and didn't have any predisposing congenital heart disease or other coronary abnormality or familial cardiomyopathy. So we are suspecting this is a case of myocarditis, and we have done ECG, and ECG showing ST changes, and there is also echocardiographic changes like left ventricular dysfunctions. So this is a suspected case of myocarditis. Now, if we have to confirm this, we have two options. We can go for a cardiac biopsy, which is not feasible always, and it is very invasive procedure, and patient may not be prepared for this thing. And there is an alternative for that, that is a cardiac MRI. If it is feasible, affordable, and available, we can go for that. So this is the cardiac MRI picture, and you can in the A picture you can see the early enhancement and cardiac left ventricular edema, and in the D picture you can see the gadolinium enhancement, that is a late enhancement. Okay, so the current status of our child after after shifting the PICU, the resident noted that child didn't pass urine for last 6 hours. Pulse is feeble, heart rate is 190 per minute, BP is low, and some resident decided to give a bolus 10 ml per kg. Now, this bolus is indicated or not. If you are sure with your diagnosis that myocarditis, you should not give a bolus to this child. But sometime in emergency situation, it is not very easy to pick up myocarditis because most of the children present like a case of viral pneumonia or bronchiolitis. So you can miss it. So if you are suspecting a child having heart failure or not, you are confused, so you can give a trial of slow bolus. You can give a very small aliquot of bolus, 5 ml per kg, for a long duration with the monitoring of clinical signs to see fluid responsiveness. If the child responds, then you can give more. But if the child is decompensating with this small bolus, you should not go further it. But if you have some advanced equipments like USG, bedside USG, you can always take help of it. You can do a bedside echocardiography for seeing the cardiac function. You can see the IVC, and you can always see the pulmonary edema in lung USG. So maintenance fluid has to be given, and it is usually restricted to 50 to 60%. So now comes to it is time for the starting an inotrop. So BP is low, so we have to give some inotrops. Ideally speaking, in case of myocarditis, the ideal inotrop will be milrinone. But milrinone is usually causes a vasodilatation, and it may further lower the BP. So usually what we try in our practical situation to lift up the BP for an acceptable BP. I'm not saying some target like 50th or 90th percentile. I'm just saying about an acceptable BP. What do I mean by acceptable BP? That BP that can maintain a minimum urine output 0.8 to 1 ml per kg per hour, and your clinical signs like peripheral temperature, pulse rates are going down with it, so you are happy. So to achieve this, you can start adrenaline, and sometimes we can start noradrenaline or vasopressin, but it has to be started in very low dose, not very high, because these drugs works by increasing afterload, and too much afterload will be detrimental for the heart. So minimum doses of adrenaline, noradrenaline, or vasopressin, sometimes we combination these drugs, not going for one thing too high. We usually use 2 to 3 drugs at a time to have a minimum acceptable BP. And after achieving that, our aim will be to start milrinone. But before milrinone, sometimes we start dobutamine, because dobutamine has less effect on BP lowering effect. So if we are too much worried about the blood pressure, then dobutamine will be first choice. Then we can add on milrinone to it. Now, another drug is levosimendan. It is a very good drug. It has a very well tolerate. Patient will tolerate very well it. But pediatric data is not much, and there is no head-to-head trial of levosimendan and milrinone saying which one is better. So we are not recommending it at present, but in future we may recommend it. So now we are back in our case. We have started adrenaline in our child. It is a 0.1 microgram per kg per minute. The respiratory rate, but what happened? Maybe due to bolus, respiratory rate has increased, and now we have to do something for it. So child is in distress, we have to reduce distress. We have two options. Either we can intubate this child, or we can put this child in NIV infusion. So what will be our choice? So as per the recent data, NIV works very good at heart failure, and it can prevent need of intubation and ventilation, and it can reduce, if it started early, it can reduce mortality also. So obviously non-invasive ventilation is first choice, and we have to remember during intubation we have to use some drugs that can lower BP and decompensate the child further. So NIV is always natural first choice. But if the child not tolerating NIV, or the child is not improving on NIV, we have to go for intubation. giving NIV is to avoid intubation, not to delay intubation. Okay, when intubation is needed, we have to intubate this child, and to intubate we can use etomidat. It has a very good hemodynamic profile, and if the child BP is low, we can use ketamine due to its sympathomimetic effects. Now, if we are ventilating this child in NIV or invasive ventilation, what will be our PEEP? So the PEEP has a very complex relationship with the heart cardiac output. In both ventricle, it affects differently. So what happens if we are looking at the first picture, you can see this is in case of positive pressure ventilation, left ventricular transmural pressure decreases. So what happens? The left ventricular output increases. The next, the lower picture is showing that if we are using positive pressure ventilation, it will reduce right ventricular right ventricular preload. So that will ultimately reduce right ventricular output. The corner picture is showing how this pulmonary vascular resistance is related to the PEEP. If the lung is collapsed, the pulmonary vascular resistance is high, but lung is over-distended, then it is also high. So optimum PEEP is very important. When we are ventilating a child with heart failure, we always don't try to ventilate this child on high PEEP. We usually try to achieve optimum PEEP, and that is also in lower side. So back to our child. The child was put on NIV PS mode ventilation with PEEP of 5 and PS of 12, and midline was started 0.25 microgram per kg per minute. With this, BP improved 74/40, and urine output is also 0.5 ml per kg per minute. Now, next step is preload reduction. That is also very important. We have to start Lasix. We know Lasix is the drug of heart failure. But when we start Lasix, because the child is having low BP and we are giving lots of inotropes, so we have lots of fear to start Lasix. But we should not fear. Whenever we are able to hemodynamically somewhat stabilize the child, we have to start Lasix. This Lasix will improve the child further. Okay. So what is the mode of starting Lasix? It will be bolus or continuous. The trials have not shown any benefit in these two modes. Either way you can start, but it is believed that continuous infusion, in continuous infusion, BP fluctuation is less. But it is a belief. There is no data behind it. So I am always speaking about acceptable BP and acceptable hemodynamic parameters. But on clinical background, to determine this acceptable BP and acceptable clinical parameters is not always very easy to get. So we have to rely on this downstream markers. So if we're getting the lactate, our child is having lactate is going down, and SCV2 is acceptable, and base excess is going down, then we are happy. Okay, and there is another marker that is NIRS. That is a surrogate marker for cerebral oxygenation, and it is a surrogate marker for mixed venous saturation. But pediatric data on this is lacking. So another important thing is in our pediatric ICU we are using this thing. This is PICO monitor. This is a wonderful machine. It can show the cardiac output. It can show peripheral vascular resistance, and it can show preload markers like extravascular lung water index. So if we are getting these parameters directly from the patient, we can regulate our therapy on the basis of this. Suppose the cardiac, if we increase the cardiac contractility, we can use inotropes. To reduce preload, we can use Lasix and other drugs, and to reduce So this machine usually uses two methods to detect these data. They usually use arterial pulse contour, and by these two methods, it usually detects these parameters. So after 8 hours of admission, our child is having MAP of 55, urine output is 1 ml per kg per hour. Initial lactate was 8, after 6 hours it is 3.5, and base excess is minus 3. So we are happy with this patient. So happy that doctor and happy patient at present. So now we have to think about adjuvant therapy. So when if anticoagulant is indicated in this patient, so there are very specific indication for anticoagulation in case of myocarditis. If the cardiac left ventricular ejection fraction is less than 20%, or there is some arrhythmogenic, there is a thrombogenic arrhythmias like atrial fibrillation and other things, or there is visible thrombus in the heart, we have to start anticoagulation. Otherwise, not. It is not indicated generally in all patients. Okay. Immunosuppression. Immunosuppression in form of prednisolone with or without azathioprine and cyclosporine. Different studies have been done on this, but till date there is no evidence to support this type of immunosuppressions in case of myocarditis. But steroid has been given in myocarditis, especially in COVID era when we are dealing with MISC, and if it is associated with SLE or other things. And sometimes in case of IVIG resistant myocarditis, we use steroid in desperation. It is not based on evidence. So another thing is immunomodulator, that is IVIG. If we go for a Cochrane, Cochrane review is saying that there is no sufficient data to support the use of IVIG. But a recent meta-analysis has supported the use of IVIG in patient. So in practice, we are practically using IVIG in myocarditis, and dose is 2 milligram per kg. But we have to remember this 2 milligram per kg, 2 gram per kg, and 2 gram per kg IVIG is a lot of volume. So whenever we are giving this patient to a heart failure patient, we have to look for the fluid decomposition signs. Okay, and we have to give it for a long time and slow and divide it. Okay. So now, if in our patient we have seen the patient responded with this conventional therapy, but it is not expected that all patients will respond. If the patient is not responding with these conventional therapies, then we have to go for advanced therapies like VA ECMO. VA ECMO is a good option for these patients, and it has been shown that in short-term course of VA ECMO is very good for very good outcome. But in case of more, if it is given for more than 2 weeks, then outcome is not that good. So it is a bridge therapy. Which if the patient recovers, then it is very good, but it cannot be given for long time. And it has a lot, we have to remember when we are offering this thing to patient, we have to remember this has lots of side effects like hemorrhage and hemorrhage, infections, and there is also chance of vascular injury during cannulations. Another important thing is ventricular access device. These things are now we are using in pediatric patients also, and these early studies have shown they have a very good result also. But pediatric data till now is not sufficient for this thing to recommend universally. So if we think if we have to see the outcome overall, the outcome is not that bad in case of pediatric myocarditis. Survival rate is up at as high as 93% in some studies, and there are some poor predictor for poor outcome also. If the ejection fraction in echocardiography is less than 30%, fractional shortening fractional is less than 15%, and left ventricular dilatation is there, and moderate to severe mitral valve regurgitation, maybe we are dealing with a severe case, and this may have a poor outcome. Thank you.
Thank you, Dr. Raichaudhuri. That was a brilliant presentation. A quick comment on your this cardiogenic shock. I mean, recently we had an MISC with myocarditis where we faced the scenario of how much fluid to give. And very fortunately, we had a pediatrician who knew our bedside echo, and he told us the ejection fraction. He told us about the IVC collapsibility index, and he told us how much fluid to give. So that is the key factor about, in a case of a cardiogenic shock, how much fluid to give, and the USG of the lung showing the B lines. So thank you again, and some quick comments from the floor. Any questions? One question to you. I mean, I know you have said about so many advances in this myocarditis diagnosis, but one clinical bedside, what we used to earlier teach about very muffled heart sounds and low ECG complexes, does that still hold good in the bedside before we go into the advanced investigation? Or
Most of the time, madam, we are seeing this patient in our emergency when we don't have these advanced things. Once we establish the diagnosis, then we are able to access these advanced things. So clinical suspicions and clinical monitoring and clinical accumulations are very important to assess this myocarditis. So these clinical signs are very important to pick up the early cases. Otherwise, we will miss them.
Very small children, especially with bronchiolitis, pneumonias, and they may mimic some myocarditis. So I always tell my students to look at the heart sound, do an ECG, and look at the failure.
That patient with as bronchiolitis.
Yes.
If you don't have a good suspicion for them.
Any questions from the floor? If not, thank you once again, and maybe we can move on to the next speaker.
Thank you, madam. Thank you, Uda.
Thank you, Dr. Satyabrat Roy Chaudhary, for the nice presentation. It was a nice discussion. We have to suspect myocarditis in pediatric ICU. So moving into the next session, the next speaker is Dr. Rohit Bhowmik, sir. Sir is Assistant Professor of Pediatrics of AIIMS Kolani Medical College. And sir, special interest is acute care nephrology, non-invasive ventilation, simulation-based teaching, and infection control. Sir holds a lot of grants and publications and awards and achievements. So I'm requesting sir to for the next talk. Sir will be talking about heart failure in children, what's new. Over to you, sir.
Good morning, all. At the onset, I'd like to thank Pediatric Cardiac Society of India for giving me this opportunity. And a special thanks to Mihir sir for giving me this topic, which is very close to my heart. And when I thought how to approach this topic, it's vast and many part is there, like medical management, mechanical management, surgical management. But my talk has been made easy by my previous speakers, Lopadi and Munidipadi, and also few parts will be covered by Soman sir, like the arrhythmia in the subsequent talks. So the objective of the talk will be like we have to understand the basic pathophysiology. Whenever we plan any management, the underlying basic pathophysiology is important. I will cover mostly on the pharmacological agents that have been few are evidence-based, few are in the pipeline, and further studies are ongoing. Other non-pharmacological options, and as we discussed in previous talks also, that the timely referral to our surgical colleagues is important, especially in congenital heart disease. So when to seek help from other team members, and a few research options. So when we start planning our treatment, we have to understand a brief of pathophysiology that we already known. Before going to the pathophysiology, we have to know that what do you mean by heart failure? It's just a abnormality of either structure or function or both, that ultimately leading to improper delivery of oxygen to the tissues. And in pediatrics, this chronically disturbs the growth of the child, and in many cases, the future development of the brain if chronically these patients are under oxygenated. The major causes have been discussed already. It is either structural or secondary cardiomyopathy, either due to infections or storage or infiltrative diseases. So as the cardiac output decreases, there are many physiological compensation starts in the body, like the activation of baroreceptors, activation of sympathetic nervous system. This ultimately lead to, this tries to compensate, but in the pathway, this leads to remodeling of the heart, myocardial toxicity, apoptosis, scarring, and remodeling. So when we choose a particular pharmacological agent, we have to think that how to prevent this vicious cycle, how to halter this vicious cycle, how to prevent the progression, and is there any way to revert back which has already been done, like the remodeling or scars that already been done. Can we remodel this? And in pediatrics, the drugs or the pharmacological agents or further therapies depends on which stage the patient is coming to us. For classification of this illness, we have established Ross classification. The class 1 is asymptomatic, the class 2 mild tachypnea, and in an older child, dyspnea on exertion. In class 3, this is the stage where actually growth failure starts happening. And here in older child, we have marked dyspnea. And to remember stage 4, here the distress is at rest. All the problem, the tachypnea, retractions, grunting are there even in rest. When we have to choose the drugs, many a time we see the patient which stage they are. Another model is this perfusion and congestion model. This model is especially important when we are managing acute heart failure patients in pediatric ICU or cardiac critical care unit. Here, the target is to achieve this warm and dry state. The patient can be in either poor perfusion, can be in optimal perfusion, but with features of congestion due to back pressure. The target will be in this stage. This, again, I will discuss when we are managing acute heart failure. The causes already being discussed, like congenital heart disease and when to operate. This has been already done by previous speakers. The second important is the other causes that a pediatrician must be aware of, like post infections, post myocarditis that have been discussed previously, storage disease, few deficiencies like as common as vitamin D deficiency, which can lead to hypocalcemia and further cardiomyopathy. These are correctable factors. These are correctable etiologies. If we correct these simple etiologies, we can prevent progression and we can prevent hospitalization and further worsening of illness. Next, what are the goals when we think how to optimize? Obviously, our target will be to improve hemodynamics, to prevent progression, to prevent the progression of remodeling. And at the bottom, our target is to allow optimum growth development, to improve survival, to prevent recurrent hospitalization if we are unable to treat the etiologies like many a time like cardiomyopathies, where the options are transplantation due to resources or due to non-availability of heart. We have to just manage them in a conservative manner. So we have to prevent further hospitalization by simple modification of some correcting factors. The principles lies as in other diseases, like basic optimization of oxygenation, oxygen support by simple nasal mask, and if required, like nasal prongs, if required, non-invasive therapy, or further intubation and mechanical ventilation, as has been discussed in myocarditis session. The other thing is supplementation of nutrition, micronutrient deficiencies. It is not in all cases. Suppose a patient is having established anemia or established deficiency, hypocalcemia, or in some metabolic diseases like fatty acid oxidation defect, where supplementing carnitine has some role. So no need to give in all cases, but in case-to-case basis where there is obvious deficiencies. Then precipitating factors like infection, active myocarditis in a known heart cardiomyopathy patient, prevention of rheumatic activity in a valvular heart disease, already established valvular heart disease, specific measures like antiarrhythmic drugs, which we have in next session by Soman sir. Then the most important drug therapy, we have our age-old conventional pharmacological agents and few newer drugs which are coming, which are mainly based on adult literature, but newer studies on pediatric populations are also coming. And then other surgical or advanced mode, which is beyond the scope of this discussion. So as Sushmita ma'am asked in the first session that how you optimize fluid and nutrition, because the optimization of nutrition depends on fluid balance, because majority fluid, majority feeds, or in acute setting, the fluids has to be considered when you are giving the feeds. And we have to assess the fluid status at admission in ICU or in chronic patient when we are giving the titrating the drugs plus feeds. We have to prevent worsening of fluid overload. And in acute stage, we have to give a low sodium diet and proper calorie protein we have to calculate, like in younger infants 100 to 150 kilocalorie per kg, in older children like 50 to 70. The calorie is calculation of proper calorie and protein is must as a pediatrician, and also when we are managing heart failure patients, because these things are important for growth. And thickening of feed, adding calorie dense materials like MCT oils are important when we are writing the nutritional plan for this child. And as we discussed, no role of routine micronutrient supplementation, but yes, if there are deficiencies, features of deficiencies are there, we have to supplements like even in thiamine deficiency can precipitate heart failure, carnitine deficiency can precipitate heart failure. To correct anemia or iron deficiency, this is very common in our setting because of poor nutrition. So at the time of diagnosis, we have to check the hemoglobin level, and also in time to time when we are managing chronic patients, we can do iron studies to see the storage, because they may have other causes of anemia like anemia of chronic disease. Some cases, like especially if patients have heart failure and other organ damage like CKD patients, may not improve on oral iron therapy alone. So you have to consider IV iron therapy also. And transfusion strategies is depend on the TAXI guidelines that is published in PCCM few years back. Here, in cardiac diseases, our target is to keep the hemoglobin around 7 to 9 in uncorrected congenital heart disease. And different palliations or different stage of palliation therapy has different set of criteria, like hemoglobin of 9 in the stage 1 single ventricle repair and so on. So in other cases, uncorrected cases, we will keep restrictive strategies of transfusion. We'll keep around 7 to 9 hemoglobin by correcting iron deficiency and other correctable factors. As a pediatrician, also our role to optimize immunization as like any other child. But in heart failure patients, we have to give concern and few of the immunizations like pneumococcal vaccines, annual influenza vaccines. These vaccines not only for the patients but also the caregivers, because if the caregivers affects with these diseases, they can transmit the infection and can causes further worsening of these patients. They are prone for hospitalization, recurrent hospitalization, even if kept untreated. So in hospital for these patients, if possible, we have to keep separate policies to prevent infections, like as less as possible invasive lines, and to prevent hospital-acquired infections as much as possible. When we plan this pharmacological drugs, we all know our target is to optimize cardiac output. And how to do this? To either alter preload, afterload, reduce the afterload, increase the contractility, or in in combination of all these things. So what are the options we have? Our AC inhibitor is age-old drugs. Maybe still it is first line therapy. Second options are beta blocker like carvedilol, metoprolol. Spironolactone in the later stage, diuretics only if there is a features of fluid overload and there is no hypotension. The commonly used drugs are enalapril, which we have to start in low dose and gradually titrate to upper doses. And it helps by blocking this vicious cycle, as we discussed in the first slide, that the pathway of renin-angiotensin-aldosterone system. And one of the common side effects are worsening of renal function, hyperkalemia. So when we are selecting these agents, we have to look for the comorbidities associated, any side effect, they are prone for any side effects or not, and any further organ damage if they are not. Next option is spironolactone. It again, in this agent helps in progression or the worsening of remodeling and also prevents remodeling, and sometimes it reverses the remodeling. And the side effects we know, like hyperkalemia. If sometimes we use in combination with AC inhibitor, they can develop very high chances of hyperkalemia. Beta blockers studied in there is recently published Cochrane review. They showed some efficacies over long-term survival of chronically cardiomyopathy patients. The commonly used drugs are carvedilol or metoprolol. They have not only vasodilatory property, they control the heart rate, and we know that the diastolic function as well as the coronary perfusion depend on heart rate. So severely tachycardic patients, there may be myocardial perfusion alteration, especially in chronically heart patients. So the abnormally high heart rate is also detrimental for a fatigued or a heart failure patients. So these drugs also helps in controlling the heart rate. Diuretics, these are only in transiently used, especially if there is a congestion, back pressure, fluid overloads are there. We can use intermittent dose. In ICU, if there is a features of significant congestion, we can use these drugs as a continuous infusion. Though there is a no added advantage of intermittent versus continuous infusion dose. Sometimes we need refractory, if their drugs are refractory to oral therapy, we can use intermittent IV therapy. Digoxins, because it is a very narrow therapeutic index drug, only used as a rescue therapy. It also per se is arrhythmogenic. And as the newer guidelines are coming, the role of digoxin is coming down. These are the common traditional agents we known and we used previously, and any other newer drugs are coming up. This is the microcellular level of cardiac myocyte as well as the nodes, the tissue where the electrical the stimulation are percolating. So this one of the agent is an neprilysin inhibitor. I'll come few slides on this drug. Levosimendan, as sir already discussed, can be used in low cardiac output state, post-op state, and in refractory acute heart failure, which is refractory to catecholamines, milinones. We can use levosimendan, which is a calcium sensitizer. Not only helps in contractility, also helps in relaxation of the heart. Other drugs like SGLT inhibitor, which actually is a drug for diabetes. In adult, but still is new evidences are coming that it can be used in pediatric heart failure also, like dapagliflozin. And ivabradine, which helps in repolarization, that funny current, it alters the flow of funny current in cardiac myocyte. So these are the few agents, and the researchers are ongoing on mainly in adult patients. Also few they are including adolescent patients like serelaxin, omecamtiv. These drugs are still not in picture, and the endothelin receptor antagonist we know can be used in pulmonary hypertension. So what is this neprilysin? This is a neutral endopeptidase, which helps in degradation of natriuretic peptides like bradykinin, adrenomedulin. This natriuretic peptidase in normal physiology helps in diuresis, prevents fluid overload. And if you see this natriuretic peptide system helps in diuresis, reducing in blood pressure, and the inhibitor of this is a endopeptidase. What this endopeptidase does, they breaks up this natriuretic peptides. By inhibiting this endopeptidase, we can help in prevention of vasoconstriction, the prevention of sodium retention, and also remodeling. So these drugs came as mainly in adults. This is a combination drug of AC angiotensin receptor blocker valsartan along with sacubitril. So the first study published in NEJM, and they showed the benefit over AC inhibitor alone. So large RCT, enalapril versus angiotensin neprilysin inhibitor. And it showed that the composite outcome within 27th month, they found significant reduction of cardiovascular death and relative risk of mortality. Then the significant panorama heart failure study, where they sequentially updated the dose, and in 3 phases, they first checked the optimization of pharmacokinetics and pharmacodynamics, subsequently the safety of these drugs in pediatric age group. They classify this in 3 groups: 6 to less than 18 years, 1 to less than 6 years, and in smaller children. So at almost 1 year of study, they found that significant efficacy and safety. So FDA gave approval of these drugs, and after this panorama study and paradigm HF trial. And sacubitril valsartan is available as oral tablets. Those syrups are not available for pediatric use, so we have to keep small sachet and we have to give the drug like that. Ivabradine, it's a study published in 2017. It also has significant improvement over placebo. So as a rescue therapy, it can be used. The only issue is the cost of these 2 agents. Though sacubitril valsartan is almost 10, cost of 10 tablets is approximately something 600 to 700. Ivabradine comparatively is cheaper to that. So as we discussed that, we have to initiate the therapy in stepwise manner. We have to start with AC inhibitor. If it's not improving, we'll add on beta blocker, subsequently aldosterone antagonist, and in between, we have to optimize fluid overload and to features back congestion. And if refractory to this therapy, we have to consider either inotrope therapy as an intermittent dose, continuous infusion, and if refractory to all medical therapy, we have to take help of our cardio colleague or cardiovascular surgeons for mechanical therapy. In acute heart failure, we have to consider mainly on perfusion. So that model, what we already discussed, has to be rethink again. We have to keep the patient warm and dry. So if there is a features of cardiogenic shock or poor perfusion, we have to titrate inotropes like dopamine or dobutamine, and also in adrenaline. Phosphodiesterase inhibitor like milrinone not only helps in improving the contractility, but also helps in reduction of afterload, because these drugs are inodilators. But again, the problem in acute care setting, these are milrinone is a long-acting agent. It is difficult to use in renal failure patient because it can cause precipitous hypotension. In acutely ill heart failure patient, if at all, if you are using, you have to be considered that after optimization of blood pressure and as a continuous infusion, not any, better to avoid any bolus dose. Levosimendan already discussed, calcium sensitizer helps in inodilator. This important property of this levosimendan, it also helps in relaxation of the heart. So role is mainly in low output state in post cardiac surgery patient. Vasodilators like nitroglycerin or nitroprusides has a role especially in rheumatic heart failure patients, because many times they are regurgitant lesion not improving by only AC inhibitor alone. These patients, if you reduce the afterload, the chances of recovery is at least for some time is there in regurgitant lesions. Other non-pharmacological options, Obviously, structural disease, if they are like correction of any defects, valvular defects or structural defects. Some mechanical devices are there. For that, you have to refer to the patient to the higher center, and in refractory patients, obviously extracorporeal therapy. These are few agents commonly used to pump like Berlin Heart, HeartMate, or XCOR. These are only used in stage class 3 or class 4 heart failure, which is not improving despite continuous IV inotrope therapy. These are also as a bridge to transplantation. Suppose patient is waiting for transplantation, you can use transiently till we get a donor heart. And any patient with associated, again, organ dysfunction, we have to use this. This can be short-term use and long-term supports. If short-term mechanical supports are not improving, or sometimes we can give directly to long-term supports. Commonly used agents depending upon the body surface area and body weight, like PDMAG, Centimag, or Berlin Heart. So what we have in future directions? We know that the causes are heterogeneous, and sometimes 2 or 3 causes can be overlapping in single patient. And overall, the incidence is not that very high like in adult. So we need pooled data for different centers and specific trials for pediatric age group, for not only for the drugs, also for the devices. So in Western world, they are networking in different, not only different states or cities, they are in different countries, they are collaborating, so that the data are there, pooled data are there. Hope in future that we also establish this kind of thing. Already they are there, network trials are going on. And so this will help not only in getting the information of new agents, also will help in trials, because if we see, the evidence came for mainly for adult and adult data and extrapolated to pediatric studies, because the number are less in one center. You may not get the optimum number of patients to give the adequate power of a study. So collaborating studies will be the future. And as government of West Bengal is helping the congenital heart disease patient surgeries, so most likely we may get government funds also for collaborating studies. So in brief, management of pediatric heart failure is a complex thing, and we need better understanding of pathophysiology and stage of the disease is important. Optimum dose, drug interactions, and associated comorbidities has to be considered when we are choosing the therapies. Nutrition, immunization, and growth, prevention of anemia. These are the role of a core pediatric persons when they are day to day they are seeing these patients with their specialist colleagues. Focused on timely management of underlying treatable causes like infection, nutrient deficiencies, sepsis. Treating the sepsis is key. Referral at prompt period, like the optimum time, we have to choose the referral center when the disease is refractory to medical therapy for either extracorporeal therapy or devices. We have to optimize the referral. And at the end that every speaker has discussed that it is a multidisciplinary team approach. So a collaborative team approach is the key of success. So thank you again for the organizer, and thank you all the audience for patient hearing. Special thanks to Dr. Samajit, who helped like newer drugs. He's a pediatric cardiologist in NRS, working in NRS and also other medical colleges, to help me with newer informations like drugs like dapagliflozin. He only told me that I read, but it was like they are using in AIMS New Delhi also, and now I think some trials are going on. Thank you for patience here.
Thank you, Dr. Bhomik. That was a wonderful presentation. Something as common as congestive cardiac failure, heart failure, which we come across very often in our childhood practice and in the ICU setup. I think the key word that you want to say is optimization. Optimization of fluid, looking after the preload, contractility, and the afterload. During our time, it was digoxin, which was one of the drugs which I think has almost gone out of vogue right now. But I think that's the key message about how to optimize the fluids and give the drug in the right time and the right dose. So any comments from the floor or any questions, please?
Hello.
For a very lucid talk.
Yeah. Thank you very much for this nice point. As an arrhythmia, like I purposefully kept arrhythmia because Somen sir will take the next class whole on arrhythmia. So yes, arrhythmia prevention, especially a simple thing like electrolyte imbalance, a hyperkalemia. These patients are on like ARBs or spironolactone. They are prone for arrhythmias. So already fatigued heart, any arrhythmia can worsen further. So ECG, yes, that sir will tell us the importance of ECG and how to interpret and to tackle the arrhythmias. Second is yes, after the though FDA they gave the approval for this sacubitril valsartan, they also said that the company is waiting for post-marketing like phase 4 trial as well as post-marketing surveillance before launching or promoting them for pediatric use. Though the approval given, even their company per se, like the drug is actually harnessed, the main drug, the molecule. So they per se says that they're still waiting to launch or promote for pediatric uses. They want data, they are post-marketing surveillance phase 4 level data, and from adult, like especially adolescent, they are focusing on adolescent data like side effects. So still they are though approval we got, but they are not very. But adult it is still they're rampantly they are using. I think one of my uncle is taking this drug.
Any further comments?
Yeah, Samajit.
So this is not directly related to this topic, but for any infant with heart failure, suppose you have found any infant with heart failure, first, as Sarah has told, that see the ECG. And two things which are very often missed is one is among structural heart diseases is coarctation of aorta and Al-Kappa. So please get echo done from a good echocardiography center and mention that we want to rule out Al-Kappa and coarctation. And you can rule out clinically also by seeing the lower limb pulses, as well as for Al-Kappa, you can rule out by seeing the ECG. But keep these two entities in mind, because very often when we are both working in All India Institute, we have seen many patients referred to JCM and ultimately they come out to be Al-Kappa or coarctation.
Yeah. That actually nicely discussed in previous session by Lopadi. The other two sessions were there in congenital heart disease. So ECG, importance of ECG, pulses, saturation was nicely they discussed. So thank you for that valid point.
Thank you, Dr. Bhomik. Once again, we can move on to the next speaker now.
Thank you, ma'am.
Thank you, Dr. Rohit Bhomik, sir. So now, now we are moving on to the next talk, which will be the last talk of this session. Let me introduce Dr. Soumen Meur, sir. He needs no introduction actually. Sir is the consultant pediatrician and intensivist in the Amri Mukundapur Hospital. Sir is also the director of the IAP Critical Care Fellowship Program of the Amri Mukund in the hospital that is running at the Amri Mukundapur. Sir is also an accredited teacher of IAP Intensive Care chapter. Sir will be talking arrhythmias from the general pediatrician's perspective. I'm requesting sir to come into the stage. Sir, just interrupting, sir. There was one talk I missed before your talk, but as I announced, so, sir, I'm requesting, I'm placing your talk after such talk.
Hello, good afternoon, everybody. Thank you, Manoj, for the very nice introduction. And I would like to thank PCSI for the invitation for this talk. First thing to declare, I'm an intensivist and not a cardiologist. Whatever I say about arrhythmia is like a blind person leading not so blind people. So I'm not going to talk about much about difficult arrhythmias or how we treat them. We'll leave it to the cardiologist. So we'll talk about how not to miss arrhythmia and their emergency management only. So first question, I would, this is more of a statement rather than a question. Are we pediatricians afraid of it? Very. Arrhythmia definitely scares us. Why? Non-familiarity would be the most prominent cause, I would think. We don't see arrhythmia that often. Arrhythmia, fortunately, is not that common in children, unless you're doing cardiac intensive care or post-cardiac surgery patients. Arrhythmia is relatively uncommon. And some of the arrhythmias are difficult to diagnose. Even looking at the ECG, even cardiologists sometimes have seen struggling to determine what the rhythm is. And arrhythmia has the potential to degenerate into a more serious rhythm or going to cardiac arrest over a relatively short period of time. So we are rightly afraid of it. I'm afraid of arrhythmias, but I'm probably even more afraid of missing arrhythmia. So I work in intensive care. All the patients are on monitor. And if there is an arrhythmia going on and I don't recognize it, that's a worry for me. Or a child coming to emergency or coming to outpatient clinic even with symptoms suggestive of episodic dangerous arrhythmia. If we don't recognize that, that can be a problem. And as our cardiologist colleagues were mentioning, pediatricians are not great in getting an ECG done. There are practical difficulties. And sometimes ECG may have the answer. So missing it is probably a bigger concern for me because we do sometimes miss it. So what is arrhythmia? It's an abnormality of heart rate or rhythm or both. And it needs to be confirmed by an ECG. And when we when we say ECG, we mean a 12-lead ECG, not a rhythm strip. If you look at broad classification of arrhythmias, so where the rate is higher than contextual, I use the word contextual rather than normal, because the heart rate in children varies not only dependent on their age, but also dependent on what they're doing. So 1-year-old crying at the top of his lungs can have a heart rate of 220. That would be absolutely normal. But if he has a heart rate of 180 when comfortably sleeping, that's not normal. So you need to look at the context and the age. So rate higher than contextual, most commonly we see sinus tachycardia. Some people will argue that's not an arrhythmia, that's a physiological response. Supraventricular tachycardia, junctional tachycardia, ventricular tachycardia. The rate is lower than contextual, where we see sinus bradycardia, which again can be physiological, sinus node dysfunction, junctional nodal rhythm, heart block with slow escape rhythm. And there are some arrhythmia where the overall rate is acceptable or within the normal range for that context. Like sinus arrhythmia, ectopic atrial rhythm, junctional nodal rhythm can have normal rate, supraventricular ectropic and ventricular premature contractions. But let's not focus that much on this classification for the time being. Let's think about how will the children present, because children will not come with a monitor or ECG tracing. So they'll come with some symptoms. The problem with arrhythmia, like with a lot of other things, especially in young infants, their presentation is often very vague, and presentation also changes with age. So you need to have a high degree of suspicion to think about arrhythmia and need to investigate from that point of view. So what do infants present with or can present with a serious arrhythmia? They can just have excessive cry, and that's the only thing they may have. Pure feeding, cold extremities, excessive sweating. They can have respiratory distress with tachypnea, recession, and grunting, all respiratory distress, and not because of lungs or bronchoconstriction. Low pulse volume, difficult to feel peripheral pulses. It's really difficult to feel pulses in a small infant who is moving around quite a lot. People who do it on a regular basis would all agree that that's not a easy thing to do. And going to the even worse end of the spectrum, difficult to feel central pulses, lethargic, mottle, pale, gray, blue, all these things. If they're on this end of the spectrum, difficult to feel central pulses, lethargic, mottle, pale, gray, blue, this sort of end, then life can be a bit simpler from pediatrician's perspective, because we are all aware of this pediatric assessment triangular pad. So if you look at their appearance, if you look at the circulation of the skin, that should immediately warn us this child is critically unwell, and then somehow it becomes easy because you just follow the PALS protocol, ask for help, assess ABCDE, correct life-threatening abnormalities as soon as they're detected. But when they're not quite that unwell, but having all these symptoms, then we need to think about rhythm abnormality. So try to check and count pulse. If that is difficult, listen to heart sound and count how much that is. Check for liver size. That again can be difficult if the child is moving too much. Check for basal crepitations. Both tachyarrhythmias and bradyarrhythmias can present like this. If in doubt, try to get an ECG done, a 12-lead ECG done, or send to a hospital emergency department for further evaluation. Young children with arrhythmia can again present with just irritability, refusal to feed, vomiting, cold extremities, excessive sweating, respiratory distress with tachypnea, recession, grunting, low pulse volume, difficult to feel peripheral pulses, difficult to feel central pulses, lethargic, mottle, pale, gray, blue, all these things. Assessment, again, identify any sign of critical illness, and if there is any sign that the child is critically unwell, follow the PALS guideline and resuscitate first. Then try to check and count pulse. Older children is slightly easier. Listen to the heart sounds, check for liver size, check for basal crepitations. Both tachy and bradyarrhythmia can present like this. And if in doubt, get an urgent ECG done and sent to hospital emergency. Older children can have symptoms more akin to adults. They can complain of palpitation, chest discomfort, breathlessness, excessive tiredness, excessive sweating, abdominal pain, lightheadedness, chest pain or breathlessness on exertion. This is a warning sign, or history of loss of consciousness. Assessment, again, identify any sign of critical illness and follow PALS guideline if the child is critically unwell. Check and count pulse, check blood pressure if possible, listen to the heart sounds, check for liver size, check for basal crepitations, and if in doubt, get urgent ECG done and send to hospital emergency. So what are the common tachyarrhythmias we see in children? Lots of names: atrioventricular re-entry tachycardia, AVRT, AV nodal re-entry tachycardia, AVNRT, ectopic atrial tachycardia, multifocal atrial tachycardia, junctional ectopic tachycardia, atrial flutter, and atrial fibrillation. And ventricular tachycardia would be either monomorphic VT, polymorphic VT, or torsade. The point is, though children can have all these arrhythmia, the most common one in children is atrioventricular re-entry tachycardia, or AVRT. And that's a good thing. We are fortunate that children have this arrhythmia as the most common tachyarrhythmia, because it has got some distinguishing features, and most of the time it can be identified and separated from sinus arrhythmia or other causes of tachyarrhythmia. The two age peaks in the first 3 months of life, and then again between 10 and 12 years. Generally speaking, in the first 3 months, the rate will be more than 220, but we have all seen children in the first 3 months who will have a sinus tachycardia with rate more than 220. So just a rate of more than 220 is not helpful. And in older children, the rate of 180 or above is considered abnormal, but they can have SVT with AVRT with lower rate as well. We all know the rate is fixed and the RR interval is the same. It's very regular and the rate doesn't change. T wave may or may not be visible. and sometimes it can be after the QRS complex as well. It is usually narrow complex tachycardia, but it can be wide complex tachycardia as well. Young infants do not tolerate this very well. So young infants having an AVRT SVT for 6 hours can be in shock. We're going to skip the mechanism bit. So we'll run out of time otherwise. So how do we differentiate between the sinus tachycardia? Because sinus tachycardia, especially in young infants, they often have sinus tachycardia with a very high rate. And they, especially if they're crying, it may be very difficult to differentiate. So rate, we said, not helpful. Regularity is not really helpful. If somebody has got a rate above 220 or thereabout, it's very difficult to decide whether it's absolutely regular or not. Even sinus tachycardia would be very regular. P wave, as we discussed, SVT can have P wave as well, so that's not really helpful. But the fixed rate is invariably helpful because no sinus tachycardia or ectopic atrial tachycardia will have a fixed rate. The rate moves at least 7, 8 bits per minute, 10 bits per minute, it will move. But the AVRT can't have a moving heart rate, physically impossible thing for it to happen. So AVRT will have a completely fixed rate. If it's 223, it will be 223. It suddenly goes to 223, and when it terminates, it will be terminated to normal rhythm with normal rate. It doesn't slowly come down. Okay. Febrile children, this is another conundrum we often face. Child who has got a fever can have a sinus tachycardia, and we know infection and fever can be a precipitant for SVT as well, especially AVRT, AVNRT, or it. So how much of this tachycardia can be contributed to fever? 4-year-old child with a fever of 101 having a heart rate of 190. Can you contribute that to the fever? Can't really. So generally speaking, we should add 10 bits per minute for every degree centigrade rise in temperature. So 1.8 degree Fahrenheit rise in temperature will correspond to roughly about 10 bits per minute increase in heart rate. So need to put that in context. So fever and tachycardia does not necessarily mean tachycardia because of fever only. This is an ECG of a 10-year-old child who is complaining of palpitation, and he has got a fixed heart rate, and the ECG is this. No price for guessing, so rate is about 175 or thereabout. And the diagnosis is a SVT, and you can see the retrograde P wave. I don't know if you can see it very well. You can see a P wave just after the QRS complex, this one. And I'll show you the pointer. So just after the QRS complex finishes, there is a downward deflection, which is the P wave. So this is an SVT with retrograde P. I'm not going into the mechanics of that. So treatment we all know. I'm just going to briefly summarize. Vagal maneuvers, is it worth doing? Don't know. Often it doesn't work. But I think it's worth doing, because when you diagnose a child with SVT, it will take some time for you to get things ready. You need to get a cannula, you need to get your adenosine ready and things like that. And there's no harm in trying for vagal maneuvers in that time it takes for you to get ready for the medicines or whatever you are going to give. If it works, it's great. If it doesn't work, no harm done. Adenosine is the drug we need to give. If in heart failure, we need to think about this with cardioversion, 0.5 joules. We need to start with 0.5 joule. We can go up to 2 joules per kg. But it will take some time to arrange for DC cardioversion. So if you have got adenosine handy and the child is in heart failure, do give it. If the child converts to sinus rhythm, heart failure will improve. If we can't get sustained sinus rhythm, we can do all sorts of things. Amiodarone, beta blocker, verapamil, maybe digoxin, not really. Radio frequency ablation, but that's for our cardiology colleagues to guide us with. So we will stick to adenosine and DC cardioversion. Adenosine dose is 100 to 400 mics per kg. It has got very short duration of action and rapid bolus needs to be given in the upper arm. So we all know adenosine, no point giving adenosine in the foot, in the long saphenous vein even, because you'll have a sluggish circulation because of the arrhythmia, and giving a drug that far away from the heart is not going to work. By the time it reaches heart, its half-life is gone. So you wouldn't get any adenosine in the heart. Preferably in the antecubital vein, and you give it as a 2-syringe technique through a 3-way as shown in the picture. So you give the adenosine quickly, followed by the flush, a big flush, a 10 ml flush through a 3-way connector. And this is typically what it looks like. SVT, you give the adenosine, there is a big AV block, big pause. So there are some ventricular ectopics, and then you go on to sinus rhythm. If you're doing synchronized DC cardioversion, thing to remember for SVT, thing to remember, it needs to be synchronized. Okay, it must be synchronized. Synchronized is a soft button in most defibrillators, so it sits between number 1 and number 2. You need to manually select it. And if you have selected it right and the machine is reading the ECG right, you will get this little dots above the QRS complexes. That means the machine is recognizing the QRS complexes and will deliver the shock at the right moment. Otherwise, we can transform an SVT into a VT. Do you do sedation for cardioversion? I think you should. This is painful. And right pad placement can be difficult if the child is moving, unless you are using hands-free pad. So I think the child should be sedated. But intubation is not needed unless clinically indicated for airway or breathing support, but to give some sedation. As our cardiologist colleagues were reminding us, try to get an ECG, 12-lead ECG before and after the cardioversion, if possible. If the child is too unstable, you can't do a 12-lead ECG before, then definitely do after cardioversion, and at least keep printout from the defibrillator before, during, and after adenosine. Otherwise, the cardiologist will find it difficult to know exactly what happened. If sustained sinus rhythm can't be achieved with adenosine or DC cardioversion, then ensure other things are at place, like ensure oxygenation, rule out significant pH abnormality, rule out significant acidosis, check electrolytes, and then discuss with pediatric cardiologists or EP specialists about how to move ahead. Ventricular tachycardia, they tend to be wide complex tachycardia. QRS duration for children is considered to be 90 milliseconds or more, not 120 as in adults. So monomorphic PT can be indistinguishable from SVT with aberrant conduction or bundle branch block, like we sometimes see in WPW syndrome. So they can look just quite complex tachycardia. Again, try to get an 12-lead ECG done unless it's very unstable, or if the child is pulseless, obviously no question of getting an ECG. So treatment depends on the hemodynamic status. If hemodynamic stable, consider adenosine first, just in case it's an SVT with aberrant conduction. Monitor rhythm if the complex tachycardia persists, give amiodarone or procainamide. If hemodynamics is unstable, dish cardioversion 1 to 2 joules per kg. If pulseless, forget about rhythm, start CPR first. Okay, first CPR and then do your cardioversion when everything is ready. And then obviously consult pediatric cardiologist. Polymorphic VT, more likely to degenerate into pulseless VT or VF. DC cardioversion with 2 joules per kg. Don't forget CPR if pulseless. So this is an example of a monomorphic VT, wide complex tachycardia, but all the complexes look exactly the same, more or less the same. So it's a monomorphic VT. And this is an example of polymorphic VT where the complexes are different looking. So this is a worse rhythm compared to monomorphic VT. And this is torset. So bits of ventricular tachycardia, then a sinus bit, and then again ventricular tachy, but the axis changes. This is torset. So it happens from QT prolongation. May quickly degenerate into VF. If with pulse, then give magnesium sulfate, 50 milligram per kg slow IV bolus, and then continuous infusion. You need to monitor the magnesium level. Also check for potassium try to maintain the potassium in the higher range, 4.5 to 5 millimole. If pulseless, CPR and DC cardioversion. If refractory, consider isoprenaline infusion to increase the heart rate, and obviously discuss with cardiologist. Ventricular premature complexes, very common. If we put children on monitor, we see lots of SVs and VPCs. And if they are frequent or multifocal, then we need to think about whether there is something else is going on, like if their oxygenation is okay, if their acid status is fine, if the electrolytes are normal, if there is any myocardial disease, or if you're giving any drugs that can be causing this. So this is a isolated PVC. These are ventricular bigeminy. So you get one sinus, one ventricular ectopic. Then this is ventricular trigeminy. You get two sinus bits and then a ventricular ectopic. These are couplets, two ventricular ectopics in succession. Triplets, three ventricular ectopics in succession. And this is polymorphic VPCs. So you can see two different types of VPCs here. Bradycardia. So you see sinus bradycardia, not so common, but you do see sinus dysfunction and heart blocks. The sinus bradycardia is a rate slower than acceptable for age, can be seen in athletic adolescents. And common causes would be vagal stimulation, hypothermia, hypoxia, myocardial ischemia, drugs, raised ICT. And the treatment is just treat the cause. Sinus node dysfunction, sinus node fails to function as the dominant pacemaker. So sinus node is not the fastest pacemaker anymore. And this will lead to a variety of arrhythmias, can produce just profound sinus bradycardia, can have a slow junctional escape rhythm, can have a slow ventricular escape rhythm, or ectopic atrial or nodal rhythm are also possible. This is an example of sinus node dysfunction. You can see first three bits, look at the lead two, the bottom one. First three bits has P, QRS, P, QRS, P, QRS, and then there is a long pause, there is no P, and there is a QRS complex, which looks similar to the earlier ones, but not preceded by a P. So it's likely to be a junctional ectopic. It's just come because there is no P wave from the sinus node. And then it looks like a P wave just after the QRS complex, but that's not conducted because the ventricle is refractory. It hasn't repolarized yet. And then you see three sinus bits and then a pause and the junctional ectopic. So sinus node is not firing regularly as it should. Mostly idiopathic. We sometimes see it post-operatively after Fontana or TAPVT repair. We can find it in myocarditis or pericarditis or in hypothyroid. One of the most common scenario we see it in, if we put children on monitor, is the recovery phase of dengue. Lots of children in recovery phase of dengue will have sinus node dysfunction with relatively slow heart rate. But no treatment is necessary if hemodynamics is stable. The hemodynamics is unstable or heart rate is too low, we can try atropine or isoprenaline. If possible, we need to treat the cause. Very rarely we need to pace these children. Atrioventricular block, I'm not going to concentrate too much on that. We know first degree, second degree, third degree. Complete heart block. One thing to say, congenital complete heart blocks are these days often antenatally detected. If they're antenatally detected, most cardiologists or obstetricians will suggest delivery in a pediatric cardiac or cardiac surgical center because they sometimes need early intervention. Acquired cardiac complete heart blocks are mostly seen after post-cardiac surgery scenario, and we are seeing some children with MISC presenting with complete heart block as well, needing pacing even. This is one of our children who didn't have complete heart block at a very slow rhythm and needed to be paced externally through a external pacemaker. Quickly talk about palpitation, syncope, and chest pain. We see a significant number of children, pediatricians see a significant number of children coming, complaining of palpitation, has a syncope or something of that sort, or chest pain. And most of the time they are possibly benign. Before the exam, broke up with boyfriend, girlfriend, whatever. But some of these children may have some serious underlying pathology. So some of these children will need to be selectively investigated and referred to cardiologists for full evaluation. So what are the warning signs if these children present to us in OPD? So if the palpitation is abrupt in onset and cessation is also abrupt, it's likely to be an arrhythmia. Okay, so palpitation because of anxiety or exercise tend to come on slowly and then settle down over a period of time. Arrhythmia will cause sudden onset and sudden cessation. Palpitation associated with breathlessness or chest pain or discomfort is concerning. Loss of consciousness without warning or aura. So, somebody standing in the sun for quite some time was feeling a bit dizzy, lightheaded, and then fell down, likely to be a vasovagal, but there was no warning, no aura. The child suddenly fell on the ground. It's likely to be or can be an abnormal rhythm related problem. Loss of consciousness during exercise is extremely, extremely concerning. So anybody become unconscious while in a football match is extremely concerning. That needs to be investigated. Convulsion without any post-ictal state. So we know convulsion, usually children after having the seizure tend to be a bit sleepy. But if the child went into a stiff posture and then suddenly fine again without any post-ictal state, we need to think about rhythm abnormality. If you find any of these, refer to pediatric cardiologist or kidney specialist. Long QT syndrome, this one you can see visually looking at the T wave, looks like it's going on for eternity, almost touching the T wave. One of the things that I would say, we use two medicines quite a lot in children. One is azithromycin, another one is ondansetron. Both of these drugs can cause long QT and can cause dangerous long QT. So if you're prescribing azithromycin and ondansetron, which we do on a 4 times a day basis, be careful. It can cause QT prolongation. So think of arrhythmia if the pulse is too fast, too slow, irregular, or there is hemodynamic compromise. If the abnormal rhythm is suspected or detected, assess hemodynamic stability. If unstable, follow pulse protocol. If hemodynamics stable or acceptable, 12-lead ECG, try to analyze the rhythm, consult with pediatric cardiologist. If history suggests possible episodic arrhythmia, full systemic examination, 12-lead ECG, but ECG can be normal. Most of the long QT syndrome can have a normal resting ECG. Referral to pediatric cardiologist or EP specialist. This is the formula I use when looking at an ECG. So the first thing to ask is there is a clearly identifiable P wave. The P waves all appear similar looking and regular. Is the P wave upright in lead 2 and AVF? Are all the P waves followed by a QRS complex? Are all the QRS complexes preceded by a P wave? Are the PR intervals fixed and less than 200 millisecond? Are the QRS complexes less than 90 millisecond? Is the QRS rate, age, and context appropriate? Is the QT interval less than 450 millisecond? These are the questions we need to ask. If the answer is yes to any of these questions, then the child has got a rhythm abnormality. Thank you.
Thank you, Dr. Muir. That was an excellent presentation of a topic which we are not very familiar and not really confident, like you said initially. In fact, recently we had an MISC child who had gone into complete heart block and we had to go for a permanent pacemaker. Initially temporary and then went into a permanent pacemaker.
Yes.
So that it can be so dangerous.
Yes.
So, yes, any questions?
I don't like questions about arrhythmia from cardiologists.
No, it's just
sorry,
about
kidding.
the long QT.
Yeah.
You said that we know that it's a conventional teaching tells us that haloperidol and risperidone causes QTC prolongation. But for the last 4 or 5 years, I've followed up many patients with on haloperidol, on risperidone, or sometimes both. Surprisingly, I have not found single of them having long QT. Neither has the long QT segment like increased more than before. What's the literature? Any particular thing?
Literature is that risperidone is the long QT syndrome with risperidone is a post-marketing event, isn't it? Because it was reported after risperidone came into market, and there is a WHO yellow form. So if you come across any new side effect which is not standard, you need to report it. So a lot of people reported long QT with risperidone. So it's difficult to prove causal association because you're giving a medicine for a condition and something happens, is it inherent to the condition itself or the medicine you are giving? Absolutely impossible to know. But it came as a post-marketing adverse event identified. It wasn't there when risperidone was first introduced. I don't remember about haloperidol.
And also just a quick comment that
Yeah.
we are conventionally taught long QRS than VT, short small, narrow QRS as VT. But there are conditions, and they are not so rare also, that we can have a long QRS in a SBT, especially those antegrade retrograde pathways.
Yeah.
Rather, those antegrade pathways are more common than a VT in a child. And some specific kind of vesicular VT can have a narrow QRS complexes.
Absolutely.
So because it makes a major difference in the medications, I think we need to put that down as a, even in the PALS guidelines, I think we should put that down as a, the footnote or something like that.
No, PALS guideline has changed now. So PALS guideline says even if it's a wide complex tachycardia, try with adenosine if the child is hemodynamically stable. Because of this thing, AVRT is more common than AVNRT, and some of them will have a wide complex tachycardia, as you described. Yeah, it's worth trying adenosine if you have got time. That's fine. If it's a wide complex tachycardia because of SVT with antegrade aberrant conduction, it will be terminated.
Yes.
Yeah, sure. Well, any medicine can cause sudden death, but so when you are giving adenosine, I'm presuming you are giving in a healthcare setting. So it can cause cardiac arrest, but you can resuscitate, can't you? If the child goes into a cardiac arrest because of adenosine, you go on to do a CPR. Child should not die. Cardiac arrest can happen, but the child should not die. It can, especially post-cardiac surgery patient for SVT. I have seen 2 patients after adenosine, no ventricular complexes came, so needed to resuscitate them. Yeah, it is possible.
Thank you, Dr. Muir. I think the next presenter is already here. So yeah, can we move on to the next presentation? Thank you.
Thank you, sir, for a nice presentation. So now moving to the next talk on this session, the last talk of this session, Dr. Ravindra Pawar, sir. He came from is the senior consultant pediatrician and pediatric cardiologist from Kolhapur. Thank you, sir, for giving your valuable time and coming to the Kolhapur to us. We are eager to hear you. Sir will be talking about the functional echocardiography of in the newborn. What the basic conceptualization and utility at the bedside that all pediatricians. Requesting sir to come onto the stage.
Good afternoon, everyone. At the outset, thank you, PCSI, for giving this chance to present this topic. And I would like to congratulate all the previous speakers of this session. They had excellent talk on non-structural heart disease or congenital, cardiac diseases rather than cardiac defects. And my talk, I think, is a little misfit into this, but then still, I won't take much of your time. The topic is functional echocardiography in the newborn, conceptualization and utilization at the bedside. Though it sounds scary, I would try to finish it in few minutes. So this is the outline. What exactly is functional echocardiogram or functional neonatal echocardiogram? There are various names: targeted neonatal echocardiogram, point of care cardiac ultrasound, and focused cardiac ultrasounds. Is it something like boys with new toys? Is your functional neonatal echocardiogram same as mine? Or what are the guidelines for functional echocardiogram in the newborn? And then we'll go for the practical utilization with a few case scenarios. Now, since the time given is just 15 minutes, I assume that there is a little bit fair idea of echo views in the audience. So what is a functional echo in a newborn? It's an echocardiogram performed and interpreted by the neonatologist with the intent of either answering a focused clinical question or achieving a specific procedural goal. It provides anatomical and or physiological information to be integrated with clinical and lab data and make a timely and accurate decision possible. So it is completely different than a complete diagnostic study done by a specialist. So the characteristics are, it should have a well-defined purpose linked to improving the care of patients. It should be focused and goal-directed, not that you just keep on doing an echo and you don't know what you're trying to find from that. The findings, which should be easily recognizable and should be easily learned also, so that every neonatologist can be able to do it. Second thing, it should be quickly performed so that the actions can be taken quickly, and it should be possible to be done at the patient's bedside, not that a neonate on ventilator you take to the ultrasound room and then you do it. That doesn't count to be a functional neonatal echocardiogram. So this, coupled with the clinical examination and monitoring techniques, this can provide real-time, rapid and reliable diagnostic answers that are invaluable in patient care. So here it's a dynamic role of the neonatologist. He's the one who performs and interprets the study. He rapidly integrates this information with the current clinical setting and then repeats the study to identify changes associated with the intervention. So it's not just identifying it, but then you have to take action on it and then see what has happened after the action and whether whatever your goal was, has it been achieved or not. So the prerequisites, I say it's whether it's a boys with new toys. Boys here doesn't mean boys only. It's a gender neutral neonatologist term. Boy and toy, yes, both are important as much as is the boy's house and the guests in it. The boy, the neonatologist, or the person who performs the neonatal echocardiogram, he should have a fair knowledge of cardiac anatomy, physiology, both natural and modified, sound ultrasound training, practice of it, and also validated or certified training in it. Toy here means the good ultrasound machine with all necessary probes and software. House, everyone would agree that an echocardiogram in a single setup versus a level 2 or 3 ICU setup is more required in a level 2 or level 3 ICU setup, where after whatever you find on the echo, you should have adequate monitoring and treatment facilities available. And guest is the neonate itself or the patient itself. The training requirements have been quite standardized both by the American Heart Association or American Cardiology Association, as well as the Association of European Pediatric Cardiologists. And there have been separate guidelines by neonatological societies world over. Depending upon you're doing a core or a basic training level to advanced to expert and then accredited level, there are various training programs into it. As far as I know, still in India, there have not been any programs or this accredited programs, though there have been training programs varying from 1 day to 10 days to 2 months, but then nothing of this sorts is there still. The toy is the echo machine. We have them in all shapes and sizes, but moreover, it's generally not possible for a general neonatology ICU to take an isolated cardiac echocardiography machine. What we have is generally dedicated radiology echo combined package kind of machines, where you can do both the neurosonogram, abdominal sonogram, as well as the cardiac ultrasound. So there are many vendors. You have to find which fits best to an ICU, and whatever the machines are, be sure that they are portable or readily available at the bedside. And they should have separate neonatal probes. The probe for a 700 gram or a 1000 grammer would be different from somewhere for a 2.5 kg or a 3 kg child. So that needs to be taken care. And then they should have dedicated cardiac softwares also. The toy is the patient of the toy. You need to know how to see the views. There are many views. I would not go into details of this. And then there are various modes also, M mode or a motion mode, Doppler. What I'm trying to tell you in this thing is that make sure that your machine has these softwares, because ultimately these things, when you do start doing eco, will make your life easier. The house is, this is what I mean by a second or level 2 or level 3 NICU. But then yes, any person who practices neonatology and has adequate monitoring facilities and can have an echo machine can do a functional echocardiogram. The guest, few lines about the patient himself. They are delicate beings. Sometimes they're ELBW, extremely low birth, very low birth weight, maybe on ventilator, hemodynamically stable or unstable, on phototherapy, multiple infusions. So what has to be taken care is of the comfort of the neonate. Your echocardiogram should not destabilize the neonate. As well as that, at the same time, be sure that you, as a neonatologist performing, he knows what I mean by asepsis. And one more thing which is important is that many neonates which are preterms, less than 1,000 grams or around 1,000 grams, you may think that you put a probe and you might see the visual, image of the heart, but then they might, if they are on the ventilators, can have difficult windows also. So you have to maneuver your ways and find out the heart and complete the echocardiogram. The functional echo, how standardized it is. I doing the functional echo may not be the same as you doing the functional echo, or somebody else says that no, this is the functional echo. Are there any standard guidelines for it? Yes, there are. The most recent one which I came across was the international evidence-based guidelines on point of care ultrasound. It's just the other name for the same thing for critically ill neonates and children, and in both pediatric and neonatal NICU. What they have done is evidence-based guidelines have been prepared for use of focus in neonates and children. And the panelists have agreed on 39 out of 41 recommendations. Though it is said so, but then the quality of evidence in 28 out of 39 is moderate quality. So it still needs more standardization. And this is the list of things which from cardiac point of view, they have added in the list of functional echocardiography, or the things which can be seen or done by a non-pediatric cardiologist or a cardiologist person also. So there are 1 to 11 points, of which only one is of A quality evidence, and that it should not be used as a screening tool for diagnosing congenital heart defects. I think this doesn't need an overemphasis, because we all know our purpose is not diagnosing congenital heart or screening for congenital heart. We have some other goals while doing a functional echocardiogram. Then we can assess the cardiac filling, the fluid responsiveness, cardiac function, qualitative, quantitative. The major 3 places where it is useful is assessment of PA pressures, presence or absence of a PDA, and assessing its hemodynamic significance, and assessing the cardiac function. Yes, and after that, things like pericardiocentesis or pericardial effusion is also one thing which we can, where we can use. And then many of the specialists have disagreed on the point number 11, that you can use it to detect the vegetation or exclude the diagnosis of bacterial endocarditis, but it requires, it's a different topic in itself. So as of now, it's not included in the functional echocardiogram. So again, to reemphasize the same thing, in a newborn with compromised circulation, it is paramount to rule out congenital heart disease. Even if a slightest possibility of congenital heart disease is there, the echocardiogram, a formal echocardiogram, should be performed by a pediatric cardiologist. Now, quickly, we'll go through a few case scenarios, regular case scenarios for all neonatologists. A full term born by emergency LSCS, thick MSL, did not cry immediately after birth. You intubated him. Somehow stabilized hemodynamically, but after 1 hour, 2 hours, also the oxygen saturations remain in the range of 80 to 85%. So you have called the cardiologist is at least 5 hours away from you, or might take that much time to come. So in the meantime, you do an echo. I would give you that thing that, yeah, you are good at echo and you can do a quite, get quite nice apical 4-chamber view. And what you see here is the right side. These are the 4 chambers of the heart. I don't know if you can see the monitor, this pointer. So this is the left side, this is the right side. And okay. So you could get the other views also. Here, what you are seeing is the left atrium and the right left atrium and the right atrium, and the interatrial septum in between. It has a small hole that is the patent foramen ovale. And the patent foramen ovale is shunting right to left. That is the blood from the right side is shunting to the left side. And that is the reason for his desaturation. Not only that, if you see the cross section, the right side is dilated. The function looks here okay. So you know here that we are heading towards persistent pulmonary hypertension. So the immediately whatever things are needed from treatment point of view, we can start without waiting for the cardiologist to come. So this definitely improves patient management. Now, if you go by the guidelines, there are these many things which need to be seen or which can be seen for in a case of PPHN, or to rule out PPHN, or to assess the severity of PPHN. But from our point of view, for a basic neonatologist who has some basic training about echocardiography, you can do a PA pressure guesstimation. I call it not estimation per se. You can guess it by the position of the interventricular septum. Now here, if you can see, make out the LV. This is in cross section. It's a round circular thing. The septum is pretty much moving with the left ventricle. But when you see in this view, in severe PAH, you can see the right ventricle is dilated and the septum is flattening out. So just one view, you can make out that the RV pressure is high and RV is dilated and the septum is moving towards the left side. So depending upon that, just the configuration of the LV, if it's a O-shaped LV, the 50% of the LV pressure is less than the 50% of the right ventricular pressure. If the LV becomes D-shaped, or if the LV becomes crescent shaped, the possibility of RV pressure being high is 50 to 100% and more than 100%. So standard method by which everyone does measurement of the PA pressures is by tricuspid jet. These are the views here. What you see here is the right ventricle which is dilated. That blue jet which is flowing into the right atrium is the tricuspid jet. With new machines, what they have some formulas and software which can, with the help of Doppler, you can accurately measure or nearby measure the amount of pressure which is there in the right ventricle. So this is how the trace comes with a Doppler. And what you see here is you just have to put the point here and you get a reading here. There are formulas to it, but then your machines make them very easier and you can easily make out the tricuspid regurgitation jet value. And that value comes in millimeters of mercury. You add the right atrial pressure and you get the pulmonary artery pressure, provided that there is no pulmonary stenosis. And depending upon how much is the PA pressure of the PA pressure value, and compare it with the systolic pressure value, your blood pressure. And depending upon that, if it is less than 1/3, 1/3 to 2/3, more than 2/3, or more than the systolic pressure, you can gauge the degree of pulmonary artery hypertension. So it has limitations. Generally, RAP you assume to be 3 to 5. You do not measure it, and the accuracy, it depends upon which angle you take. This angle which I am showing here is more important. It has to be within 20 degrees. But then once you know how to do it, you get to know that you get to align it with different views, and then you can get a value. Problem is sometimes there may not be tricuspid wall regurg also. In that cases, there are many other things also. If there is a shunt, like what we saw in the last echo, that the PFO was shunting right to left. Similarly, if there is a VSD or a PDA, depending on which side it is shunting, you can make out whether the right side pressure is more or the left side pressure is more. Then going to the next case scenario, again, extreme PT, 27 weeks, emergency LSCS, cried immediately, has RDS, is on surfactant, had received surfactant, then extubated. From day 4, again having tachycardia, tachypnea, mottling. Common scenario, you put to the probe and what you see is a big PDA, huge PDA. Now, PDA in preterms, neonates with him, the important considerations are that initial scan should be a comprehensive appraisal of cardiac anatomy. So you have to rule out that you are not dealing with a duct-dependent congenital or duct-dependent systemic or a pulmonary circulation. And inadvertently going and closing a PDA in that situation might be life-threatening. So there are many things which we can see in a PDA. Like once you put the probe, if you see the PDA, you can see the diameter, the flow direction, the velocity. And there are other parameters of pulmonary overcirculation which also can be seen. But then those are like not for core or basic purpose. We can, if you have additional training, we can easily make out those things also. So in color Doppler, depending upon the pattern which we see, if you get a pulsatile pattern or a restrictive pattern, This is on the color Doppler, and you put a Doppler on it, and then you get those trace. Left to right shunt with an arterial waveform. That means the systolic velocity is high, but the diastolic velocity is low. This is the classic restrictive pattern which we see in a little older children. This is a bidirectional pattern where the flow is both into the PA as well as during systole it goes into the from the aorta to the PA, but in diastole it again comes back. And then the last one is the complete right to left flow in which there is suprasystemic PA pressures. So this trace also can tell you the amount of pressure that is there. This slide I have purposefully kept just to know that we can measure the other parameters related to the hemodynamics of a PDA. This again is for advanced training. Once you know there is a PDA and you could measure the size and the cardiac dilatation, you can start treatment. Again, a big slide, but then for this cutoff values only I have kept this slide. These are the parameters which can be seen, and these are the values upon which we decide whether there is hemodynamically significant PDA or not. Now, there are limitations to this also. Many times imaging may not be possible. You may not be sufficiently possible, or it may be possible, but then you may not be sufficiently possible for interpretation of hemodynamics. Many times you may feel that you put the probe on the suprasternal area or the high parasternal area and you might see the PDA, but in a ventilated child or an operated child with a, say a drain or something, it's not possible to look the PDA at that point. Again, the awareness that echocardiographic indices of hemodynamic significance have variable reproducibility between observers. So me do
share to volunteer to come on the chair to chair this session, as we don't have other two chairperson because of some issues could not meet. So moving on to the next talk. The next will be about the echocardiography in children. So what the Dr. Devdatta Mukhopadhyay madam. Madam is professor as well as and one thing I must say, I learned intubation from madam in my during my training in my house. I have the intubation yet, madam. I will not forget that. So welcome, madam.
बना के घूम रही है तब से। अरे हो जाता है।
Dicho.
Hello. Hello. Ma'am, can you hear? Hello.
Yeah, now I can hear.
Okay. Thank you, ma'am, for joining us.
My slides are they visible?
Yes, ma'am. Yes, ma'am.
Audible?
Yes, ma'am. You're audible.
Okay. May I start?
Yeah.
Hello? Hello? Hello?
Yes, ma'am. Hello.
Very good afternoon, everybody. And thank you, PCSI 2022 and Dr. Amitabh for giving this opportunity to be speaker. I'm sorry, I'm not there physically and I have to do it online. So I'm going to speak on our experience about MISC, cardiac manifestations. There is no conflict of interest here. We all know these diagrams in 2022. The first half for 2022, 2020, there was all lockdown and the things. And with the second wave, especially when we all face a lot of number of MISC, and still we are seeing, though decrease in number, but still we are seeing. So starting with my case, it was in June 2021. It's a 1.5-year-old boy with history of fever for 3 days, redness, swollen eyelids, palm and sole edema with tenderness. These are the typical cases you all have seen as a pediatrician. The child was very irritable. It was so difficult to do echoes in these babies. There was history of COVID in the family 2 weeks ago. And his brother also had same symptoms, but of milder variety. The chest X-ray, there was lung infiltrates on the right side, quite significant. And this was the picture. Picture was taken with permission with the family. So there was palm, sole, edema, and eyes, puffiness, lips red. So all features are sort of typical of the Kawasaki thing. So in the initial stage, the many names were given to the disease. Most of the time, they are having relative bradycardia and ECG with a junction escape rhythm. So this is the sinus rhythm going on, that there is absent P wave. So basically sinus node dysfunction with junction escape rhythm. This was quite common rhythm in these patients, and we had any sort of arrhythmia, complete heart block, first degree AV block, long QTC, STT wave changes. So many type of ECG changes happened in these babies in our study. Echocardiography, this is 4-chamber view. There was severe left ventricular dysfunction, dilatation, and there was a thrombus. So a patient, this is very unusual site for a thrombus to be formed, but we could see thrombus in L appendage, thrombus in left ventricle, thrombus in the right side of heart or the pulmonary arteries. These were the things which saw in these patients. So this baby had a thrombus with LV dysfunction and the dilated coronary arteries. Obviously, these coronaries were very typical of Kawasaki. The clinical picture was fitting into Kawasaki picture. Blood investigations, platelets were high, CRP was very high, there was relative anemia. TLC, DLC was normal with high BNP and drop high. Albumin was low, and he was COVID IgG positive with the negative RT-PCR. With this background, this diagnosis of Kawasaki-like disease or Kawasaki or MISC and then PIMS. So these were the names from KD-like picture to MISC were happened during that time. The child was managed in ICU with low dose of dopamine. CPAP was required because he was having respiratory distress and it was acute left ventricular dysfunction. He was given IVIG, and because there was thrombus, he was started on oral anticoagulant after low molecular weight apparent, and later when the thrombus disappeared, he was continued on egosprin. On follow-up, 1-year follow-up is there. He's doing perfectly fine. There was no recurrence of symptoms and things, and all medication was stopped. Another case is a newborn. So with the LSCS was done for the fetal distress, loss of fetal movement, and there was thick mechanism aspiration, there was low FGAR, on lower side FGAR, and with respiratory distress, desaturation, chest X-ray, cardiomegaly, echocardiography evaluation was done, and you could see severely dilated right heart. There was tricuspid regurgitation, and all these, strictly heart was otherwise fine except PFO and the PDA. There was no outflow tract obstruction or the residual ventricoseptal or any large ventricoseptal defect. In short axis also you can see LV is just pinched and it is dominating right heart in this patient. And ductus arteriosus was, this is a small PDA which was shunting right to left, and that says the PA pressures are suprasystemic. So basically this is severe pulmonary arterial hypertension in a newborn, born with the fetal distress, emergency cesarean section, and thick mechanism aspiration. So everything fits into PPHN. With PPHN, you need supportive care from PPHN point of view, but because this scenario was going on, we had to think from the additional entity which was happening there is about the COVID inflammatory response. Cultures was negative, reducing platelet were there, because in PPHN, as such, you don't expect a high CRP or falling platelets. Then these additional things were there, we have to think for the another infection or inflammation thing going on. Coronaries were dilated, so TLC was high, platelet were borderline, CRP was very high, and it was very fast rising from day 1 to day 3, 4. It was from 10 to 116. So it was a very acute rise in the CRP in these patients. Mother was COVID positive, and with that background in mind, with the whatever was going on with cases being reported, so IVIG and methylprednisolone was added to the with the new entity MIS, and basically MIS, fetal MISC leading to neonatal manifestation. This was the scenario happened with these baby, and you can see the test X-ray. So first X-ray was huge cardiomegaly, and here with the response of with IVIG, 3 days after, CRP was 10, X-ray was almost normal, echo PA pressures was almost normal, PR was 22 on 3rd day of IVIG. So this dramatic response can happen only when something additional inflammations can't be explained by PPHN only. That doesn't go so fast. That take time. But inflammation, obviously, we suppress the inflammation by the anti-inflammatory drug, and child did very well, that newborn. So with that, the first, the case report, the first entity was reported in 2022. And in that, at that time, it was initially thought that children are immunologically less susceptible to COVID. So we sort of that it is disease of the adults. Kids are minimally asymptomatic. So it's sort of false thing was going on in our mind. Kids are comparatively either less susceptible or less symptomatic. But with this MISC, that was an alarming situation. Initial study shows 1% of the babies with COVID had MISC. And they said it was the older kids' involvement. And according to that study, it was basically myocarditis. You may have myocarditis with shock, with CHF, or just ventricular dysfunction with high BNP and NT-proBNP, or echo normal but high inflammatory marker. So all 3 manifestations, all 3 type of presentation could be there in these patients with multi-system involvement, with inflammatory syndrome with the COVID. Our experience of about 111 babies, and we compared the data with the recent publication in Circulation in 2021. So our data-wise, the cardiac involvement who was referred to us for me for echocardiography with the clinical, with the suspicion of MISC by the pediatrician. So there was symptomatic, the child was symptomatic, either bradycardia or infection or fever, all lab reports were, and all were COVID antibody positive, none was RT-PCR positive. So in all patients, they were suspected to have MISC, strong suspicion of MISC by the pediatrician, referring pediatrician. The cardiac involvement was almost always there, 95%. Cardiac dysfunction around 40%, which was entirely with the published literature. Coronary artery involvement, around 2/3 of patients were having coronary artery involvement. It was either dilatation or aneurysm or thickness of wall, brightness of wall. Many types of changes were there in these patients. Diastolic flow reversal, it is not reported in the literature, but in 17% of patients, it was with severe left ventricular dysfunction, low cardiac output, we see diastolic flow reversal. But comparatively normal left ventricular function, having diastolic flow reversal alarm us towards that some sort of vasculopathy, arteriopathy is going on these patients, and they are on follow-up with us. Pericardial effusion, almost 50% of patient. Mitral regurgitation, mild TR is quite common in general population, but MR more than mild is not a something benign thing. So we had almost 50% of patient had either mild or more than, none had severe, but mild moderate MR was there. Aortic regurgitation in around 1/5 of the patient, intracardiac thrombus in around 2% of patient, pulmonary hypertension, mainly newborns, were in 10%, and rhythm abnormality in 6%, which is reported in 6 to 25. So many things which were not reported, which noted in our study. And the correlation with the statistics showed that there was no significant association between duration of admission, duration of illness basically, age of patient, BMI, BSA, with coronary artery dilatation and dysfunction. So this was, anybody can have severe cardiac involvement. There were no association with the fever of 1 day or 10 days or 3 weeks. We had seen coronary involvement and ventricular dysfunction and thrombus formation. So we could not find any direct correlation with that. And thus there was no significant direct correlation with level of inflammatory marker in these patients. So inflammatory marker very high, we may see normal cardiac patient. Inflammatory marker mildly elevated, we did see significant cardiac involvement. So inflammatory marker and cardiac involvement plus type of presentation, clinical symptoms and cardiac involvement, there was no definitive correlation, but they all responded to anti-inflammatory medication. That is the important thing. So coronary artery dilatation was commonest being the left main, then LAD, then RCA, and least common involvement was the circumflex artery. So this picture is showing, this is right atrium, left atrium. This is big thrombus sitting in a right atrium in this patient. This was 1.5-year-old child with MISC, and cardiac response to the on follow-up. So initial coronary chamber dilatation, floor of ventricular dysfunction, everything was there, but on follow-up everything came down. This was 1 month follow-up post anti-inflammatory therapy. Cardiac MRI, the study is going on various centers about the long-term effect of MISC on cardiac. So cardiac MRI is being done. This is one of the patients who had MISC in neonatal period and now having the fibrotic changes into the myocardium. But in majority of patients, this permanent scarring is not seen in post-MISC patients. So that is a good finding. That says that it is sort of acute insult responded to anti-inflammatory and long-term, not in majority of patients, but in some patients. So a follow-up is important by echocardiography, by ECG, clinical, and then if you have a doubt, we need to ask for the further in this modality like the MRI. In our observation, the difference between MISC and Kawasaki disease is MISC we could see at any age, even 15, 14 years, starting from the newborn, or you may say fetal, we could see MISC. Kawasaki has its own defined age. Neonatal involvement, obviously not much known about the Kawasaki. Shock is more common here. Disproportionate clinical presentation. As told, the symptoms and the cardiac involvement, it's not, it was quite disproportionate about the symptoms and about the inflammatory marker. In Kawasaki, we see high inflammatory marker. The clinical picture most of the time explain our cardiac findings. Cardiac involvement is very common as in comparison to Kawasaki disease. LV dysfunction is more common, coronary involvement is higher, which we see in our study and in other published data. Intracardiac thrombus with normal EF also reported in MISC, which is not in Kawasaki disease. Rhythm abnormality is more common, prolonged QTC, AV block, any type of rhythm abnormality seen with MISC, not that with the Kawasaki disease. And diastolic flow reversal, there are few with shock and poor LV dysfunction with Kawasaki disease, but here with MISC, even with normal functioning heart, so-called, we could see diastolic flow reversal in aorta. That points towards a arteriopathy, and obviously we need a long-term follow-up to look what is happening. And this is our analysis about the MISN, about the COVID, post-COVID multi-system inflammatory disorder, where we could see, even in newborn, we could see cardiomegaly, PH, mitral regurgitation, aortic regurgitation, pericardial effusion, thrombus, so all sort of involvement also being reported in newborn. And the good thing, at the time of suspicion of the disease, the CRP was so high, and within 3 days, the response to IVIG in these patients was really beautiful. So that means early pickup of the patient and early treatment help these patients. In last, I would like to show the recent encounter with MISC. So this is older kid, 11-year-old child with history of fever for 3 weeks. It was high grade fever 100 to 102, and he was hospitalized somewhere, received antibiotic, IV antibiotic for 2 weeks. There was no response. TLC was within normal limit, platelet were lower side 80 to 1000. There were multiple reports. CRP was very high, 80 to 120. A walk-in patient with this CRP, I always keep a possibility of MISC. Cultures were negative. Other fever causes, malaria, dengue, typhoid, everything was done and it was negative. And the last thing was COVID antibody positive with negative RT-PCR. And he was also carrying a normal echo report from outside. Positive findings, except everything normal except mild pallor plus wide pulse pressure. So BP was 110/30, and my residents were very worried about his blood pressure. ECG, he was carrying the ECGs, and you could see it was 1:1 AV conduction, heart rate on slower side, child who is having a significant pyrexia. So PR interval was progressive from day 14, day 12, 160. Normal, we expected this age up to the 100, 110. So 160, 200, then 280. In the same day, 200 to 280 his PR interval. When we saw the child on 28th day, it was 280 with 1:1 AV conduction. Rest of the intervals were normal. And this was the echocardiography. Contractility was good. There was a small pericardial effusion and his coronaries were normal. There was no intracardiac thrombus, no vegetation, no other structural heart defects. So he was treated as MISC. It was in government setup. Finances were issued. We gave methylprednisolone high dose and started on ecosprin. 3 days post ecosprin, 2 days, the PR intervals of 140. So in today's scenario, all pyrexia of unknown origin we should keep MISC as a differential diagnosis. They can come in any form. This prolonging PR interval was a manifestation here, and when you do echo, you just find some pericardial effusion, which is very non-specific. But rhythm abnormality gave us an direction to think towards the MISC, and the response was really good. So take home message is cardiovascular involvement is nearly universal. We are seeing less patients now, less coronary involvement, but we are still seeing. So need to have a suspicion towards this in all patients with atypical presentations, not usual patients presentations. This could have myriad presentation, extreme age group, spares none, even fetal, newborn, or any age group are affected. And we are seeing 40, 50 year of age with sudden death, so many causes. So probably we are missing them. That multi-system inflammatory involvement was there in those also at some point of time. Need to have a multidisciplinary team. Long-term outcome is unknown, so long-term follow-up is needed. We have given IVG and IVIG and steroid. Some patients received both. Some patients received only IVIG, some received steroid. So had a learning curve. Now today, the choice is IVIG, but a big number of patients can't afford IVIG, so we go towards methylprednisolone, and the outcome is almost same in all patients. And this paper is under publication about our study on MISC. Probably this is underreported thing, and we have to have centralized data collection. All patients should be reported, and planning about the management and long-term follow-up is important. Telecardiology today, like ECG, can be done anywhere. Screening echo can be done anywhere, and if suspicion, specialized opinion should be taken all these patients to help to make them better, to have a very good outcome. The disease which respond as of now responding to the treatment what we are offering to them. Thank you.
Thank you, ma'am, for excellent presentation. I'm not sure if you can hear us. Can you hear us, ma'am, from the hall?
Thank you. Thank you for it.
I have one question.
Yeah.
There is a lot of choices about the methylprednisolone dose. It varies from 1 milligram per kg to 13 milligram per kg. What's your choice?
Audio is very unclear.
I'm sorry, I was asking about the methylprednisolone dose.
like when CRP is high, this symptomatic, highly symptomatic patient we gave in high dose, means 30 milligram per kg over 3 days, and the tapering dose. And we continued steroid, oral steroid for around 2 to 3 weeks. IVIG is 2 gram per kg as a standard we all give.
Thank you, ma'am.
And all patients, MISC, whether there is coronary involvement or not, the ecosprin was given for 3 months. If there is coronary involvement, it was continued depending on the cardiac findings on echocardiography.
Sure. But I have a question. What area was for severe IBS? You have 15 lines of IVA also.
Audio is very unclear on my side. I can't hear anything. Sorry.
The doctor is asking about a 15-year-old child, 60 kg, who was diagnosed to have MIS and was given IVIG and steroid as well. Yeah, but the child did not survive. So is there anything else, any other therapy we should consider? That's the question.
One is, what was our cardiac involvement? What was the cardiac finding? So like in Kawasaki disease, we had many options to as anti-inflammatory. So, and that depend on our response to the treatment. So first is IVIG, with MISC we go with IVIG steroid not responding. Other anti-inflammatory are there. But means why he died, that is important. Was it arrhythmia? Because VT can happen with anyone, and VT doesn't give us time until unless we are monitoring the things. Was it thrombus? Was it coronary event? So whether it was anti-inflammatory which did not respond to anti-inflammatory drug, or it is some acute cardiac event which is happening today, was unknowingly we are having so many patients. So coronary event, obviously one thing. So baseline echo ECG plus what happened that time is important. We need to have, like, to know the cause, we need to have what was going on with the child. Plus this is such a new disease. We are coming across any type of finding in these patients. So I think postmortem autopsy is very important if we have something explained which are not, which we are not doing. So many things which we don't know.
The child had severe LV dysfunction.
I'm sorry, I can't hear anything actually.
Coronary normal. Sorry, coronary is normal.
Can we type in chat box?
Function. Sorry, about the sound. The child with severe LV dysfunction. Sorry. Well, we call it a day, because the sound is causing so much problem. Thank you, ma'am. Thank you very much.
I'm sorry, thank you. I can't hear actually too much of. I'm sorry.
Sorry for the technical inconvenience. So the next topic is
So that's what I mean.
so our next topic is benefit of preterm PTA, the latest evidence by Dr. Operation Alan Choudhury. We welcome Stan on the stage. He is a consultant pediatrician and neurologist in the NICU of Narayan Hospital, Harvard. We will be listening from him with the management of preterm PTA. What are the latest evidence